Test one, two, check one. Test one, check one. Now test one. అదే మైక్రోసాఫ్ట్ అదే మైక్రోఫోన్ అదే చెక్ టెస్ట్ టెస్ట్ వన్ చెక్ చెక్ టెస్ట్ వన్ టూ చెక్ బయలుదేరు టెస్ట్ టూ కొంచెం అది లాగ్ ఉండిద్ది అన్న ఎట్లాగో టెస్ట్ చెక్ ల్యాప్
హలో 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 చెక్ హలో 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 ఇయర్ ఫోన్స్ పెట్టుకుని చూడమను లేకపోతే బాగా తక్కువ వస్తుందేమో తెలుస్తుంది అప్పుడు హలో 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 వస్తుందండి హలో హలో నేను పిలుస్తున్నాను చూడు ఆయన సోర్స్ అది వెళ్తుంది ఏంటో తీసుకోండి మైక్రోఫోన్ హలో హలో రావట్లేదండి
ఒకసారి మీరు మాట్లాడండి ఇందులో విన్నాం ఒకసారి అది
హలో
Good morning everyone and a very warm welcome to all our distinguished delegates, speakers and guests. I am Dr. Ramya and this is Dr. Madhurya. We are the MCs of this CMO. It's an honor to have you here today for this continuing medical education program focused on a topic that has truly revolutionized critical care, ECMO, extracorporeal membrane oxygenation. As the boundaries of life support continue to expand, ECMO
is at the forefront, challenging, demanding, and often life-saving. Today, CME brings together expertise, experience, and insights from across the field to help us deepen our understanding of ECMO and its real-world challenges.
We hope this day fosters learning, discussion, and perhaps even a shift in how we think about extracorporeal support in our own ICUs. With that, to formally begin the proceedings, I now invite Dr. Uttam Sharma Sir, Medical Superintendent, Manipal Hospitals, to deliver the welcome address.
Very good morning to one and all. I would welcome all the people gathered here to this CME. We take great pride in organizing this Pulmonology and Critical Care CME, Mastering ECMO, Insights from Manipal's leading experts, organized by Manipal Hospitals, Vijayawada. Manipal Hospitals now is one of the largest hospital group chains in the country. We have 39 hospitals across the country, having more than 10,500 beds, serving 19 cities, having 5,000 plus doctors and 18,000 plus employees. So that is the scale at which Manipal is operating now and still growing. Coming to this CME, it is the first milestone event in this region, in AP. For the first time, a dedicated CME for ECMO is being conducted. So we take pride in organizing this. And we are actually thankful for all the participants. We have got more than 300 plus registrations for this event today. This only shows how much interest there has been in regarding the ECMO and advanced critical care therapies in the region. At the outset, I would like to welcome our guest of honor, Dr. Chaudhary Bodepudi, Vice President, IMA. Hearty welcome to you, sir. We would also like to welcome Dr. B. Vidyasagar, who is the observer for the event from APMC, who have given us 2 credit hours for the program. A hearty welcome to you, sir. We also have a stellar lineup of speakers, moderators, and faculty. First, to start with, I would like to welcome Dr. Sunil Karant, Chairman and HOD, Critical Care, Manipal Hospital, Bangalore. A very warm welcome to you, sir. Dr. Devanand NS, HOD and Senior Consultant, Cardiovascular, Heart and Lung Transplant Surgery, Manipal Hospital, Old Airport Road, Bangalore. Warm welcome to you, sir. Dr. Srinivas Samvedam, President, ISCCM and Head Critical Care, Sindhu Hospitals. Sir will be joining us soon. I warmly welcome him in his absence. Dr. Karthik Hanuma Shetty, Consultant Cardiac Anesthetist, Sakra Hospital, Bangalore. Very warm welcome to you, sir. Dr. Dinesh, Consultant Critical Care, Manipal Hospital, Vijayawada. Very warm welcome to you, sir. Dr. Vinay K, Associate Consultant, Critical Care, Manipal Hospital, Bangalore. A very warm welcome to you, Dr. Vinay. Our sincere thanks and welcome to each one of the panelists who have agreed to grace this occasion and be part of the panelists. A very warm welcome to all the panelists. We also welcome all the workshop faculty and station leads who are going to have, we are going to have a very hands-on experience workshop in the second half of the session. So I welcome all the faculty and station leads to this program. I would also like to welcome all the delegates, the 300 plus registrations, doctors who have come forward and registered to be part of this learning experience. A warm welcome to everyone. Finally, a gratitude to Dr. Sudhaka Kantipudi, Cluster Director, Manipal Hospitals, Vijayawada, whose leadership and support was, because of whose leadership and support we were able to conduct this CME. And I also welcome all the press and media friends who are present here. Wish you all a very happy learning experience today, and thank you one and all.
Thank you, sir. Moving ahead, let's start with our talks. It is my honor and privilege to introduce a true leader in the field of critical care medicine, Dr. Sunil Karant, sir, MD, FNB, EDIC, FCICM. Dr. Sunil, sir, is the chairman of Critical Care Services at Manipal Health Enterprises Private Limited and the head of department and senior intensivist at Manipal Hospital, Bangalore. He serves as an adjunct professor of critical care medicine at Manipal University and holds several key positions, including chair of the Hospital Infection Control Committee, Code Blue Committee, and the Pharmacotherapeutic Committee. A respected academician, he is also a senior examiner and teacher for IDCCM and IFCCM as well as the National Board of Examinations. Sir has served as the former chairperson and treasurer of Bangalore chapter of the Indian Society of Critical Care Medicine and contributed immensely during the pandemic as a member of Karnataka State COVID Task Force and a critical care support team. His clinical excellence has been recognized with several prestigious awards, including the Namma Bengaluru Healthcare Professional of the Year 2021, the Didonic Golden Aim Awards for Critical Care, and for the Most Trusted Healthcare Provider 2023. His key areas of interest: neurocritical care, obstetric critical care, poisoning, ECMO, which makes his presence here today especially meaningful. Please join me in welcoming Dr. Sunil Karan sir to deliver his talk. Thank you, sir.
Thank you. Can I put it here? Yeah, sure. Right. Good morning, everyone. Nice to see such a big gathering on a Sunday morning. And it's my honor to be here. Thank you, Manipal, Vijayawada, and all the organizers for having me here, including my good friend, Dr. Srinivas, for getting me. Oh, sorry. Yeah.
And to be the panelist, I request Dr. Manoj sir, Senior General Physician, Manipal Hospitals, Dr. Y. Ramesh Babu sir, Chief and Anesthesiologist Care, Ayush Hospitals, and Dr. Poonanand sir, Chief Cardiologist, Poona Heart Care Center. Thank you. Sir, you may take over.
Thank you, respected chairperson. So, yeah, so I'll be talking about VV ECMO primarily. Of course, a little bit of physiology and a little bit of basics since this is the first talk. I know quite a few of you might already have been doing ECMO or have been exposed to some degree of managing ECMO. Firstly, the nomenclature. So, the word ECMO has now been coined as, it's been called as extracorporeal life support. In short, we call it as ECLS. These are the different modes that you are able to see in how the coinage of the nomenclature has been done. So, fundamentally, we have two important things. We call what is called as VA ECMO, and the second one is what called as VV ECMO. So, by default, ECMO started more for patients who have reversible respiratory failure was the initial thought in how we started in clinical medicine. Of course, its role probably in the OT and some other places as an alternative or as a bypass was something different. But what we started in adult was more primarily to look at reversible heart failure, cardiac dysfunction, or reversible respiratory dysfunction or respiratory failure, which is beyond the scheme of what we would consider as conventional high-end ventilation. Of course, from then, ECMO has evolved a lot. Today we talk about ECPR, we talk about ECMO supporting for organ donation, for keeping the organ perfusion going, what we call as ECPR, EISOR, and such other interventions, which are predominantly beyond the scope of just saving life. So today when we talk about extracorporeal therapy in the context of ECMO, we talk for two things. One is bridge to cure, or we talk about bridge to bridge, which could be primarily when we talk about cardiac dysfunctions, where you bridge with the ECMO to something which is a little more sort of intermediate term like LVAD or something, or it could be bridge to transplant. So essentially this is a support. I think that is something we really need to understand, because it is not that every ABC patient goes on ECMO. So when we talk about putting somebody on ECMO, it's very, very important for us to understand the context. Is there an end to this? And most importantly, it is a support. So just like we thought, we think twice when we put somebody on a ventilator or dialysis in the ICU, ECMO also comes under a very similar purview. So the basic minimum thing of an ECMO circuit is that of course there are circuits, but most importantly it has a pump and an oxygenator. So in the context of extracorporeal therapy, when we talk about dialysis, for example, which is the most common form of extracorporeal support that we know for a very, very long time in acute care settings, Here instead of a filter, we have a oxygenator, which does the job of what the filter would do perhaps in the CRRT or in a renal replacement therapy setting. Now, the way we now nomenclature the cannula as well, there are certain norms which have been established by the 2019 sort of consensus conference. Essentially, we look at 4 levels of naming it. One is the basic configuration and flow. That is how we get the name of VV, VA and things like that. The cannulation site, tip position and the cannula dimension. So as you can see here, whenever we talk about V-V ECMO, it means that there is veno-venous with a single membrane in the middle. So if it's a single membrane, it's a single line. If there are 2 membranes, sometimes, not very commonly, not in basic ECMOs, but in very, very high-end settings, sometimes we may end up putting 2 membranes in a series, and we have a double line. And if it is in parallel, it's a double line. If it is, in intersection, or it's in sort of in 2 different circuits, then we would call it as a plus. So these are some of the sort of nomenclature, sort of standardization that we talk about. And also, if you're adding a cannula, whether the cannula is on a access side or the drainage side. So these are some of the words, if some of you are not familiar. That cannula which brings blood from the patient into the pump is called access cannulas, and that it sends it back is called as the return cannula or the drainage cannula. So if you are having an additional cannula put on the access side, you would have the additional nomenclature or additional alphabet put on the left of the hyphen. Or if you are having another one which is put on the drainage side, then you have it on the right side. And of course, based on the chronology, it could be, you may start as VV, but you add an arterial limit, it become VVA, V-VA. So that kind of nomenclature is what we go by. Now, the basic physics is, of course, we are talking about fluid passing through a cylinder, which, as you all know, is governed by the Hagen-Poiseuille law, which gives you the physics for laminar flow, which is depicted by the formula delta P, which is the pressure difference between point A and point B, or between the 2 ends of the tube or the cylinder. And of course, you have 4 times the power of radius, so R to the power of 4, which means that the flow is directly proportional to the pressure gradient, and directly proportional to force R to the power of 4, sorry, not 4 times, but R to the power of 4. So these are the direct sort of correlation, and the inverse relationship, of course, is to the density of the fluid and the length, and that is why you get the 2 other sort of variables in the denominator. So this is how the formula comes with, and for PVC or polyurethane, and most importantly, most of them are coated cannulas. So it could be heparin bonded, it could be ionic bonded, whatever. We'll talk about a few of these things, but they are coated sort of cannulas with wire reinforcement, which gives it the degree of stiffness that we need, because these are large cannulas and we don't want it to be kinking, because you're talking about flows in the range of 2 to 4 liters, not like the dialysis port where you're looking at 100, 200, 300 ml kind of a thing. So most cannulas do have additional openings, as we call it as, and often we look at what is called as multi-stage. It's not like only couple of side port, but you are having at different levels of the distal part of the cannula, and that's why it's called as multi-stage opening. And the pressure drop that we target in the access cannula is about less than 15, is less than 100 for, is about less than 50 for the access, and it would be less than 100 for the return. And these are what the cannulas are built for. You have single lumen, double lumen, different sizes. So these are all, this is just about the cannula itself. Then, of course, I told you there is a pump, and the most accepted pumps that we use today is what is called as pressure generating pump. It could be either the centrifugal pump or the diagonal or mixed flow pump. The Mackay and all these come with what is called as the centrifugal pump, but there are also devices which have diagonal pump, and the older generation, which was called volume displacement pumps, are the roller and the membrane pump. So the roller pumps are not used much these days, primarily because of the fact that each one has its pros and cons, but it's just that the fact that the pressure-driven generating pumps work on a physical principle which causes less damage. So the damage on the cells or the red cells in particular, platelet breakdown, all this is much lower, because it works on the principle of actually creating a suction in the mid cone, as you can see, and that is how the pump actually ends up causing a movement of blood. But one disadvantage with the pressure-driven pump is that it actually the volume is not directly related to the RPM. It is actually dependent on the pressure and the pressure gradient, and that has its own problem. Whereas in the case of roller pump, you actually set the volume, and the volume actually is almost directly has to do with the revolutions per minute. Because here in the pressure-driven pump, the revolutions actually determine the pressure, and there are other factors which will determine the volume. So you might see that the volume varies in the ECMO. Sometimes you keep a RPM of 2,500. If the volume is adequate, you might find that there is 3 liters generated. But if the volume drops, you might actually find that it actually comes down. Then the next important part is the oxygenator. Again, this is nothing but the place where the blood and the gas sort of pass through a membrane with a small membrane between them, and essentially each flow in a different direction. So you have what is called as axial flow pumps and what is called as transverse flow pumps. This is just based on the direction in which it flows. No major advantage or disadvantage, but it's just that it depends on how you are actually aligning your flow. But most important thing is these are all made of PMP. So there's a lot of been evolution in the technology from the silicon-based pumps to the only the polythene pumps to now what we call as the polymethylene pentene hollow fibers which are being produced. So the membrane oxygenator, which is the heart of the, or which is the artificial lung where all the oxygenation and or the gas exchange takes place, has a set network of fibers. So you have blood flowing through the fibers and air around it, or in certain pumps it may be the other way around. So each one has a volume or as a flow. So you have a gas flow, you have a blood flow. I think that's what is very important to understand, because that's the physics on which the exchange of gases takes place. So just like any other membrane, the efficiency of the membrane depends on the nature of the membrane, the porosity of the membrane, depends on the surface area, and a whole lot of other things. So to measure the efficiency of the pump, we look at what is called the rated flow which is nothing but the venous blood which gets perfused at low flow and at a given time, which gives you a certain amount of saturation. So you would expect that for a given flow there is maximum saturation, and that is what is called as rated flow. So most standard tubes or standard pumps or standard membranes would be considered to be giving you a saturation of 95% on a hemoglobin of 12 grams, when the membrane saturation is about 70. So a 70% saturated blood comes to 95% with a hemoglobin of 12 is what is considered as ideal. And of course there is a certain rate of flow. If that rate of flow exceeds, then you find that naturally the oxygenation drops, or if it is too less also there will be not optimal efficiency of the pump being utilized. And lastly, of course, all these different gradients or different sort of components are connected by what is called a circuit, and there are different circuits. I told you again, there are coated circuits, which are different types of coatings based on the necessity. Most commonly used is what is called as heparin bonded circuit is what we use, with which the intensity of the anticoagulation can be much lower. So when you put somebody on extracorporeal circuit, it's important to understand that there is extra dead space that gets created, and how much dead space is properly mathematically looked at. And for most adult tubings, we have a 3/8 inch, which is about 71 ml roughly per meter. So the rough length is about 5 to 6 meters for the whole circuit you're talking about. So you can multiply 71 by 60, and that's the kind of volume that you're looking at, somewhere between 400 to 500 ml of additional dead space that gets added. Now this is important in the context particularly of VV ECMO, because VV ECMO patients generally are relatively hemodynamically stable. And when you are talking about ARDS, generally the feeling is that I will not push too much volume, you keep them diuresed. But the moment they go on the pump, you might actually find that temporarily there's a drop in the blood pressure, and you have to tank them up a little bit during that part, the initiation part. So be very, very careful when you initiate these patients. So often what we do, we'll talk about it, but additional volume is often being needed, because you are adding half a liter of additional dead space to the volume, which is the vascular compartment, which has now been extended because of the addition of the extracorporeal circuit that gets added on. So there are different monitoring areas that we look at when we have people on such a complex device. And as I told you, the two basic things that I said was the pump followed by a membrane, and of course you have the patient at both ends. You have the drainage and the return on one side. So the common pressures that we look at is called as P1, P2, P3 generally. So there is one pressure that we look at pre-pump, which is before the pump itself, which is obviously a negative pressure. Then you have a post-pump, which is a pre-membrane pressure. So you have a pump, you have a membrane, as you can see in the figure here. I don't know whether it can show. Okay, don't bother about it. So just a minute. Yeah, so you have a pump pressure and you have what is called as the pre and the post membrane. So across the membrane, the gradient is very, very important to be monitored. So we look at both these things because this will give you, this is one of the measures of the efficiency of the pump. Over time, you find that the pressure gradient of the pre and post membrane drops. So there are three areas where we measure. This is called P1, the P inlet, which is the pre-pump. Then you have the pre-membrane, which is the artificial lung, and the post-membrane. So P1, P2, P3, respectively. But this is just for you to understand. Of course, in the afternoon station, they will show you and explain to you what they are looking for and why you are looking for each one of these. And each pressure has a definition. It has a range, and you need to keep monitoring this on a routine basis to ensure that you have one, optimal pump efficiency, because if there is decreased volume, you find that there is chattering happening, there is too much of negative suction on the pre-pump part of it. This is the P1 that I told you, and that can cause hemolysis and a lot of other problems. Then, of course, you have the pre and the post membrane, which is again looking at positive pressure in the pre-membrane, post-membrane also it's a positive pressure, but the gradient is very, very important. And the additional parts of the thing is the main console itself. It's like the actual engine of the ECMO sort of setup, and a temperature regulating device. So this is in sort of the different components that we talk about. Now coming to the core of the first half an hour talk, which is the types of VV ECMO. So simple understanding, VV or veno-venous ECMO is for severe respiratory failure, provided all the necessary things have been done to optimize ventilation, including proning, this, that, whatever else, and then you know that he's beyond conventional ventilation or the highest possible level of ventilation, and then these are patients whom you would consider for ECMO. Most common preferred modes in VV ECMO is femfem, or it may be femoral internal jugular. We generally prefer to go femoral jugular because you have one limb left, so you need central lines, you need HD catheters, a lot of other things. Occasionally we do what is called as femoral PA catheter, or femoral pulmonary artery, which is the drainage catheter goes directly into the pulmonary artery, which is often done when they have very, very severe RV dysfunction or some additional component where the VV is not enough, and that's one of the indications where they look at pulmonary artery sort of return, which is not very common, but most common for conventional ARDS or conventional lung failure, we do what is called as femorofemoral, or we do it femorojugular, where the femoral axis and you return back into the femoral on the other side, or if it is femorojugular, you take the drainage, or you drain the blood out from the femoral and return it back to the internal jugular vein on the right side. So there are different techniques. Percutaneous is the preferred one, which is the Seldinger usual thing, ultrasound, put the wire. Sometimes we put a small catheter and then put the larger wire through it. So whatever is convenient, and depends on the operator's sort of choices. Of course, ultrasound, as you know, has changed the way we look in critical care. So I think please do use the ultrasound, because this is it is a situation where there is a bit of time on your side. It's not like you had an arrest and you're putting a line in an arrest, where sometimes you might end up doing it blind, but I think ultrasound helps you a lot. This particular graph shows you the sort of rough diameter of the gauge of what you're looking at of the catheter size. So generally for a person between 50 to 70, we would have access cannula or a drainage cannula of between 23 to 25. It's very important to have as big a drainage cannula as you can, because that is the one which will determine the blood that is coming out of the patient, and a good return as well, which could be a slightly smaller one, because if you're tackling the IJV, you don't want a very massive one going there. So often we use the ultrasound to measure the diameter of the vessel, and based on that you multiply it by 3, and that will give you the gauge of the French that you're going to use for this thing. So as you all know, French is the conventional measurement that we use for the size of the diameter of the cannula. And you also need to understand that when we talk about the French, the diameter in inches is actually actually outer to outer. So the inner diameter may be variable depending on what company you use as well. So that's there, you know, so if you take a 25 gauge cannula of one company, it may not have the same internal diameter as the other one. So these are certain subtleties that you will probably learn on the way, but it's important that you know what cannula you're using, and you can probably stick to the same one, because that gives familiarity to the whole team, because ECMO is not a one-man show, it's a team game. You have the cardiothoracic team, you have the perfusionists, you have the intensivist, you have the bedside nurse, so everybody contributes to the care of the patient, and it's not like half an hour, 1 hour, it's going to be sometimes at least a week, 10 days in a VA ECMO, and probably much longer in VV ECMO. Our longest VV ECMO was somewhere like 89 days. So we are looking at, you know, big numbers. In our compatriot hospital in Whitefield, I think had 106 day sort of duration of VV ECMO. So VV ECMO is there for the long haul, as you know. So it's very important for you to understand. There are different ways in which you can actually look at these cannulas, but this is generally a good return is what we look for. A VA, again, venous will remain the same, but arterial, again, you look at the diameter and decide, which my other colleagues will talk about. So brief understanding of the cardiovascular physiology, I think this is a familiar figure to all of you, so I won't waste much time on this. But what I want you to understand is that normally the body has a buffer of at least 5 times of delivery. So if you're looking at an extraction ratio of around 25%. So if you send X amount of blood, only 25% of them, sorry, X amount of oxygen, only 25% gets used in rest setting. So the natural reaction of the body is to increase the flow, as you know, vasodilation, metabolic states, catabolic states. How you see that the cardiac output improves, that's the first line of defense. And the later line of defense, of course, is the extraction ratio going up. So once the extraction ratio goes up, then you know that the patient is in real trouble, because that's the level of reserve that is available for the human body. So this is again, you know, rack your brain, go back to physiology, the oxygen content of the blood, which is in brief, what you know is the oxygen carrying capacity, which is hemoglobin times saturation into 1.34, plus of course the dissolved oxygen, which generally we don't bother much in routine settings. You know, IU, we don't bother much because we know that the dissolved oxygen contributes less than 1% of the actual oxygen carrying capacity. But in a patient on ECMO, you might find that this dissolved oxygen is quite high, because you're talking about 300, 400 ml of millimeters of mercury of oxygen can be there additionally dissolved, because we are actually getting right from the pump, you know, you're getting highly hyperoxygenated blood which enters the venous side of the circulation. So there is an estimate in vitro data that says that this can contribute between 5 to 10% to the actual oxygen delivery of the patient in times of dire straits. But this is again in vitro data, but dissolved oxygen may have a role to play in the setting of hypoxia or such other problem that we deal with our critically ill patients, right? Now, some basic understanding, I think just a revision for you. Just remember that 20 cc per deciliter is the actual concentration of oxygen, is the actual content of oxygen which is there. And when you multiply that by cardiac output, it's about 600 ml per minute per meter square. But of this, I told you only 120 ml gets used. So you have this figure, all of you know this, what is called as the critical point, beyond which you actually find that there is a tip over and it becomes into what is called as anaerobic metabolism. But this is what I want you to focus on. 2:1 is, I mean, normally it is 5:1 is the actual margin I told you. When it comes 2:1 and below, it's when it actually switches to anaerobic metabolism, and our aim is to keep it at that level. Now, this was what I told you about the rated flow concept. I think last 5 slides were general physiology. You want to remember, you remember, or you can forget it. But this is in context to the talk that I am giving now, which is VV ECMO. Now, here, if the blood flow goes beyond a certain value, as you can see in this graph on the left side, you actually find that the efficiency of the pump actually falls. So there is an increase as the flow increases to a certain level of the oxygenation exchange, but if the rate goes beyond that, you obviously will expect that to drop, because there is not enough time for the gas exchange to happen. Now, this is an important graph in vitro done on 2 lung prototypes. Now, what I want you to understand here is that CO2 is more diffusible than oxygen. Now, in routine normal life or normal metabolism, you find that for every 1 part of oxygen exchange, there is 1 part of carbon dioxide that gets moved across the membrane. But when the need is very, very high, carbon dioxide diffuses 20 times more than oxygen. Therefore, when somebody needs only hypercapnia therapy or carbon dioxide to be cleared, as you can see, generally the flows are much lower, 1.5, 2 liters. And also, it is not only determined by the diffusibility, but also by the gradient of the CO2. Higher the CO2, greater is the gradient, as you can see on this. So this is the point that I was telling. The more the CO2, you actually find that the gradient eventually ends up with the same amount of blood flow. You actually find that you actually get good clearance of the CO2, because that's the diffusibility nature and also the gradient which matters for CO2 to jump across the membrane. So when we talk about veno-venous ECMO, as I said, it is for lung support. There is no hemodynamic support. So if somebody has poor heart or associated circulatory dysfunction, you have to look at some other form of ECMO. It may be either central VA, or you can do what is called as VAV, where you actually have both arterial venous support and have a flow regulatory mechanism where you can actually divert the blood on the return to different parts, to either so much to the venous part, so much to the arterial, but that's when there is associated cardiac failure. Now, it is important for us to understand, and it's not uncommon in clinical practice to see that because of the hypercapnia, because of the acidosis, there will already be some degree of RV dysfunction or elevated PA pressure or a poor cardiac function as well. So I think it's very important to take a clinical judgment call before you put this patient on ECMO, that is this a reversible dysfunction because of the acidosis or because of the hypercapnia, for which just a VV ECMO will actually make the difference. So sometimes that call can become a little tricky because you don't know whether you're actually dealing with the circulatory failure and consequent other effects, or it is just because that there is severe respiratory failure, including hypercapnia and acidosis, causing the cardiac dysfunction, which will immediately get better the moment you take these people on VV ECMO. So that's very, very important point, that you need to sort of make a judgment call sometimes if there is a cardiac dysfunction associated with patients with severe respiratory failure. So generally the goal of therapy is, of course, keeping an oxygen of between 85 to 90 saturation, and of course looking at a CO2 which we kind of come down very gradually. We'll talk about it. Now, what are the things that determine oxygenation ECMO? Again, I think we went through it in physiology, but important is membrane area, rated flow. These are all fixed concepts or fixed for a given membrane. But from a patient perspective, hemoglobin concentration, and of course most important is what is the relative cardiac output of the ECMO flow to the cardiac output of the patient. Am I making sense, or it's all rubbish I'm talking? Yes? No answer. All right. So if a person has a cardiac output of 5 liters, you would expect that the cardiac output on the VV ECMO is at least around 3 to 3.5. So you actually find that hypoxia worsens in certain situations when you actually see that the cardiac output of the patient starts going up. Not in all cases, there are 2 examples I will talk about, but it's very important to understand in a situation where the cardiac output of the patient starts going up, native cardiac output, you have to supplement by additional flow or increasing the flow of the VV ECMO itself, because on the general terms, 2/3 to 3/4 of the native cardiac output has to be matched in VV ECMO flows. Otherwise, you find that the patient starts getting more and more hypoxic. Whereas removal of CO2 is very easy. As I said, we generally determine it with what is called as the sweep gas flow, and that will actually determine the CO2 removal. So if you are only looking at CO2 removal, your blood flows can be 1.5, 2 liters, and it is most important that sweep that actually determines. So this was the scenario that I was talking about. Now, when we talk about increasing cardiac output, there are 2 scenarios that can happen. One, increasing cardiac output because of increased metabolic needs. That situation, you have to supplement the cardiac output additionally. Sometimes there can be increased native cardiac output where the body has already compensated for that. So how do you differentiate between these 2? In that scenario, you may not have to increase the flow. How to differentiate is look at the venous return or the central venous oxygenation returning back. If the venous oxygen is low, then you know that there is too much extraction happening and you need to augment the flow. But sometimes it's just the hyperdynamic state causing increased native cardiac output, but there's not much change in the oxygenation, there is no need to supplement that. So this is a thing that you actually need to this. So if you look at this in scenario 1, we have this is one of the scenarios where you actually have increased native cardiac output, but not much change in the returning central SvCO2, which means that there is optimal oxygen delivery. There is no need to do anything at the ECMO. Doesn't matter about the native cardiac output. But in situations where you actually find that there is decreased hemoglobin, anemia, or actually increase in the catabolic demand, SvCO2 drops, and that is one area. So if your pre-membrane oxygen, or sorry, pre-pump oxygen or pre-membrane oxygen has a saturation of below 70, then you know that there is some trouble and you may have to actually augment the flows, okay? Right. So who are the patients on whom you would actually consider starting them on VV ECMO? Now, about 10 years ago, or maybe 8 years ago, before these 3 trials came, we would actually say all those who had a high Mero score, reversible injury within 7 days of mechanical ventilation, who had an 80% mortality if they don't be supported, these are the patients on whom you would consider them on ECMO. But today we have a more objective way of looking at it. So, especially looking at the last Eolia trial, where they actually had the inclusion criteria that PO to FiO2 of less than 80 for 6 hours, which means that you've done everything, proning this, that, no improvement in 6 hours above, in the PO to FiO2 gradient, or the PO to FiO2 of less than 50 for 3 hours, you would actually consider starting them on VV ECMO from the oxygen point of view. Or a PCO2 which is more than 60, and you're not finding that the PCO2 is getting better and the pH has gone below 7.25 in a pattern of about 6 hours. These are the patients who you consider starting them on VV ECMO. Now, the 7-day mark is probably now a relative indication, contraindication. I think we, in our own experience, also have had many patients whom we have started on day 8, day 9, day 10, and they have done quite well overall. But I think what is important is that you start it as early as possible, because important thing is to protect the lung. Because once you hammer the lung with your ventilation, you have actually lost the boat. So very important. In fact, people are now looking at more refined data, looking at driving pressure as a concept. And if the driving pressure is too high, maybe okay oxygen, maybe okay carbon dioxide, but if your mechanical power calculation on mechanical ventilation is very, very high, or you find that the driving pressure is high in spite of all optimization, then this is one place where you probably will start considering ECMO early, or there is some other form of lung injury, barotrauma, pneumothorax. All these things are where we look at ECMO much earlier, though the evidence for that is still based on cohort and case series. But it's very important to think about ECMO in the context not only of the gas exchange, but also in other areas where you think mechanical injury can actually cause a problem. So this is the sort of different trials and recommendations. The Caesar trial, which was looking at the erstwhile indications, as I told you, initially when we started, I told you 80% risk of dying and all those other things. But subsequently, with the Eolia, it is much more objective. So you look at PO to FiO2 50 for 3 hours, 80 for 6 hours, and a PCO2 above 60 for 6 hours with the pH drop of less than 7.25, which is not responding to the usual measures that you are going to do. Right. Other indications for ECMO, as I told you, the role of VV ECMO is expanding. And many of these indications we have also done on one-odd patient and have actually got good results. Bad hemoptysis, diffuse alveolar hemorrhage, these are all indications where, of course, like ARDS, you would actually find that there is hypoxemia, hypercapnia, so they do well. Bronchopleural fistulas, you protect the lung, allow the fistula to heal, or you want to intervene in the upper airways, or for that matter, even for the lung, if they want to intervene for the bronchopleural fistula. This is one indication where ECMO can be commenced. In our experience, we have had 3 patients on whom we had to actually start them on VV ECMO because there was some, either a mass or some other upper airway problem which needed to be intervened. So they were on ECMO, then the procedure was done comfortably by IR and pulmonology in combination, and eventually the patient got better. In trauma, I think there is increasing role of VV ECMO in lung contusion. Even if there is an associated traumatic brain injury where you actually look at minimizing your anticoagulation, we'll touch on that as well. Now, once you decide to go on ECMO, how do you start your ECMO? It's on a ballpark, we would say start the pump flow at around 50 to 70 ml per kg per minute. That's the rough thing. Of course, if you are very scientific, if you can do the DO2, VO2 and all that, nothing like it. But I think in conventional clinical context, it's very hard to be sitting and calculating those things. But generally, we have a starting point as 50 to 70 ml per kg per minute. So you look at the body weight and start it at that rate. And sweep flow or sweep gas flow is generally on 1:1. Generally we say 1 liter of flow of blood, 1 liter of gas, and then gradually up titrate it, because important to understand that many of these patients are having a CO2 of 70, 80, pH of 7.1 or 2, and the moment you go on the pump, you actually find that the CO2 drops rapidly, and there is a risk of developing cerebral vasoconstriction and predisposed to a higher risk of CNS complications, including bleed and such other things. So be very, very careful at the start of it. And also, of course, the rapid clearance of the CO2 can actually further compound your drop in the blood pressure as well. So it's all very important to be very, very slow on the sweep flow. So we generally say 1:1, or even a little less is okay, 1:0.8. So blood flow of 1 liter, you would go for a sweep of 0.8. So on that sort of ratio, you would actually start the flow and then gradually go up based on the ABG and such other things. Of course, the flow can be directly manipulated based on the saturation. So you are not optimizing, getting into your saturation of 80-85%. You would actually increase the flow gradually. I'm talking about the pump flow, not the sweep gas, but the flow of the pump, and reach the target that I told you of about 60-80% of the actual patient's native cardiac output. Now, sedation and paralysis, of course, most patients on the pump, we do start them on sedation paralysis because they're already, battered, ARDS, already on severe, high levels of sedation paralysis. But there have been times when we have actually commenced patients on awake VV ECMO as well, not intubated HFNC, maybe an ILD deteriorating, or maybe somebody who has maybe a bronchopleural fistula, just want to rest the lung. So there are contexts where you can actually start VV ECMO on patients who are on HFNC, NIV, or on spontaneous breathing as well. Gone are the days when we would actually bomb these patients out, keep them so deeply sedated that God only knows whether they're awake, alive or dead. So I think today, within the first few hours, we try to slow down the sedation paralysis. And of course, if it's a bad ARDS and you find that the patient is doing steady on the pump, you can actually, that will also give you an opportunity to slow down the sedation paralysis earlier, keep them awake. Sometimes we even extubate them. I'll just briefly touch upon what are the contexts on which you can extubate patients with ECMO. But generally, the role of sedation paralysis has actually declined substantially. What is the ventilation? We look at what is called as rest ventilation, 2 ml to 4 ml per kg. That's all with a rate of 10 to 15, and ensuring that the driving pressure stays below 15 and the plateau pressure stays below 25, because that is the whole aim. So the focus is just to keep the lung rested, but not zero ventilation, because zero ventilation has its own problems. And today we have data emerging because of ultra low tidal volume as well, that it causes atelectasis, a lot of other problems. So even that's a bit of a debate people are looking at. But in general, 2 to 4 ml per kg is what we would look, and some expansion of the lung on a routine basis at the rate of around 10 to 15 per minute, and ensuring that a PEEP of around 8 to 10 or 12 is actually there to keep the lungs open. This is all the usual concepts of ARDS. There's no rocket science in what I'm talking in this. And of course, eventually, if the patient is stable enough, you would look at extubations or CPAP or such other more. Now, extubating patients on HFNC or NIV, there's a lot of literature emerging out of it. You can do it, not a problem, but it depends on patient characteristics. So if the patient is very anxious or, in a very high catabolic state, they start breathing at 30, 40, try not to do anything about it. Don't try to extubate these patients, because the moment you extubate, they will actually get very distressed and you put them back on the tube. So it's very important to take a very guarded view on this. And if you find that the patient is steady, comfortable, you can extubate him, then of course please feel free to extubate him, because it's very important that they are better off extubated than on being on a ventilator, and it makes a lot of difference. But when you're starting the ECMO program, don't aim to extubate them in a hurry. I think your aim will be to make sure that the programs get settled in, or the patient himself gets settled, and take the discretion based on a case-to-case basis. Because on the ECMO, if the patient is comfortable, then yes, it makes sense. Otherwise, what happens, you extubate these patients, they get very agitated, they breathe very hard, and you actually find that the demands of the ECMO also start going up. So that's not the idea of why these patients are on ECMO. The next important thing is, of course, tracheostomy. Earlier the better. Generally, we prefer to do it as early as possible, because we know that these patients are going to take a while, unless you're sure that you can extubate them. That's one point. Second point, of course, is before you start getting into episodes of sepsis or membrane dysfunction, when the coagulation also starts getting a bit haywire, it's often better to start doing tracheostomy on these patients earlier. So there is some data, not very strong, but some data to indicate that early tracheostomy helps, and particularly in the context of, as I said, coagulation dysfunctions, which can occur down the line because of either sepsis or because of membrane dysfunction or any other reason, which is likely because of the ECMO itself. So of course, when you're talking about tracheostomy, the usual debate, percutaneous versus surgical, we have done a lot of percutaneous tracheostomy, but there are times when we have sent it to cardiothoracics for a proper sort of surgical trachea as well, if there are big blood vessels. So don't be a hero. It's always better to do it safely, or you can even defer it by some time, but the conventional rule is you can do it a bit early as well. Stop the heparin if it is there. Make sure that you have good coagulation parameters just prior to going in. A TEG is a very useful way of doing it, and I think more and more centers are now using TEG as a good marker of coagulation profile. Not only does it give you the values of each of the components of the pathway, but also, of course, the functionality of the platelet and such other things. Renal dysfunction, 30 to 50% of patients, if you look at ELSO data, about 1/3 to 1/2 of patients on ARDS do have renal dysfunction of varying degrees. About half of them often end up needing renal replacement therapy. So there are two ways of setting up the circuit for renal replacement therapy. You either put it in line with the ECMO, where you actually pull off a limb from the ECMO circuit itself to the filter and send it back, or you can have a parallel circuit, say totally a separate HD catheter placed where you can actually do it. But there are different ways in which you can connect the CRRT circuit to the ECMO circuit. But one important rule, don't cross over from the oxygenator, which means that you should not be putting a circuit from a CRRT circuit from here to here, because you're actually bypassing the efficiency of the membrane oxygenator. Some people have done reverse, that's okay, but not the other way around. But generally, we would either try to stick to one side of the oxygenator. Of course, each of the thing has its own problem, because if you're after the pump, before the oxygenator, your CRRT machine starts giving high pressure alarms. If you're before the pump, it starts giving suction alarms. So you'll have to probably modify the machine, blind it. So the marrying the perfusionist and your dialysis technician sometimes becomes a problem. But I think it's important that you actually get that sorted. So most important, as I said, no bypassing the oxygenator. Please don't do that, because then you're actually compromising the efficiency of the oxygenator. There are different theories about anticoagulation. I think we are familiar with heparin. We have used it for a long time, but heparin has its own complications, and as you know, the longer the heparin is used, it actually gets into the realm of being very unpredictable. So a lot of other things have been used. Bivalirudin is the most common thing, which is used as an alternative, and we use, of course, either APTT or thromboelastogram as a guide to our monitoring. Other sort of general, coming to last 2 minutes, general ECMO related monitoring, a nurse who is taking care of your patient, of course, looks at all critical care aspects, but also the ECMO, which is the flow, the clot formation in the pump, or these are all the pressures. I told you the 3 pressures we spoke about. All these things are something they need to be looking at. So the other issues, general ICU issues, of course, be very, very this thing. There is talk about ECMO and proning, no evidence to support it, but I think on a case-to-case basis, you can actually use it as a useful tool to improve the lungs, the recruitment of the lung. And the last part is, of course, how do you wean your patients of weaning of ECMO. So when you talk about weaning, I told you there are 3 components. You have a sweep gas, you have a FiO2 on the ECMO, and of course, you have the flow itself. So people have used all sorts of combinations, reducing the flow. So of course, you would want the flow to come down below 2 liters. Then you know that the patient is ready. They drop the FiO2 to 21%. But I think most commonly what we now do is just reduce the sweep. And once the sweep goes below 1 liter, you take a cutoff completely. Because if you start reducing the flow, then you have problems with anticoagulation, this, that, etc. So for VV, it is very simple. Most often, we just reduce the sweep or keep the sweep at 0 for between 4 to 24 hours. And you load the patient on the ventilator. If the ventilator is able to do the job, nothing like it. Generally, we prefer, not by any evidence, but by by default, if the patient can directly switch into pressure support and remain stable on that, I think that's the best thing, because always remember, the moment you take these patients off ECMO, the day you decannulate them, many of them, about 60% of them temporarily worsen because you have some sort of an endotoxemia storm or biofilm storm, don't know, you actually find that they temporarily worsen, some degree of worsening of the idea. So you have to have that buffer. So please remember that when you take off these patients, you expect them to worsen for 24, 48 hours before they start stabilizing on the ventilator. So you should have that kind of margin. So the usual ventilator parameters of plateau pressure less than 30, 6 to 8 ml per kg, you are able to ventilate, not 4 to 6, because 4 to 6 is the idea. So you're already on the pump, let the lung heal enough to come back to 6 to 8 ml per kg of ventilation, and of course able to keep the PCO2 with good levels of ventilator. So in summary, hypoxemia with or without shock will decide on what is the modality you're going to use. Straightforward hypoxemia or hypercapnia with no shock, VV ECMO. Or if it's only CO2, of course, you can look at other forms of extracorporeal therapies like ECCO2 removal, etc. But I think since we're talking on ECMO, I'll stick to that. Flows are much smaller for CO2. That's something you need to remember. Hypoxemia is determined, the response to that is the flow of the pump or the blood flow, the cardiac output of the VV ECMO. If there is shock, decipher whether the shock is because of the ARDS, lung, CO2, hypoxia, and will it reverse with the VV ECMO. If it is not, then you may have to consider cardiac support as well along with the VV ECMO support. Thank you very much. Sorry if I overshot a little bit with the permission of the House. Thanks very much.
Good morning, all the delegates, my co-chairpersons, Dr. Manoj, Dr. Purnanand. I congratulate Dr. Sunil Karan for extensive coverage of the ECMO. And I'm so happy that ECMO shop is being conducted in Vijayawada itself. Me and my cardiac surgeon, Dr. Sai Pawan, went to Mumbai to take the course a couple of years back. Suddenly, all the humanity realized the extra armamentarium we need to develop in COVID times. Lungs are totally gone. We realized the value of ventilators in polio epidemic. And now we realize the value of ECMO because of the COVID. So essentially, all the centers, whoever is operating open hearts in Vijayawada should be capable of doing all these things. But at this point, from people from Bangalore, they should realize they are not very often happening in Vijayawada. We will be requiring your help in coming future to develop Vijayawada further. Here we are collaborating so that my perfusionist may go to Manipal and here they may come to us. With your cooperation, we want to take it forward. And I congratulate Dr. Sunil, especially for covering extensively when to intervene. Essentially, it is for VV is not a complicated thing. Essentially, it is to initiate, it is a respiratory failure. He has given clear indication when to initiate or 4 indications. He clearly mentioned what are the 3 pressures which are very useful. So his talk is so elaborate, maybe subsequent talks will go to much more complicated circuit like VA and other complicated circuits by further talks. And I wish all the delegates, I am very happy to see so many people who are interested in knowing about this. I want this to be an interactive session rather than a didactic thing. It's an interactive, it's an opportunity for the people to reach to eminent people like this in Vijayawada itself, need not travel to far off distances. These few words, maybe, if the other people permit, shall we go for a small question answer session, or you want us to proceed to the next talk? Srinivas, shall we allow them to take some questions, Dr. Sunil?
Question answer session.
Yeah.
It will be important because there's such a big crowd. They definitely will be having some doubts which need to be clarified. Just to initiate the talk regarding the questions and all. Sir, in your experience, what's the most setup error you have come across? That will be very important because any sort of error which is occurring regularly.
Yeah, I think one is anticoagulation titration. That is the most difficult problem many times because it's very unpredictable. Especially, there's a trend that somebody has said ACT, they keep on doing ACT forever and ever. So that's one thing. Second, I think, is making sure that all your oxygen port and your the battery backup plus the power backup to the ECMO is maintained, because that's the last thing you want. Something, somebody comes, cleans, pulls off the plug or something. You should understand that the patients completely depend on this. Third part is, of course, infection control. Very, very important, because if you look at even the ELSO data, you would see that the risk of infection increases by tenfold every 1 week. The patient is on ECMO, and this is more so with VV ECMO, because they are much longer, they have a damaged lung, they will need a lot of vascular access. So I think infection control is very, very important. Most deaths in VV ECMO actually happen because of secondary infection. So I think that is something which you need to be conscious about. And watching for the coagulation abnormality. Sometimes it becomes very difficult to know that whether a certain coagulation abnormality is happening because of the membrane dysfunction or there's a new onset sepsis, because as you know, ECMO is a pro-inflammatory state. So the ECMO itself will keep the inflammatory axis sort of very active. And even if there is a subtle infection, you just have to have a very high index of suspicion to actually make to think of infection as a possibility. And sometimes they're unnecessarily an antibiotic, because you don't know whether it is a non-infective inflammation or an actual infection happening. And last one, I think there is an empirical thought that if somebody is in ECMO, they should be on antibiotics. That is not needed.
Yeah, that's the take-home message regarding somebody should be monitoring ACT. How regularly do you think and I think the recommendation is somewhere in 160, 180 kind of.
Venous you can have between 140 to 180, not more than 180, generally not needed. But of course VA would be much higher. So that's the target range, or you just look at APTT of 30 to 45. You don't have to keep it at a double. But as I told you, I think many instances we have actually run it without heparin as well. One is they are heparin bonded fibers, so it's not necessary to actually do that. And if there is either a bleeding, you've done a tracheostomy, as I told you, we have had patients with TB and chest contusion on whom we have to start ECMO. So these are places where you cannot use anticoagulation. So I think you can even run them without anticoagulation. I'm talking in terms of VV ECMO. So it's not a must that you have to run them on so much of heparin, so much of this thing all the time. At the most, you may lose a circuit, so be it. You put a new membrane if the membrane goes away. But otherwise, I think be a bit careful with anticoagulation, especially with VV ECMO.
Any more questions?
Yes, in which cardiac conditions ECMO was helpful, and how many patients we are able to extubate or get the patients on the ECMO?
So I think Sir will probably answer that question more. I think in a medical condition, on the medical side of things, I think VA ECMO is overdoses, myocarditis, or it could be somebody who just had decompensated heart failure or goes into cardiogenic shock, who is in line to bridge to something. Now, if there is no bridge, then ECMO is not going to be of help. But generally, only from a medical perspective, I think overdoses and myocarditis. I mean, just to give you an example from the Indian scenario, I think, as you know, aluminum phosphide, there is a lot of data. Before the onset of ECMO, I think the mortality was something like 80%. But Dr. Srinivas, I'm sure, will add to that. But after we have started VA ECMO, now we are talking about the mortality down to 20%. And I think we don't see that much in this part of the country, but if you talk to people up north, western Indian states, a lot of centers have started ECMO only for that reason, because the maximum number of toxins they see are cardiotoxins, which is aluminum phosphide. And I think in that kind of setting, definitely ECMO has made a huge difference in terms of survival.
Did we have any evidence of cardiac function deteriorating during ECMO because of stress cardiomyopathy?
Yeah, stress cardiomyopathy is another situation where VA helps. I don't think there's any place where because of ECMO it has deteriorated. I think there's already a bad native disease. So I can't say that a particular deterioration has happened because of ECMO. But in general, but it's important that I'm sure we'll have the other talks on VA ECMO, that you are able to identify what are the problems, because sometimes just the LV distension itself will not allow the heart to recover as well. So I think looking into those aspects is very, very important as well.
Yeah, actually this ECMO, I think decade back started in Vijayawada, quite a few centers, and somehow it died off automatically. So nobody is used recently. Now again, I think it's a time actually we have to go ahead and use the latest technologies, and mainly this CME is for most of the time awareness, because most of the people are not aware that things are available in Vijayawada and people are doing, not 2 or 3 centers are doing, and so we should know when to refer the patient or when to go for the ECMO, all these things, at least the basics. Sometimes you may not be understanding what people are telling here, but at least we should know we can help our patients, because this is quite a high time actually. This is going to be the capital, and we are also supposed to go forward and use everything. Thank you.
How long can we use before we return back to the routine?
As I told you in the first or second slide, it is a support. So there is no longevity to that. I think if we know that there is going to be reversibility, it can go on for quite some time. But by convention, generally VA ECMOs are much shorter, because you would expect if it's an acute cardiac condition, it would reverse by a week, 10 days, or then you bridge them to something else. But veno-venous ECMOs go on for quite some time. As I told you, in our experience, 89 days was the longest. We've had one person on VV. Most people, as you know, the pathophysiology of ARDS, 2 to 3 weeks is what they would need. But there are certain things like, say, lung contusion needing this thing. They come out in a week's time. So it depends on the etiology. So there is no timeline to say only this much you do or that much you do. I think in literature, if I'm not wrong, 604 days is the longest ECMO, I think, if I remember correctly. But people have done it for a while. So there's no reason not to do it. But you also need to understand that longer the ECMO goes on, there are problems with that, because it's like another support. So it could be critical illness neuropathy, it could be risk of infections. All this is much higher. That's
The people like us who never have any exposure to ECMO, were in government service, of course, people like Ramesh Babon, you only took one class from EMO to ECMO in our Vijayawada city branch. What I want to ask is, what are the prognostic indicators in the ECMO treatment, and when you call off?
Prognostic indicators, I think, will depend on the primary disease. So I think we need to have a clear understanding that is this disease reversible or not. That's the first one. If there is no reversibility, then do I lead to somewhere? And this is particularly true in VA ECMOs, where we would say that there is a cardiac dysfunction or there is a pump failure. Now, do I make this patient on ECMO to cure, or do I bridge him to something else? So you should have an endpoint. If there is no endpoint, then ECMO is not an option. If you ask in statistical sense, the primary disease, age, of course, comorbid problems, if somebody has bad malignancy and these are probably, if there's no longevity to that, then you would not consider ECMO in those patients. And the longer they are in ECMO, of course, higher is the risk of them not getting better, etc. But even then, we have had situations where, bad ARDS is eventually bridged on to lung transplant, but they are not the most ideal candidates for that. So I think that will be an ongoing assessment is what I would say. Now, when do we call it off? It's probably if as a clinical team we feel that there is no end point at the end of this, then I think it's high time. Say if they stay on ECMO, multi-organ failure, persistent multi-organ failure not getting better, then I think that's something where we'll have to think. But depends again on the clinical context. Yeah. I don't know, sir. I would say my center. I will be biased. Yeah, I think now a center which does about at least 10 to 20 ECMOs a year is probably a good one to go to. That's where the hub and spoke model would come. So, if there's a center doing 1 in a year or 2 in a year, then the expertise won't be enough. So, in fact, ISCCM has also made the fellowship courses based on having at least 10 ECMOs per year as this thing. So, if you're doing 10 a year, then you're a reasonable center. More than 20, also says more than 20, it's a good center to be in. Yeah. Right.
So, I may be out of time. The last question, your experience with Bivalirudin, other than heparins, how many you did and what are your experiences using
So
other than?
we have used Bivalirudin. In fact, a lot of data is in favor of Bivalirudin in many ways, that it is more predictable in its titration. So in those patients, we have had 3 patients who have had HIT, or we suspected to have HIT, and eventually we ended up changing it to Bivalirudin. They've all done well, but I think the good part about it is titration seems to be much more predictable, unlike even in the setting of AKI.
The availability is freely available.
Yeah, it's available.
Coming to Bodepudi's question, what is the cost involved? It's a very tricky question in answering in CMEs. When they cannot afford that.
No. I think we have to bifurcate the two things. If they can't afford, I don't think we should stop treatment. That's point number 1. So the stoppage of treatment or cessation of treatment will be based purely on clinical grounds. So it could be, there is no end to there's no forward flow, there's no forward direction for the patient, then of course, say the patient is on ECMO, develops a brain bleed, then obviously we stop the ECMO. Persistent multi-organ failure, he's on ECMO, CRRT for a long time, maybe a month, and then he develops bad sepsis, triple vessel, 3 vasopressors, 2-3 days not getting better, then maybe that is one place where you would consider physiological irreversibility and consider stoppage. So that has to be a clinical decision, I would say, but not in the context of money, that's for sure.
Once we start that problem, obviously erupts.
It does happen, we know. I know it's easy to sit here and talk about it, but on a ground level, I'm sure we do face it. In fact, right now I have a patient whom we are facing the same problem. Fortunately, she's getting better. But we have to look at ways and means to help them. If I'm not crossing my boundary, I think we should have this program even active in the public hospitals, what I would say. Because, finally, if a good public system is available, then a lot of these things can be done there. I think that is where I would say the balance would lie between money and no money. Yeah, right.
Audience side, did you face any situation where you need to change the circuit on an emergent purpose?
Yeah, we have had one occasion when it has happened, but generally it is predictable. It's predictable. So see, so the patient has to give us that 1 minute sort of window. So what we do is we keep the prime circuit ready, and then of course make the switch in that 1 minute. But during that time, we take them on full ventilation, whatever. But often enough, they would give us that time, unless there is one occasion we actually had the machine conk off and there was some problem, and immediately we had to make a change. But that's what. But that problem in VV ECMO is probably not much of a clinical concern. In VA, of course, it will be a big concern. Yeah.
Thank you, sir. Thank you very much, and we will conclude this session here. We are still say a lot of things, and we will still workshop also is there, and any of speakers are here. Thank you.
Thank you, sir, for that comprehensive and insightful presentation. Your talk has truly enriched today's academic session. For the next topic, I would like to welcome the chairpersons onto the stage. Dr. Dilip Kumar, sir, Chief Cardiac Surgeon, Manipal Hospital, Vijayawada. Dr. Kola Srinivas, sir, Chief Cardiac Surgeon, PSIMS. And Dr. N. Sandeep, sir, Senior Cardiologist, Manipal Hospital, Vijayawada. It is our honor and privilege to welcome Dr. Devananda MS, sir, a towering figure in the field of cardiothoracic and vascular surgery, as today's speaker. Dr. Devananda, sir, is the head of cardiothoracic and vascular surgery at Manipal Hospitals, Bangalore, with an illustrious career spanning more than 28 years. He holds an MBBS from Karnataka Medical College, MS in General Surgery from Seth GS Medical College, and an MCH in cardiothoracic surgery from the prestigious Sri Chitra Tirunal Institute of Medical Sciences. A pioneer in heart and lung transplantation, aortic surgery, and complex congenital cardiac procedures, Dr. Devananda, sir, has personally performed over 10,000 open heart surgeries and more than 7,000 pediatric and adult cardiac surgeries, including India's first successful open heart surgery on a 29-week-old baby. He has also led landmark interventions in ECMO transport and support, including transporting a patient on ECMO across 450 kilometers by road at an extraordinary feat, demonstrating his dedication and expertise in critical care cardiac surgery. Dr. Devananda sir has contributed to several national and international journals and is a regular speaker at conferences with media-recognized talks on rare cardiac surgeries, heart transplants, and innovations in pediatric cardiac care. His accolades include the Rotary Centenary Award for Vocational Excellence, and he is a founding member of the World Society of Pediatric and Congenital Heart Surgery. Please join me in welcoming Dr. Devananda sir for his talk.
Thank you. Fine. I'll use this, I think. Thank you very much. I think some of the talks, which I'm going to cover is going to be a kind of overlap. I think most of the things about ECMO, what is required, is elegantly put by Sunil. And some of which I think it's going to be again repeated by the next speakers as well. All we should remember is we have a body called ELSO, most of you are aware. A body which started in 1989, which basically records, it's a registry of all the ECMOs which are reported from across the world. Now today, 2024, there are I think close to 2.5 lakh ECMOs. So whatever we are speaking today, whatever we are practicing today is a kind of offshoot knowledge which comes from analysis of this registry. That's point one. And point two, the outcome has been excellent. I think more than 124,000, that's 1.25 lakhs of survivors out of this 2.5 lakh, which is almost amount to 51 or 52%, which speaks about the success of this ECMO. If you institute the treatment properly, well within time, I think we can still save many lives. Now, having said that, we owe it all to these two great persons. One in the white and black picture is John Gibbon, who invented the heart-lung machine, early 1930s. Again, it was a kind of a passion, or whatever you call it. He saw a young lady dying of pulmonary thromboembolism. He thought if only we could keep her alive for a few more days for clots to be busted or whatever, one or the other way we can treat, she could have been saved. And that's the beginning of real cardiac thoracic surgery. He went on next 20 years, he worked and developed the heart-lung machine with which he did the first open heart surgery in 1953. So that's the beginning of this concept of extracorporeal circulation, a heart-lung machine. And next, I think most of you know Dr. Bartlett, Robert Bartlett from Ann Arbor, Michigan. He is the kind of considered as father of ECMO. He is again, I think, inspired by keeping a young man with the lung injury alive. He started his first ECMO in 1972, then 1975 in a child. I think then ECMO went behind, but he continued to work in Michigan, Ann Arbor, developing various aspects of ECMO which we practice today, whether it is tubings, coatings, different kind of oxygenator technology, working with the industry. He's still alive. I think a large contribution from him, and even this ELSO Society is his brainchild. Now with with this introduction, I would say anybody who wants to start the ECMO can start the program. It's not a rocket science. It's something which is done across the world. There are more than 800 centers who are reporting ECMO results to the ELSO registry, including one from the Manipal HL Road. It's the interest which is most important. If you want to start the program, you should be genuinely interested in it, not the other aspects of it because somebody else is doing, we want to do it, is not the question. You should be really interested because ECMO does save lives, number one. Number two, commitment. Like these two gentlemen, they were committed to the cause, and this is where we are. So if you want to take the program forward, there has to be a commitment in the sense because ECMOs might have to be put in the middle of the night. Your decisions may come anytime. So you should be ready to get out of the house at 1 o'clock in the night and put the patient on ECMO if need arise. Or sometimes when you put these ECMOs, they bleed, they give trouble. You should be able to be there to solve the problem. And only then with time you will reach a point where it goes on kind of autopilot. Building a team around is again important. As Sunil already said, it's not one-man show. There are several components you have. I'll show you the slide. You just cannot put an end to that, but there are some people who are core and there are many who are going to support. I think everybody is important. As it is said, the strongest chain is decided by the weakest link. You should remember that. Every member of the team should be good enough, or if they're not good, we should pull them up to that level. And resources, again, that question somebody is asking, the cost, it comes to, again, resources, how we are dealing, what is that individual hospital commitment to the program is absolutely important. When you are taking, probably there are areas where you have to let go with the money. As the question came, you treated a person, for example, 2 weeks, person is improving, but he's run out of money, what you're going to do? Your hospital or your center probably should be in a position to absorb that money, end of the day, see to it that the patient goes home. And probably he will bring in another 5-6 patients, your money eventually will come back. But if that kind of support or resourcefulness or commitment from the admin is not there, ECMO program is going to take a problem. When we started, if I remember, 2007, I keep on telling this, our very first ECMO, those are the days only Medtronic used to make the machine. We had this huge bulky silicon-based oxygenator. The first patient whom we put the ECMO was a second-year PU student who failed, and father scolded. This fellow went and took all his antihypertensives. He was in a vasodilatory shock. Who came to the hospital, showed in 2 cannulas into the groin by a cardiologist, Dr. Subhash Chandra. I do not know how many of you know about him. He's no more. We went on with that ECMO and we kept him alive. 2 days later, we could pull him off the ECMO. Those days we had no concept of distal limb perfusion and all that. This boy survived, but we had to do an AK amputation for him. So that was in 2007. I think until that time, 2013 or 14, Sunil may correct me if I'm wrong, most of the ECMOs are all done for the cardiac purposes. Most of them are VAs. I think the interest in VV in our country came somewhere around 2014, 2015. We started using that, and now today we are here. And that's the team. I think this is not just the members, your intensivists, nurses, surgeons, perfusionists. Most important people of our team, I would say, are the perfusionists, who are the one who are going to probably, who have the maximum knowledge of which oxygenator to go with, which cannula to go with, what would be the adequate or appropriate flows that's going to be required for the patient. And those are the people who are going to sit on this ECMO 24/7. Even today in Manipal, having done so many ECMOs, one perfusionist is always available inside 24/7. No matter ECMO runs for 10 days or 20 days or 50 days or 100 days. I mean, these are the commitments you have to give in to see to that the program succeeds. Indication was said by Bartlett himself very clearly, and this has been again said by everybody. It should be put for an acute and severe cardiac or pulmonary. This is reference to the basically MVA I'm talking, who is unresponsive to all your conventional therapy. You should have exhausted everything that is possible. There's nothing else. But there should be a potential for recovery. If there is no potential to recovery, there is no point in putting them ECMO, because only kind of delaying the declaration of death, nothing more than that. So if you want to have successful outcome, you should foresee that. Rarely, yes, today since we are doing transplantations, it can be a kind of bridge to the transplantation. So these are all some of the scenarios which we ourselves had in our own ECMO experience. Commonest in the beginning used to be post-cardiotomy, adult, child, wherever you go, you do a surgery, patient is unable to come off, bypass, 1 trial or 2 trial with optimal inotropic support. Earlier days we used to go on increasing adrenaline, noradrenaline, whatever we wanted we went on. When you bring them out, somehow purging and stuff like that, only to have them dead after another couple of more hours in the ICUs. Now we have learned that early institution of ECMO, you give them a couple of days, those hearts are going to recover. So that's where I think the huge part of this ECMO experience in the first 1 or 2 decades came from. Post-acute myocardial infarction with shock, many of the myocarditis, whatever may be the etiology, it could be viral myocarditis, it could be postpartum cardiomyopathy, various kind of this myocarditis. Poisonings as Sunil has already said, aluminum phosphide. That is how we started ECMOs in our MICUs. Our earlier ECMOs was for poisonings. Luckily, I think 2 out of 3 went home, and that is where the whole scenario changed. Septic shock. We have not done too many, couple of them. Yes, septic shock, there is a role if you catch these patients little early, not when they've gone into the cold, irreversible shock, mottling appearing. There is no point in putting these patients in ECMO. They are now going to come around. They probably would last next couple of hours and they're going to die. Decompensated chronic heart failures. These are some of the patients, some of them will recover, some of them will become kind of bridge to decision making, what to do next, or some of them will go in the transplant or LVAD line and stuff like that. Support, like difficult PCI, very tight left main, right is completely gone, borderline heart function, cardiologist wants some time, so we can give ECMO support to them. Tracheal surgeries, we have given supports. Whenever we are doing tracheal surgery, you do not want a tube around, very long segment tracheal reconstruction. You can put these patients in ECMO and do the reconstruction and get on the via ECMO. Neonates, whether it's for lung reason or whatever heart reason, we have used it for 4-5 situations, including cardiogenic shock, to meconium aspiration, to intractable arrhythmias in a newborn. So all these indications we have done the neonatal ECMO. Probably I think neonatal ECMO is the best outcome, especially in the set of meconium aspiration or PPHM. ECPR is something which is coming up now. We have done only 1 or 2, but I think ECPR is completely a different chapter, even for us who are so well versed with the ECMO. There are many other commitments which have to come, like what should be the timeline when you want to initiate, who is going to initiate, the team members, then the costing, because some of these patients you may be able to explain the cost, may not be able to explain the cost. Is institution going to be committed? So that's a chapter by itself. So ECMO is one thing. In VA or VVA as a timing is very important. You have the indication, but at what time in that indication you should put the ECMO is again something which you should learn, and something has been defined, something we'll learn with time. It should not be a terminal event. Note that event. The sentence is very important. Is you have done everything and you don't know what else to do, you just put him on ECMO. I want to, because I have not told the relatives that he is sick, I want to buy time. And that's what used to happen in the beginning. That's why ECMOs were put so awfully, results were bad. Because it was pushed just as a postponement of death. That's not the way it should be. You should know when exactly to put that. So it should be a part of the planned approach. You should have your own algorithm. This is what we're going to do. This is what we're going to accept. And beyond that, we are going to put ECMO electively. If the ECMO is going to be relatively elective, your results are going to be far better. And it's again, it's better when it is a single organ domain, either heart or lung, or at best heart and lung. His kidney is gone, his liver is gone, you're already facing 2 or 3 organs, the results of ECMOs are going to be down. So various sites can be used for VA ECMO. Sunil again said that in VV context, in VA context, we can now, you can draw the blood from one of the venous source and return the blood back to the arterial. So we can draw the blood. Commonest that is done across the globe is femoral. You draw the blood from the femoral vein and put it back to the femoral artery. Followed by, you can use axillary. You draw the blood from either jugular vein or the femoral vein and return the blood back to the axillary artery. Either direct cannulation, or you can use a small tube stitched to that and you can cannulate the tube. We can use the carotid. In newborns, I think that's the way to go. You always use, draw the blood from the IJV and put the blood back into the carotid artery. Central ECMO is what generally is used in surgical context, because chest is already open, so we generally convert it into ECMO by putting cannula, continuing the same cannulas into aorta and the right atrium. But again, central ECMO is sometimes we use in dire emergency. If somebody is in deep shock, you are not able to feel the pulse, patient is laterally cold, and that's the time you have to initiate ECMO. There is no point in trying any other vascular access, because everything will be under spasm. You will create much more damage. It's better to go with the central ECMO. Another area of central ECMO probably bit controversial is wherever you require a very high flow. Like say, for example, somebody in septic shock, you know that they're vasodilated. You cannot run the ECMO with even 3 liters or 3.5 liters or 4 liters of flow. You probably may require 5 liters, 6 liters of flow to maintain the cardiac output. So the best and the safest way, you can put any size cannula you want. So central ECMO may be the better. So also on smaller children. Children who are 10 kilos or 15 kilos, I think central ECMOs are far more safer than trying to meddle through the peripheral vessels. These are different ECMO sites. I'm sorry for these ghastly looking pictures. They're not that bad, but I think this is central ECMO in a child. The next one is actually a child, newborn, who has got a carotid cut down and neck cannulation. The last one is how we stitch a small graft to a femoral artery or an axillary artery and cannulate the graft so that there is no distal limb perfusion, or you're not bothered too much by the size of the vessel as such. This is how a groin ECMO looks. The first one, where you have the venous and the arterial return cannula, and the other limb, small limb which goes around, is for the distal limb perfusion into the superficial femoral artery. And the last one is central ECMO, where you see the 2 cannula, one is venous, one is arterial, and the third one is a vent. We will come to that a little later. This is that newborn who was on VA ECMO. In fact, this is the kid, lightest kid, weighing at around 1.9 kilos. Karthik would remember that. 1.9 kilos to go on successful ECMO and come out of the ECMO, which got even published. Because now below 2 kilos of weight, it's a relative contraindication to put a child on ECMO, but this kid made it. So cannula selection, again, Sunil has said that, you remember that. Frenches, whatever you see, 0.33 millimeter is 1 French, and that's the external diameter. That's the most important thing to remember. As I said, makers to maker, the thickness of the tubing changes, the cannula changes, so the ID of one need not have to be the ID of the other in the same given French. So you choose the best cannula and use the shortest possible length of the external tubings. Longer the tube, longer the pressure differences. So use the shortest possible length. Obviously, it should be functional. You want to shift the patient from cot to the say a CT or something else, it should be possible. Don't make it too short that you cannot move the patient. But within that limitation, there is no big advantage of keeping meters of tube thinking that that's going to be much easy. That's going to be damaging. So it's much more important, the cannula sizes in the arterial cannula compared to the venous cannula, because venous cannula anyway are larger. This again is showed. All you have to remember is why 17 French is far superior to say 15 French. Because of the size. It's R raised to the power of 4. You can remember, you increase by 1 millimeter, it's exponentially increase. The flow increases or the pressure drops. So every millimeter you work around the cannula is very, very important. That's all I would say in this most important thing. In some of the VA ECMOs, like when we are cannulating a limb, this is very important. As I told you from my very first experience, first fellow's leg we had to cut. We had those days no concept of distal limb perfusion. We thought you put the cannula short time, nothing will happen, collaterals will take over, nothing will happen to the limb. We were wrong. Yes, if the cannula is small compared to the artery size is 10 millimeter, you are putting say 15 French cannula in that, probably you will have enough space for blood to go around the cannula, you may not face it. But often the average femoral artery we see is around 6 millimeter or so, and you are putting 15 or 17 French, which snugly sits into the cannula, you probably will land in trouble. So distal limb perfusion is very, very important. If you cannot do that, you stitch a side limb to that and cannulate the side limb so blood will go in either direction. What is said, use of ultrasound in across this, whether you are putting the cannula or later you are looking at the recovery of the heart or even to some extent lung, ultrasound is very, very, very important. it's better not to do these procedures, including cannulation, very blindly. We have burnt our hands in the beginning. When you pass the guide wires have come out through IVC or a junction. And in the ICUs, we have to open the chest. So we have gone through all possible complications, not that we have come to this stage without pain. So it's better always to use the right guide wires. If the guide wires are not good, your dilators are not good, please discard them, use the safest one. Trying to save on a little bit of money can cost a life. So I would say cannulation is at most important. You do a good cannulation, good positioning, half the job is done. Because the rest of the half is going to be done by the perfusionists. Venting is another important. This is very specific to the VA ECMO. Venting only means that you have to decompress a dysfunctional ventricle, a ventricle which is not having enough strength to contract and put the blood out. You do not decompress it. It distends because you're giving a pump flow there which will not allow the aortic valve to open because of its pressure. And the sick ventricle is unable to push and open the aortic valve. So ventricle distends. The moment the ventricle distends, your back pressure, patient gets into pulmonary edema. You will start pouring blood out in his ET tube. So that should be prevented for both. One, to prevent the pulmonary edema, and number two, umpteen number of studies are there. You vent the heart, recovery is going to be much, much higher and much faster of the ventricle. So they have to be vented. You put a cannula into that. There are various routes we can do it. Either surgically we can put them, central, there is no issue in putting. If you are putting a peripheral ECMO, you can make a small cut either right or left, and there are various ways of putting the vent into that. It can be done non-surgically also. A cardiologist can put a catheter across PFO into the left atrium, or he can create a rent like we create during balloon dilatation of the mitral valve, create a hole in the intra-atrial septum and put a catheter into that. All that will help. You can put a catheter into the pulmonary artery, you can decompress these ventricles. Now the current thing, you all know that Impella is available, which is an axial flow pump which can be put percutaneously. I mean, even that is used in many centers abroad. Here cost is the constraint, so we don't use that, but it can be used to decompress the ventricle. You put the Impella pump into the left ventricle, it pumps out the blood from the left ventricle. Now they use this funny term, ECMella. We use ECMO with Impella, that becomes ECMella as one of the ways of venting this. Simple IABP in a kind of contracting but not very powerfully contracting ventricle. IABP itself can ask a venting method. This is the commonest thing, FEM, because it's very simple, easy, reproducible. Even middle of the sleep you can do that. The only thing you should remember is it's a retrograde perfusion. You are not flowing forward antegradely. You are going reverse way. Can sometimes cause differential perfusion. Saturations below may be better. Saturation in the upper segments could be less. And that becomes very important as the heart recovers. When the heart ejects, if lungs are still not ready, you are going to get impure blood into the heart, and heart is going to pump out the deoxygenated blood, which is going to perfuse the coronary circulation as well as the cerebral circulation. Some of these patients can land with brain damage. Their heart function need not have to improve. Seemingly it was improving last 3 days. Again it started deteriorating. It could be that your lungs are not ready and heart is getting ready. It's pumping deoxygenated blood. It's called as North-South syndrome or Harlequin syndrome, whatever it is. So pure blood will go up to there. Arch and other things are all kind of getting deoxygenated blood. That's not very good. If you recognize that early, how do you recognize that? That's the best way. If you have a femoral VA ECMO, it may be prudent to have a right radial line for monitoring. If your right radial oxygenation is low, your post-pump oxygenation is better, then probably you will do sampling from the other side to see whether this patient is having North-Side syndrome. If that is that, you can create another venous return into the IJV, give more oxygenated blood into the RA. So that is one way of prevention. Or the other way is you change the arterial return itself. From the femoral, bring it down to the axillary or whatever you want, so that you save the brain and the heart. So a whole lot of things we need to manage: anticoagulation, temperature management, flows, sedation. How do you manage this access site? How do you keep it clean? Ventilation, inotropes, nutrition, CNS. There's multiple aspects. I think all these aspects, I think those who want to start, sit, write down and have a plan for everything. That's the best way to go and establish a very practical program. Everything should be defined. This is how we are going to about anticoagulation. This is about temperature. Temperature is important only when, see ECPR for example, or any patient who had a cardiac arrest, we revived him, we got the circulation back, but heart is still not coping, we want to put him on ECMO. These are the patients who may get benefit by inducing hypothermia for a day or two. You can get the temperature down to 34 or 33. Definitely beyond 32, it may not be advisable because heart will fibrillate. So just short of that, you can bring down the temperature so that brain recovery can be slightly better. Otherwise, normothermia is the way. These are some of the complications you may come across. Bleeding. Sunil said yes, especially VA ECMO bleeding can be an issue. It can be site-related bleeding, or those patients who have gone on pump already into coagulopathy, you convert them into ECMO, they are going to bleed. Many a times we bring these patients without chest closure, open chest for a day or two, only when we are happy, coagulation is all kind of relatively normal, not much of bleeding. Take them back and either you wire them temporarily or close, whatever you want to do, you can do that. But do everything. Every effort should be done there to achieve clear hemostasis. I think earlier ECMOs, if you remember, I think we used to have disaster, re-exploring the same sites 5 times, 6 times. After that, the skin won't be healthy. And it can be a nidus for infection. So achieve the hemostasis, whether you want to use the bioglue, you want to keep the pressure, you want to address the coagulopathy, all put together, patient should have dry cannulation site. Very important. And initially, if the patient has coagulopathy, there is no need to give any heparin, nothing. Next 2 or 3 hours, just don't give him any anticoagulation. Leave them. Let them start clotting a bit. Let the ACT come down, 130, 140. Then you start using the heparin and other things. Nothing will happen in 2 to 3 hours. We have seen that. Intracranial bleed can be a major complication. One or two patients, I think we did have interim intracranial bleed and you have to terminate the ECMO. It's a common complication in newborns. So one should be extremely careful. These kids have to be, you do the intracranial ultrasound practically every single day, at least couple of days, until the platelet count stabilizes. Otherwise, we can land in bigger trouble. DIC, hemolysis, should be managed in the usual line. Renal insufficiency, yes. Good number of them, almost 30-40% of them will require one or the other kind of renal replacement. Limb ischemia, as I said, one should watch for. There are various ways. If you do not put a side limb into the distal perfusion, you can today, people use NIRS to see the calf muscle flow. One can use ultrasound very frequently to see non-pulsatile flow in these vessels. So, or even saturation, you keep monitoring the saturation. If saturation is good, limb is warm, it's fine. If it is not, patient is developing compartment, you have to put distal perfusion cannula. Sepsis, as I said, is something which some of these patients die with. And the last complication I saw first time after so many years, aortic dissection, and that lady she became paraplegic. I think she's still coming for, correct? With you. This lady had mitral valve repair, uneventful, but I think something to do with the myocardium or myocardial protection. LV wouldn't come off bypass. We had to put her on ECMO. 5, 6, 7 days. I mean central ECMO, so sedation. So we could easily wean her out. She came around, and when she allowed to wake up, she wouldn't move the legs. Same day itself, we did the MRI. This lady had huge intramural hematoma of the aorta, like type B dissection, and that was the cause of her paraplegia. So I think you keep on learning, you keep on seeing complication. So that is the only aortic dissection I have seen with so many ECMOs, but it can happen. Flows, as I said, I think will be kind of decided like most of the surgeons, we know how we decide the flows. But having said that, if a patient again is tremendously under shock, very low ejection fraction, or very deep shock like lactates of 18, 19, 20. So these are the patients you should initially go with full flow, whatever best you can achieve. You can even use little bit of dilator in this situation to get rid of this lactate and other things. Once they stabilize, heart function is slightly better. It's better always to keep the flow slightly less than what is required so that heart keeps ejecting. And if you vent these hearts, it's very good, but even then, no vent which we put from here, short of the LV apical vent would completely make these ventricles decompress. So it's better to keep this heart ejecting a little bit. So you'll see the pulsatile flow on the graph. MAP and other things, yes, you titrate it for a particular age. In an adult, probably 60 should be okay. In a child, around 40 or 50 millimeter of mercury should be more than adequate. Saturation of around 90-95 should be more than fine, and mixed venous saturation is most important. So overall, I think more than the pressure, as cardiac surgeons, we say that it is the cardiac output which is much more important. If cardiac output is okay, patient is warm, making urine, all the pressures are acceptable. Higher flows sometimes are required in veno-venous when you are not achieving the saturation. And as I said in the beginning, septic shock probably you may require higher flows. Inadequate return to the machine. There are only 4 reasons you can think. Cannula malposition. Sometimes these venous cannulas can suck the surrounding either IVC wall or right atrial wall, and it may not drain completely. That is where our cannula selection comes into picture. Multi-holes like 1 stage or 2 stage, whatever, just not the end-on hole cannulas. So multi-hole side holes, and those are the kind of cannulas we should go with. You just reduce the flow a little bit, allow the structure to fill, it will disengage, it will start draining better. So cannula position or kinking, tubings can kink sometimes. Position changes, return changes. These are all, I think, much more common in central VA ECMO than in the peripheral. Inadequate circulatory volume. You have kind of dehydrated the patient, not much of volume is coming to the pump. You see the pump chattering, so that means patient, if you rule out other causes, you probably have to give the volume, then patients will be better. Tamponade. If cardiac tamponade is there, like any other tamponade, venous return decreases, again the pump flow can reduce. Pneumothorax. Positive pressure inside the chest, I think, again retards the venous flow, so your pump return again becomes less. So these are 4 or 5 causes. Moment you are not getting flow to the pump, these are the things you should look into. Anticoagulation, as I said, again, we are all very comfortable with heparin. So that's one which is often used, and the standard practice is we give the bolus initially 1 milligram, that's 100 units per kg, and later probably titrate it, 20 to 30 units. Any VA ECMO, 180 to 200, we would say, especially if you have a distal perfusion cannula, distal limb perfusion cannula, because it's a small cannula, generally 8 French or 10 French can easily clot off. So it's better to keep the blood slightly thinner. And again, that becomes important as you're weaning. When you're coming down on the flows, it may be always better to keep the ACT slightly higher. I mean, it's a debate kind, ACT is better, APTT is better. APTT is slightly more sensitive, but I think it has this problem that we can't do it bedside. You have to send the samples to the laboratory every single time. So we generally rely on bedside ACT. HIT can be an issue as you use this heparin, the type 1 or type 2 kind of reactions. Typically type 2, day 4, day 5, thrombocytopenia persisting or even going down. You do the panel, if it is positive, switch over to bivalirudin. It's much easy. We have done at least 5 or 6 open heart surgeries using bivalirudin. Those who had HIT, I think they all do well. We have no experience with ergotroban. Bleeding, another thing I said, it's better to do the platelet count every single day, initial couple of days. Only when you're sure that they are in the increasing trend, they've crossed 80 or 90, there is no issue, then probably you can repeat it once in 2 days or 3 days if there is no bleeding. Whereas newborns, just be rigid on that and head ultrasound, as I said. Sedation, again, Sunil discussed, yes, this is what we used to do with most of the central VA ECMOs. Obviously, the cannulas coming here, even though we have extubated some of these patients, but that's not a very common fact, most of these patients will be on some kind of sedation. Those who are very comfortable, we know that preoperatively how apprehensive they were, or their background, multiple things will go into the decision making. when to extubate this patient even though they are on via ECMO. These are all the kind of thing. Ventilation, again, do not neglect ventilation just because you're in VA ECMO. Ventilation is very important. There were a couple of patients where heart became better by the time lung got into trouble. So you're ready to come off bypass on day 6, day 7, but your lungs are gone. So that should not happen. That only shows that we were not giving importance to the lung when we were on only looking at the heart. So don't look at heart, look at heart and lung as a whole. So whatever that needs to be done for the lung, near conventional lung protective ventilation is a must. Change of positions, turning the patient, and if need arise, these patients can be proned also. A couple of patients we have done that also. Inotropes to be kept minimum, nitric oxide in some of these, especially newborns and those patients who have got PAH issues, we can use, or some of these lung transplant patients, we use the nitric oxide when required. And enteral feed, start all the supportive therapy as early as possible. There is no contraindication to start enteral feeding as early as you can. Moment the bowel sounds are there, day 2, day 3, you can start feeds for these patients. This is one of the child who had a VA ECMO central, who was prone because lungs are bad. Eventually went home but took a lot of time, 3 weeks or so on a VA ECMO. So diuretics can be used, try to keep this, they tend to accumulate fluid, these patients, whether it's VV or VA. So use albumin when required, don't have hypoalbuminemia. Diurese them well. If they're not responding to diuretics, use the replacement, whatever, peritoneal dialysis in small children, hemofiltration, hemodialysis, everything can be used. These are all the same thing. Again, our tendency in VA is to keep the hemoglobin around 10. 10 to 12 in newborn is fine. Platelets around 70 to 80,000 definitely. In children it can even a lakh. Renal functions based on the clinical scenario. Initially we do once in a day or two. Once we know that everything is stabilized, urine output is good, no issues, maybe once in 3 days or once in 4 days. LFT probably once in 4-5 days. Blood culture, this was our old protocol. We always used to take the blood sample whenever we are putting them via ECMO. Now our protocol is day 4 or day 5. We electively tend to do a blood culture just to make sure that there is no infection. So these are all the things which will help you to prevent infection. 1:1 or sometimes 2:1 nursing may be required. A child is or a patient is in multiple support therapy. He is on dialysis, on nitric oxide, he is on ECMO. So I think you probably one nurse may not be adequate. You probably have to allocate 2 nurses. Again, these are all kind of institutional policies. For us, VA ECMO, especially if it is central, we tend to give them broad spectrum antibiotics and alternate day dressing change. If not alternate day, at least once in 3 days, this site dressing, wherever cannulas have been put, should be done. That's mandatory. Otherwise, organisms will colonize and we will have infection. I think weaning is standard. Once lung is ready, heart function is decent, 25 to 30% ejection fraction, we can start weaning this. I think Karthik is going to talk extensively on weaning strategies. With that, this is our experience in last 10-15 years. We had close to 301 ECMOs, of which if you see majority, 2/3 were adult, 117 were VA, 91 were VV, and pediatric ECMOs were 88, and that's our mortality. In the VA segment, between in the VA, we have lost around 75 patients. That brings down our survivability there to around 40% or so. Whereas in pediatric, outcomes are excellent. It's almost close to 60% survivability. In 5 or so VV which we had, we have lost 1 patient. The other 4 have gone home. So these results are not bad. When you look at the registry, the outcome which is averaging around 50, we are somewhere around there. Some places we have done better and some places not so. So thank you very much. Are there any questions for me?
Any questions from audience?
Yes.
Hello, sir. Based on your vast experience, I just want to ask you, if we initiate a patient on peripheral VA ECMO for cardiogenic shock, what is your take on changing into central VA ECMO, and what is your experience, sir? Mainly to decrease the afterload. So, and which patients? What is the criteria like?
We have both the way. One, we have gone with the intention of putting a peripheral ECMO because we didn't want to open the chest. We have seen arteries were such small, bilateral cut downs, not happy. On the site itself, we have moved to the central ECMO. That's one situation when you are in very severe shock. We have gone through that. So that's the reason I said in the beginning, if somebody is in very severe shock, better not to try the peripheral ECMO at all. Go to the center directly. You will save time. Number two, we have taken out because of limb complication despite a distal perfusion cannula. One odd, I think I can remember the patient, I think for reasons unknown, whether it's part of sepsis or part of whatever, she developed kind of ischemia in the same limb with a distal limb perfusion. So we have to remove the cannula and switch over to the central VA ECMO. These are the only two or three patients I can remember where we had to switch from peripheral femoral to the central.
Yeah, why I asked the question is we had a similar situation at our hospital. Actually, we placed on a peripheral VA ECMO. We placed a 8 French distal perfusion catheter. In spite, as it is being a non-pulsatile flow, the second day also we checked the flow, everything was okay. The saturation was okay, but later on, patient developed limb ischemia. So
can be seen because young patients fine.
And in your slide, sir, actually, I wanted to ask you what the distal perfusion cannula you use, sir?
We use the same 8 French neonatal aortic cannula generally, or 10 French neonatal aortic cannula for the distal limb perfusion. Rarely we use PA catheter sheath because it's easily you can put it on a wire and put. Now we have catheters, these neonatal aortic cannulas, which can be put on a guide wire. Earlier we never used to have. So we used to dilate and then blindly gently put it without a guide wire. So that's not the right thing to do because you may damage the intima. That could be sometimes problem where you see after a couple of hours or 1 or 2 days later thrombus develops and you are in trouble. Limb can be in trouble. So I think these things are very simple provided we stick to the basics. No damage will happen. But yes, ischemia, you change the cannula. There is no point in trying to meddle around, trying to do embolectomy, do all that. So better not to. Because patients, we have seen by experience, even if they survive, if they lose limb, they're never going to pardon you. Dying is fine, but not losing limb.
Sir, good morning, sir. For VA ECMO with cardiogenic shock following myocardial infarction, do you consider ECMO as a first strategy or do you consider Impella? And what are the merits and demerits?
No.
If you have both options.
If you have Impella is far simpler. And if you have the other one, the higher version which gives you 5 liters, 5.2 liters, and you have expertise to place it, it's very quick. You probably can do that in 10 minutes. And a cardiologist who can do an angioplasty can place that, I'm sure within 5 minutes or so, you can get across to the aortic valve and put the Impella. So if you have Impella, I think Impella is definitely preferable because the cost. 25 lakhs if you're able to shell out.
Duration of the therapy?
Impella can be kept for a week also.
Sir, is the IABP by default we have to put or we have to wait for the LV loading? We have to wait till we get the parameters of the LV loading, then we put the IABP for VA ECMO. The indication for IABP is a default or only you have to...
IABP can be put provided heart is not very bad. See, your ejection fraction is around 20%. It is not very mildly distending. You can add that as a support. Or you are in a place like one of the patients whom we shifted, I said that from our university, Manipal to Bangalore, via ECMO. He was an Israeli who got into acute viral myocarditis, no relatives and language barrier. We couldn't communicate to him. He was already on a IABP when we went there to retrieve him. Now what do? That was a Sunday, if I remember, when we went there. Their embassy is closed. We have no connection with them. So we're trying to help him. If he dies, we will be in newspaper. So we decided we will do the groin VA ECMO under local. So we did ECMO under local. We did not remove IABP because to put any central cannulation on a Sunday in our university where nobody was around, it's very difficult. We left that as it is. Whatever help it does, it does. But by and large, if you ask me, is this the best way to unload the ventricle? No. Nothing like putting a direct cannula into the ventricle. Venting the heart is the best way. If you do not have facility for that, or probably emergency, you put this 3 o'clock in the morning, they have called you to put a VA ECMO, you put the VA ECMO, you don't want to take him to theatre because this requires theatre. You have to shift the patient to the theatre and put a vent. Unless your cardiology colleague is ready to come and put a catheter across. So you can probably get away till morning with a balloon, then you think what you have to do. Sir, but that is not the first choice.
Sir, regarding this ACT, where you should take the blood sample? Because following PTCA, sometimes the sister will take from the sheath, or it is from the peripheral venous axis or peripheral arterial axis. Is there a difference in taking the blood sample for the ACT?
Not that I am aware of. We generally, I think our center, either they take it from the central line or they take it from the art line. By and large, they take from the art line. Ilayaraja is here? No. By and large, we take from the artery line.
Is there any medical conditions that...
No. But as Sunil said, yes. In a day, these values can vary. Suddenly, it will give you 140. And same insulin is going. Evening, when you repeat it, it will say 200. This kind of variation sometimes are seen with the ACT. That is where APTT is more sensitive.
For angioplasty, we maintain above 250. But ECMO, and we remove the sheath if it is below 170. But for your ECMO, it is like 170 to 200.
That's because, as Sunil said, these are heparin coated. The entire circuit, cannulae, tubing, oxygenator, everything is heparin coated. So the chances of clot formations are slightly less. And when we prime these things, we also again additionally use albumin. Initial priming so that coats a bit. So by and large, it's okay. We have not seen problem with that. So maintain around 180, 200. We go above 200, 200 to 225 or 230 only when we are weaning them below say 2 liters. The flows are less than 2 liters or 1.5 liters. We increase the ACT to some extent.
And while decannulating, do you use vascular closure devices?
Come again?
While decannulation, do you use vascular closure devices? Angioseal or Proglide?
No. Most of these are put by open technique. We can put through both open or closed technique. If it is closed technique, when you are decannulating, we open and stitch. For surgeons, I think that's the easiest. Otherwise, yes, today we can go per close or something we can use and close it. It's not a problem. I mean, today it's possible to remove the cannula and put the per close and close it, or the other device which is coming now, isn't it?
Thank you.
Sir, what is your experience for a VA ECMO if you are going on a peripheral cannulation and need of LV venting? Is it by default for a cardiogenic shock?
Cannulation and?
Peripheral cannulation, VA ECMO, and LV is distending. What is your, how many cases? Almost all cases? Or
LV venting you're talking? No. If heart is ejecting well and on the echo, see we use echo extensively, whether echo is a patient is with us or patient which is the MICU, echo is something which is used left and right. So if your heart is not distending, that means it's opening, aortic valve is opening. So in that case, there is no point in giving huge amount of flow, creating too much of afterload for the ventricle. You try to keep the afterloads. Instead, if the full flow is say 5 liter, you probably give 3.5, so that you will allow the heart also to open up the aortic valve and eject. You give full flow there, a sick heart would never open unless you have vented it. So it depends on that. If the heart is reasonable, not very bad, you probably are okay watching. You do not have to put it up front, even though the best, if you put it, that's the gold standard, no doubt on that, venting. But many times, you have to make another cut. You would have put these patients on ECMO in the ICU, on the bedside. You have to ship them down to the OR. So their potassium may be already up. You want them to go through one cycle of CRRT or something. Only then you would want to take them. Otherwise, you do not want to have a cardiac arrest during the procedure. So all these factors will come into picture. I mean, that is what I say, you learn as you go. So, but if you can put a vent, nothing like it.
Sir, one
vent
more
improves the recovery. There are enough number of papers.
One more question, sir. If your patient is in a cardiogenic shock and diagnosed with triple vessel disease, but no time to do anything PTCA, so you connected the patient for VA ECMO. Do you bypass the grafts and during ECMO, or what is your experience?
No, such situation has not come, but you can do it. There is no issue. If you put him on the ECMO, all you have to do is convert that ECMO circuit into a pump circuit. All you have to do is add a reservoir. That's about it, and some suckers.
So, do you have any experience of doing on-pump, on
one
ECMO?
or two patients, yes, we have done that. You can convert them into regular this thing. When you make the circuit, you make the circuit in such a way that it gives you all flexibility. If you want to convert it into, based on the need, I'm telling, there is no point in doing that in a VA ECMO. In a VA ECMO, you can always, especially post-cardiotomy, you might have to, you got him out and maybe you have to take him back and do little more in him. Like for example, you have done a HOCM. It didn't come off, you put him on machine. And later the echo says in the ICU that you have to resect little more. So rather than putting another pump, if you have already designed your circuit in such a way that you can add the reservoir to that, you can still use the same circuit and do the surgery and come out. Okay, it's possible either way.
When you are on VA ECMO,
I mean, that's where I said your perfusionist is the most important fellow when it comes to VA ECMO. Nobody is more important than him.
So, if a patient is on VA ECMO, when do you consider this patient is yes? What are the indicators that no, it is the time to go for a VAD or a transplant?
Our general thing is, you all know that myocardium, best time to recover is around a week approximately. Most of the hearts, whatever could be the insult, whether it is myocarditis, whether it is post-cardiotomy problems, generally they recover within 7 days to 9 days or 10 days. Those hearts who do not recover 7 to 9 days or 10 days, their chances of recoverability is probably 5% or 10%, not more than that. So you have options there. So moment we see our patients of this kind of background, 7th day, nothing is happening, we want them. Like Sunil was talking about that poor lady now, postpartum cardiomyopathy. I think this Monday will be 7th day or so. If we don't see significant improvement in the ventricular function, we want them. Probably the escape route is transplant. And obviously you know that those who are on life support will get the super urgent listing and they are on the priority. So next heart will be allocated to them. So that is how we go. Not available, well, you carry on as long as you carry on, and yeah, somewhere it will end. Or if they are okay, finance is not an issue, we can, if lungs are okay, we can convert them into CentriMac, for example. You eliminate the oxygenator, you just give the RV and LV support. Then you can go on for 1 month, 2 months, 3 months, whatever that takes to get a heart or whatever exit pathway. So there, yes, money plays a role, no doubt on that. Because you know the CentriMac, they are a little more expensive, 5 to 6 lakhs of rupees for 2 pumpettes. So that would cost, and these patients are going to be in the ICU and all that kind of neuropathy, myopathy, so multiple issues. If they don't come around in this week to 10 days, they are looking at less survival, big bill.
Really enjoyed your talk, sir. I want to answer Manoj sir queries. Sir, in 2015 March we did the first ECMO in Vijayawada. This patient met with a very bad accident, road traffic accident. Sriman sir also there. Anesthetist is a senior anesthetist at Nagarjuna Hospitals and tried for 4 hours, also under ventilation, PCO2s 100, PO2s 30. So she doesn't know that there is ECMO available in Vijayawada. She was talking to the other anesthetist who is my friend, and we discussed that we purchased ECMO, and that patient, myself, and anesthetist rushed over there and shifted here and directly into the cath lab.
patients' attendants are forcing us to do that. Normally there is a different scenario. Children are at the US, you make them survive till that children come over here, and that same kind of things. Really, if you are properly do and if you have a good team and all, I don't think that it is always, definitely you can achieve even with our existing support up to 50 to 60% success rates. That's my opinion.
Sir,
one last question.
One thing to add actually. See, the problem is the timing of the initiation is very, very important. See, what Dilip has mentioned, all these are like early initiation. The problem is sometimes we get cases from the remote areas already on ventilator, and there is already sepsis has set in with multi-organ dysfunction. And especially the cardiogenic shock with sepsis or ARDS with sepsis, whether there is any cutoff, whether should go for ECMO or not. Because septic already there is vasoplegia. There is a peripheral vasodilatation. Whether to go for ECMO or not, is there any parameters?
No guideline as such. I think it's just that our experience end of the day should tell, because relatives obviously if they have money they will ask for everything. You do it. But as physicians at times I think yeah, we should learn to say no also. In the sense, if somebody is in deep shock, I think last week itself, Sunil's one of the patients, we refused. We said that no, they're gone beyond that, nothing is going to happen, no ECMO inside the hospital. So I think at times we probably have to refuse. Otherwise, two things. One, over a period of time, we will accumulate bad name. They put ECMO, no reason, dead patients also, they do anything. See, all these kind of things will start coming up. Better not to. We should tell them realistically, no, this is not the... I think we should draw a line there. It's a bit difficult to say. Clinically, I mean, that would come as you go on, as you see more, learn more. It's very difficult to put 1, 2, 3 criteria. But anybody who is in deep cold shock, bad septic shock, moved from warm shock to cold shock, I don't think those people would last, because they'll be vasodilated initially, then vasoconstricted later. So your pressures will be around 200 when you're running the ECMO, but no improvement. Lactates at 25, 30. So no CRRT, anything can eliminate that. And those are the patients who are going to die. There's no point in investing resources on them, I think.
So one quick question. In your daily practice, or would you suggest to go for a peripheral bilateral arterial Doppler to differentiate whether the distal perfusion is due to the iatrogenic thing we caused, or is a native disease already existing in the limbs? Would you practice a routine?
Patient had a disease, is it peripheral vascular disease?
Yeah. I mean, would you screen him beforehand, or is it not?
It's always, yes, it is always ideal, but many times not possible, practical. Yes, that's the truth.
True.
Because you're doing it middle of the night, it's a problem. In the daytime, I think you'll have 100 fellows to go through that and see all that. So that's the reason I would say one should be very careful when you're exploring. You explore the vessel, that's not a bad thing. I mean, obviously you want to put an ECMO for somebody who is 60 or 70. Obviously you expect some disease. There you should be extremely careful. You feel there is good pulse, there's good pulse femoral, there's good pulse dorsalis pedis. You probably think that it may be okay. But even then you should be extremely careful in passing your guide wire and dilators, or even the cannula after that. Any small resistance, ready to come back, call it off. Go for other paths. Or, if you have a big doubt like that, all you can do is put a side limb. If you think that local artery is healthy, you just stitch a 8 mm graft of Dacron or whatever, homograft piece, whatever you have, and to put a cannula into that. Venous is no problem. So, that's something which you can do. We will put a graft and put the cannula. If we have that issue, we are not going to push it through. And if there is no time to image him in any way, definitely we would go ahead, put a side limb and we do that. In center, in our center, we keep everything. You name it, we have it. We have been practicing that way, only then you can deliver the service. There is never happened that we never had oxygenator or tubing or cannula, anything of that kind. Moment we have some number that is depleting, we try to add that there. So I think keep some inventory so it will be useful. Thank you.
That was a very enriching session, sir. Thank you very much. And can you proceed to the next session?
I request Dr. Sunil Karan sir to come over the stage to accept our felicitation. And to present the memento, I call upon Dr. Uttam Sharma Garu, Medical Superintendent, Manipal Hospital, and Dr. N. Sandeep sir, Senior Cardiologist, Manipal Hospital. Request you to present a memento. Thank you, sir. I request Dr. Devananda sir to accept our felicitation, and to present the memento, I call upon Dr. N. Murli Krishna sir, Chief Cardiologist, Manipal Hospitals, Vijayawada.
Come back.
Thank you.
To mark the auspicious beginning of today's event, we shall now proceed with the traditional lamp lighting ceremony. I kindly invite our esteemed dignitaries onto the stage. May I request Dr. Devanand sir, Dr. Sunil Karan sir, Dr. Samavedam Srinivas sir, Dr. Purnanand sir, Dr. Y. Ramesh Babu sir, Dr. Uttam Sharma sir, Medical Superintendent, Manipal Hospitals, Dr. N. Murli Krishna sir, Cardiologist, Manipal Hospital, Dr. T. Srinivas Rao sir, Chief of Critical Care, Manipal Hospitals, Vijayawada. Please come forward and do the honors.
నాకు వెనక్కి వచ్చిండి అందరు ఎదురుగలదు.
చేస్తున్నా వెయిట్ కెమెరా అంటే తీస్తున్నా ఓకే డన్
Check.
I request Dr. T. Srinivas Rao, sir, Chief Intensivist and Head of Critical Care Department, Manipal Hospitals, Vijayawada, to present a keynote.
Good afternoon, everyone. It gives me immense pleasure and pride to welcome you all to this phenomenal academic gathering in the field of critical care on mastering ECMO, hosted by Manipal Hospitals, Vijayawada. Today isn't just another CME. Today is a landmark moment, a convergence of mind, a convergence of disciplines, a convergence of passion for saving lives under one roof. ECMO, extracorporeal membrane oxygenation, is no longer a buzzword or an elite intervention. It is life-saving frontier, and today we are not just going to learn it, we are mastering it. Let's begin by thanking our torchbearers, the experts who breathe life into such forums and into countless critical cases each day. I feel truly honored to welcome and extend heartfelt gratitude to Dr. Devanand sir, esteemed cardiac surgeon from Manipal Hospital, Bangalore. Sir, your surgical brilliance and ECMO experience have saved more lives than we can count. We are thrilled to have you here, sir. Dr. Samvedam Srinivas sir, a proud alumnus of Manipal and one of the most respected figures in the field of critical care medicine, sir. Your journey continues to inspire us all. Since the last almost 2.5 decades since we have known you, sir. Dr. Sunil Karan, sir, Chairman of Critical Care Services, Manipal Hospitals, Bangalore, is a true visionary who has helped shape modern intensive care across the Manipal network. Dr. Karthik, our dynamic intensivist, whose clinical insights and dedication represent the best of the critical care. Dr. Vinay, another pillar in the field, bringing precision, expertise, and deep compassion to patient care. Thank you all doctors for your presence, your wisdom, and your tireless commitment to the care of critically ill patients. Today, we also welcome a vibrant audience, an assembly of critical care specialists, anesthesiologists, pulmonologists, cardiologists, cardiac surgeons, and clinicians from different specialties. Each of you play a vital role in ECMO journey, from candidation to weaning, from decisions to outcomes. Your presence here today proves one thing, that is interdisciplinary collaboration is not just ideal, but it's far more essential. Let us also give a big welcome to all the panelists. Thank you very much, sir. So ECMO is not just a machine, it's a promise. A promise that when the heart or lung fails, we do not. We stand by our patients with science, with teamwork,
and with unwavering resolve. Let's make today unforgettable. Let's make and master the ECMO together. Thank you, and let's go ahead. Thank you very much, sir.
A very good morning to everyone, and now I would like to invite the panelists for next session today. Dr. Sriman Narayana sir, Chief Cardiologist, Centenary Hospitals, Vijayawada. Dr. N. Murali Krishna sir, Chief Cardiologist, Manipal Hospitals, Vijayawada. Dr. G. Kiran sir, Superintendent and Chief of Anesthesia, St. Anne's Hospital. And Dr. Ramakrishna sir, Professor and HOD of Pulmonary Medicine, NRA Hospital. I extend a warm welcome to each one of you who has gathered here today for the CME on ECMO. It is with great respect and admiration that I take this opportunity on behalf of Manipal Hospitals Vijayawada to introduce our distinguished speaker for today's CME session, Dr. Srinivas Samvedam sir, who will be delivering a talk on case selection for early ECMO. Dr. Samvedam sir is a name that needs no introduction in the world of critical care. Starting a professional journey in critical care is never easy. Building something from scratch, resisting the lures of powers and position, and staying true to values. But this man has done it all with honesty, hard work, and unwavering dedication. Coming to academic qualifications, Sir has done his MBBS from NTR University of Health Sciences 1995. Later, Sir did his MD in Internal Medicine from Gandhi Medical College in 2000. Later, Sir did FNB Critical Care Medicine from Manipal Hospitals, Bangalore. Sir also had an EDIC, which was done in 2006, FICCM 2015. Sir also holds a diploma in healthcare quality and medical law. Sir is currently the Chief Consultant and Head of Critical Care at Sindhu Hospitals, Hyderabad. Sir is also the current President of Indian Society of Critical Care Medicine, and he continues to be an accredited teacher and examiner for the courses offered by ISCCM and also DRNB critical program. Sir is also an invited faculty at numerous national and international critical care CMEs and workshops, a mentor to many young intensivists, and a prolific speaker who combines evidence-based insights with bedside practicality. His ability to make complex topics clinically applicable is what sets him apart. Sir is also a steering committee member on National ICU Policy Frameworks, including Ministry of Health and Family Welfare ICU admission criteria and end-of-life care guidelines. Sir has also published peer-reviewed articles and contributed to evidence-based critical care literature. He was recognized for his extensive involvement in academic forums with over 40 plus index publications and 18 plus textbook chapters. His areas of interest span ICU care protocols, advanced ventilation, obstetric critical care, trauma, sepsis, glycemic control in ICU, and of course ECMO program implementation, a field in which he has trained and mentored multiple teams across India. A pioneer in ECMO services in Hyderabad, and he has also been instrumental in building multidisciplinary team capabilities and outcome-driven protocols. In today's session, sir, we look forward to your expert insights on ECMO, especially in the context of evolving case mixes, timing, team readiness, and outcome optimization, all of which are success to this advanced modality. Please join me in extending a very warm welcome to Dr. Srinivas Samvedam, sir. Thank you.
I request all the doctors to come, please join the session.
So
I request everyone to please come and join the session.
Good afternoon. It's always a pleasure to be here in Vijayawada, the city of victory. And it's also good to be here in a city where some of my best students are working, starting way back from Vinati Paritala, down to Dinesh, Manoj, Shabbir. I mean, some of my best talents, some of my international award-winning students are working here. And it's humbling for me to see them grow and lead their teams probably in a much better way than I ever could have imagined. Thank you very much for giving me this opportunity, and I'm grateful to the organizing team for having me here. Also wearing a Manipal logo after 21 years, right? It is a nostalgic experience for me. I share my growth in critical care for my confidence with which I can multitask and manage multiple patients at the same time. Me and Sunil grew up in Manipal Hospital way back in 2002, 2005, and then in Sydney. Trials and tribulations, he knows more than us. It's a journey which I can never forget. And I'm speaking on behalf of a hospital or an institution which has given several presidents, several general secretaries, and several office bearers of the Indian Society of Critical Care Medicine. Unsung, no drama, no advertisement, but it works. Sunil, I think, and Sunil continues to lead that banner with great success. And so we all heard about when you should do ECMO, when you should not do ECMO, or what you should do when you are doing ECMO for your patients. Some other presentation, I think his presentation is playing, your presentation is playing here on the screen here. Yeah, sorry. So, I can't see this. This is not the this is the disconnected. Okay, sorry about that. So we know what VV ECMO does, we know what VA ECMO does. We know that you look at severe pneumonia with refractory hypoxemia, ARDS with a PF ratio of less than 100 and a bridge to lung transplant. We know that this is a standard indication for ECMO. But what we also need to remember is that you just cannot go by that PF ratio to decide which is the right or the correct time to initiate your patients on ECMO support. You cannot just go by a PaO2 number, you cannot just go on an FiO2 number or a ratio to tell us, yes, now this patient goes on to ECMO. You also need to know at what cost you are achieving that PF ratio. Am I achieving that PF ratio at a high plateau pressure? Am I achieving that PF ratio at a high driving pressure? Am I delivering too much of mechanical power to the lung? These are the current concepts from the basics of mechanical ventilation in ARDS, which we need to bring into deciding how early is initiation of ECMO. As Devanand said during the course of his talk, if you do it too early, you will be accused of being commercial and jumping the gun, right? And if you do it too late, you will be accused of being negligent. Both sides of the coin are true and they are seen in practice. So, when you say severe pneumonia with refractory hypoxemia, you need to understand what exactly that refractory hypoxemia means in the context of selecting your patient for extracorporeal support. So if I prone a patient, and after proning, I can get fantastic numbers. I can wash out the carbon dioxide, I can get a PF ratio of more than 100, I can probably get a PaO2 of more than 80. But if I am doing it at a plateau pressure of 30, if I am doing it at a driving pressure of 20, or my mechanical power is more than 15 joules, then I am doing more harm to that lung. On paper, on the monitor, it looks fantastic. But at the end of the day, you will get a systemic inflammatory response, you will get hemodynamic instability, and then your options would change from probably a less complicated veno-venous configuration to a more challenging veno-arterial configuration if the hemodynamics and the right heart actually gives up in the face of such high driving pressure. So you need to look at that as well. When you look at veno-arterial ECMO, we all heard in the previous talks that refractory cardiogenic shock despite optimal medical therapy. What is that despite optimal medical therapy? There is something called as a cardiac power index. Does it help you to identify which heart failure is going to recover with conservative medical management? Which heart failure is not going to respond to conservative medical management? You need to take that call very early, and that very early would mean in the first 24 hours of initiation or reaching the optimum therapy. As you get more experience in doing ECMOs and as you do more and more numbers, more and more challenging cases would come into your ICU. I'll come to that in a while. So in an Indian scenario, what is the call you need to take? Paraquat poisoning. I'm sure Dharnendra is in the audience somewhere. I met him outside. He must be here. He will agree with me that this is the biggest killer in the south of the country currently. Patients getting onto ECMO and get stuck there. They try to, and you try to put them on transplant list, it's not going to happen, right? So paraquat poisoning, how soon are you going to initiate these patients on venous ECMO, right? How many dithionate positives would you wait for to get them onto an ECMO support? So an initial CT scan, biomarkers of inflammation, plus my perception, there are no guidelines. Of course, the ISCCM is coming out with guidelines on paraquat poisoning this year, but as of now, nobody tells you when to do an ECMO on a paraquat poisoning. What I perceive is that if your fourth dithionate test is consistently positive, you need to alert the ECMO team that there is somebody who's going to go on extracorporeal support. Calcium channel blocker overdose, right? This is, I think, one of their first experiences in 2007 was calcium channel blocker overdose. Now, with the pica syndrome, that is parents in India, children in America kind of syndrome, right? More and more adults are getting into depression and, mental issues, and they're already on antihypertensive, so it's a sitting duck. Every year, we see 12 to 14 patients with cardiogenic shock secondary to calcium channel blocker overdose. And a good number of them end up on veno-arterial ECMO, at least for a short period of time. Leptospirosis, right? It is another Indian indication. You don't find this literature if you look at the ECMO literature or the ELSO registry. You might find anecdotes, but you don't find series. Alveolar hemorrhages due to tropical disease is another. When do you do that? At what point of PF ratio? You cannot apply the ARDS criteria for these patients. You need to look at where the leptospirosis, the platelet count, the coagulopathy is going before you say, I will do it. You should not do it too late because simply the patient will bleed and bleed and bleed to death. In the Indian context, where hypertensive disorders of pregnancy are higher when compared to Western literature, more number of our pregnant women end up with peripartum cardiomyopathy, and it's not unusual for a post-cesarean section patient to be coming to us for ECMO with peripartum cardiomyopathy, and that's a very, very tricky situation. Some of them have HELP syndrome. So you need to be absolutely clear at what point of time you will initiate these patients. So while on this, I will recount some of the more challenging ECMO requests we have got in our past maybe 19 years. We started in 2007 in the first H1N1 pandemic. First patient, 54 days was the venous ECMO. We ran on that patient. We were on the learning part of our curve at that point of time. We have seen in the last 17 years 5 patients with scorpion sting myocarditis who needed veno-arterial support. And as it was discussed in the previous talk, one of those was a 9-year-old child actually who had ischemia of the limb. And we had a big problem. The child almost died of myocarditis, of course a politician's family. Child recovered from scorpion sting myocarditis after 8 days of veno-arterial ECMO, but he lost his limb, and we had to actually face a lot of criticism for actually sacrificing his limb during the course of the ECMO. Subarachnoid hemorrhage patient who has stress cardiomyopathy and cardiogenic shock. We had a request to initiate ECMO on those patients, on that one such patient. Chest trauma, patient with blunt thoracic trauma with bilateral bronchopleural fistulae with pelvic trauma and splenic laceration. After fixing the pelvis and the splenic laceration, we were given the task of doing ECMO on that patient. So as you get more experience, maybe your volumes will come down because everybody else is doing ECMOs around you, but you will get more and more challenging cases into your ICUs, and that's where early patient selection is going to be the key. So recent evidence seems to demonstrate that early initiation within 24 hours of admission with the problem which satisfies the criteria reduces mortality from the pre-existent 64% to about 13.3% in severe ARDS patients with improved neurological outcomes. Now, neurological outcomes are also an essential aspect. Now, if in tertiary care centers, you don't get patients who are intubated for ARDS straight off the streets after 24 hours of invasive ventilation. You get them after 3 days or 4 days, and quite often it is that magic 7 days later they come to you, and they are deeply sedated, paralyzed, and you don't know whether the neurologically are intact. So with the availability of near-infrared spectroscopy, we are able to actually assess a priori in the emergency room and in the first day in the ICU whether the cerebral oximetry is reasonably good or it's already more non-utilizing cardiac output. So shorter durations, so early initiation of ECMO is important because you then end up with shorter durations of ECMO, reduced complications. All the complications which were listed in the talk earlier will probably come down if you reduce the length of your ECMO runs. So if you have a patient selection criteria across the board, you will look at the PF ratio, you look at the Murray lung injury score which is greater than 3, and always look for a reversible lung pathology with potential for recovery. So somebody, as I said, a paraquat poisoning, who doesn't have too much of ground glassing on the CT scan, whose inflammatory markers are not very bad, but still has a persistent diethioneate test, will satisfy the last point. But somebody who's already got more than 3/4 of the lung fields fibrosed will not be somebody who has a reversible pathology. Now that patient gets transitioned from ECMO, or ECMO serves as a bridge to transplant. So when you know that the number of organs available for lung transplant and the costs of such a transplant in India are still very high, and our outcomes of lung transplant are not comparable to what's happening in the West, we need to be very careful whether we offer ECMO for these patients. And as more and more centers get into bridge therapies, more and more centers are getting into VAD therapies, more and more centers are getting onto the cardiac transplant list. So VA ECMO plays an integral part because it may, as I said, in those reversible causes like myocarditis, overdose, and other aspects, it may be a bridge to recovery. But sometimes it's a bridge to device or it's a bridge to transplant. So who is a bridge to transplant? Who is a bridge to device? If you can identify it early and all the aspects, including the financial aspects, are understood, early transitioning of these patients to VA ECMO will be important. But what actually makes a difference in the Indian context is an age-appropriate physiological reserve for recovery potential. There was a discussion about perfusion cannulae, whom to put, whom not to put. Our own perception is more than 40% of our population is diabetic, which means most of them are atherosclerotic. So it makes sense actually in preempting the ischemia and doing it as a policy for all patients who are more than 40 years of age, if they are diabetic in the community. So if you use such kind of physiological parameters, maybe you will initiate these therapies very early. There is an absence of irreversible multi-organ failure, but again here toxicology is a different ballgame. If you get an aluminum phosphide poisoning, for example, or a CCB overdose, for example, liver dysfunction is part of the deal, but it will be reversed if your cardiac output improves. So use that if your transaminases are rising or if your prothrombin time is rising, use that as an early indicator that his organ perfusion is actually drifting downwards, and you consider early initiation of ECMO for these patients. And in Indian context, informed consent and realistic family expectations are the key. Right? Even today, more than 40% of our patients pay for their health care from their pocket. And in the last Criticare in Chennai, in Kochi, Dr. Ram Raj Gopalan actually presented his viewpoint on how many lives or what cost it takes in India to save one life with a veno-venous ECMO. It is 12.7 crores it takes to save one life with a veno-venous ECMO. This is the economic analysis of ECMO in India. But we don't measure the value of a life based on money. we need to understand that the family agrees or accepts that ECMO is not a magic therapy. There are pros and cons. There may be negative result at the end of the ECMO, but it's the only option we have in our hands. This is the so when we talk to them, we need to tell them that this is what it is, our results are this, our success rate is this, so your patient has a chance. But you need to objectify that as well. So you need to look, when you select a patient, just as you do SWOT analysis in management terms, you need to do a SWOT assessment for your patient. What are the patient's strengths? Has he come early into your, is he young? Is his functional status good? Does he have a reversible pathology? And has he come early in the disease process? That will be the strength of the patient. What will work against the patient is that you need to look at elderly patients, those with some occult malignancy, those who have come late in the course, or they have an irreversible pathology. That's the weakness. But the opportunity you have is that the earlier you intervene, you involve the team that is doing ECMOs more often than you. If you involve them, do not let them go into a cardiac arrest scenario, and you have a definite plan of what I'm going to do this for this patient. If my ECMO fails, that's an opportunity you have. And of course, the threat is that irrespective of how meticulous your management is or your monitoring is, some of these patients will develop brain injury because of multiple factors. So if you do a SWOT analysis, and if your patient actually falls into the green zone, you should consider early ECMO for these patients. So it's early recognition, identify the patients who are meeting the severity criteria, quickly assess them, and consult the team. Here, I would say, do not hesitate to take second opinion, right? If you are not very experienced in doing ECMO, but you have the infrastructure, you have the machine, and you have the intent to do ECMO, call somebody, call centers which do more often, call maybe Sunil's unit, or you call whichever unit you may know which is doing more. There are centers which are dedicated ECMO centers in the country where 15 machines are running around the clock. Call them and ask, this is my patient criteria, this is the CT scan, this is the ABG, this is the hemodynamic numbers, this is the acid-base status, this is the coagulation status, can I go with ECMO, what mode, what settings? Don't be hesitant or think that if you ask somebody for help, they will think you are incompetent. It's not going to help. Be open to take second opinion. Plan the cannulation and initiate the ECMO. So this is the RESP score, which will tell you whether your ECMO is going to be successful or not going to be successful. It basically looks at the routine parameters which we look for any of the critical care situations, like age, immunocompromised status, the days prior to initiation of ECMO, the patient has been on mechanical ventilation. The points to remember here is that respiratory causes, respiratory infections causing hypoxemic respiratory failure seem to be doing better than non-respiratory infections causing respiratory failure. In the sense, primary ARDS seems to be doing better on ECMOs than secondary ARDS. It's obvious because it's happening very late in the course of the disease, and it's more often associated with hemodynamic instability and coagulopathy. So if you get a RESP score of more than 6, then your patient has 92% chance of survival. This is quantifying. When you sit with the family, have these numbers in the back of your mind. You tell them this is a chance, but still tell them 8% chance of dying. That's important. People should know that you can still die on ECMO. It's not a life-saving device for all patients. So if you look at veno-venous ECMO, there are certain favorable diagnostic groups. You need to look at these diagnostic groups and the confounders and score them accordingly. So the favorable diagnostic groups are community-acquired pneumonia. Of course, the COVID-19 actually triggered all this enthusiasm and more widespread availability of ECMO. Aspiration status asthmaticus, and post-lung transplant primary graft dysfunction, and we did one for drowning as well. I forgot to list it, but adult respiratory distress syndrome from drowning or transfusion-related lung injuries. These are the favorable diagnostic groups. The chances of your successful management of these patients are very high. There are certain groups where you need to do the SWOT analysis more meticulously. These are the high-risk diagnostic groups for veno-venous ECMO. So you put a score of 1 for that, and you give a score of 2 for this. Necrotizing pneumonia, pulmonary vasculitis, long-term transplant patients, trauma, traumatic brain injury, bronchial injuries, ARDS from direct chest trauma and toxin-related pulmonary disease. As I said, paraquat is one of them. And of course, some of the anti-neoplastic drugs also fall into this category. So you give a score of 2 to this, and then you will have the unfavorable diagnostic groups for veno-venous ECMO. You give a score of 3 to this group of diseases like non-pulmonary ARDS like burns, invasive aspergillosis, pneumocystis infection, and remote lung infections post-lung transplant. If you give them a score of 3 for this category of patients, you then have to look at the clinical modifiers. Despite this background, what are the modifiers which will influence your outcome for patients? So if the patient had some peripheral chronic comorbidities like peripheral vascular disease, previously ischemic heart disease, COPD, CKD patients, CLD patients, and long-term immunosuppression, these are very poor protoplasm patients. So they will not do well even if your ECMO has been successful. And acute problems, these are the modifiers. They will worsen your outcome. If you initiate ECMO when the lactate is already more than 5, this is veno-venous, I'm not talking about veno-arterial, veno-venous ECMO lactate more than 5, or your patient is so hemodynamically unstable that is requiring more than 0.3 mics per kg per minute of norepinephrine, or has got an ALT of more than 1,000 or an INR of more than 2, or has been anuric for more than 4 hours. Simple veno-venous ECMO is not going to be helpful for this patient. This is probably a threat for this patient. So you need to hybridize and put them on CVVH-DF or CVVH-D along with ECMO for you to get good results. And when the patient is hemodynamically unstable, veno-venous ECMO is not enough to drive the CVVH-D. You need to transition it to veno-arterial to drive the CRRT. So such decisions will make the veno-venous ECMO decision more negative for this patient. So if you plot all of this, you get a score of more than this. So all those who are less than 40 scores and 1 to 2 score, you can get a grid into which your patient actually falls. You can actually show them this score and say, if your patient is in the green zone, don't waste time, get onto the ECMO. If he is in the yellow zone, think twice, take second opinion. And if the family is understanding that he could die, then you should do ECMO. The red ones do not offer ECMO for this patient unless the family says as a last resort we want to do. But be very clear that it's going to cost them $1 lakh plus every day only for the ECMO. So if you look at, I won't spend too much of our time on veno-arterial because veno-arterial has already been discussed. So myocarditis, PTE with cardiogenic shock, first presentation of cardiomyopathy, arrhythmogenic dysplasias, all this will come into the favorable diagnostic groups. The high risk would be post-MI cardiogenic shock, papillary muscle rupture, somebody who's failed to wean off cardiopulmonary bypass, and somebody who's had a rejection post-cardiac transplant. We don't see that very often in this country at present, but maybe 5 years from now we'll see this one as well. And then the unfavorable diagnostic groups, the clinical modifiers, again, just as we saw in veno-arterial, veno-venous, higher lactate, anuria, and ischemic hepatitis. These are all modifiers for veno-arterial ECMO as well. So you can put them on the same score and you can offer your patients whether to go for ECMO or not go for ECMO. Therefore, if you want to get good results, right, have an integrated approach. Successful ECMO outcomes require systematic evaluation combining clinical assessment, SWOT analysis, optimize the timing, and multidisciplinary coordination, right? It's always the team that wins the match. It's not the captain or the wicketkeeper who wins the match for a team. The team wins the match, not the captain or the coach. The coach, of course, loses series after series, as we are seeing, but so use the routinely available clinical scores, but adapt them into your clinical scenario. Because if you are working in a Tier 2 city, you may get patients off the streets with the primary diagnosis. But if you are working in a center like Manipal Hospital, you don't get straight off the streets. They would have been in another hospital for 3-4 days. So don't rigidly stick to the established guidelines and say, this has been 7 days of ARDS, so I'm not going to offer ECMO. So be practical on your feet and think whether if I offer ECMO, what is the strength of this patient and what is the weakness of this patient. plan your resources. Currently, this country is facing a crunch of circuits. So those centers which have got large volumes and big experience would have some hardware which is available to fabricate circuits. But the ones which don't have that much of volume are struggling. So if before you offer, you see, and when you start ECMO, it's not that if you have one circuit in your pharmacy, it's going to be enough. One has to be standby, because if this clots on the first 6 hours, you're in trouble, deep trouble. So plan for that. For that, administrative preparedness, administrative willingness to support you, but also take the hit when there is an additional cost involved in procuring certain things is lacking. Family communication, right? Always take the family into confidence. Tell them that as soon as the ECMO is started, the numbers will look fantastic. If you get a good venous flow going, saturation will look 90%, the FiO2 on the ventilator comes down to 35%, everything looks, but it is a paper, right? It is a facade. There is a simmering disease which warranted that patient to go on to ECMO. Today, just because the patient is showing a SATs of 100% and the pulse oximeter is showing 100% SATs and FiO2 on the ventilator, is not going to get decannulated tomorrow. There's a long battle, and things can get worse after the first 48 hours or 72 hours. And once you run off the ECMO, the weaning process takes its own time. It's not that today I decannulate the ECMO and tomorrow he gets off the tracheostomy or the ET tube. It doesn't happen like that. We are only giving lung rest. We are not treating the ARDS. Remember that. Just like you don't treat the kidney for acute kidney injury, you support the kidney. This is what it is. And this fact is where we fall short. We say ECMO, put ECMO, everything will be fine. Everything is not fine. You are just masking what's gone wrong there. You are allowing natural processes to recover. You are allowing nature to cure the lung. So give them that upfront information. So on that, please do join us in Criticare. There is an excellent ECMO workshop in Chennai on February 26th. We have an ECMO workshop. Bulk registrations for all of you are available. Good faculty coming from overseas for ECMO training with a simulation. Please do join us in Chennai for Criticare 2026. But before I finish, with the permission of the chair, something not related to this topic, maybe related to this topic. We talked about ECPR, right? ECPR happens when somebody gets spontaneous circulation, not getting spontaneous circulation. But how many of your patients actually come to ER like that? My aim or my campaign during my tenure as president of the Indian Society has been to take CPR to the community. We have started a campaign called School CPR campaign, where all our branches, 106 branches across the country, are being asked to approach schools and conduct CPR sessions for school children older from 9th to 12th classes, so that we empower every single future citizen of this country to be a lifesaver. And why children? Because children, in their enthusiasm, will motivate their parents to learn CPR. This is my aim. This is a campaign. Please do join hands with the ISCCM. Yes, it's good to do ECMO. It's good to do ECMO. It's good to do plasma exchange. It's glamorous, right? I did veno-arterial ECMO and my patient survived, and with all these complications, my ego is satisfied. But is that enough? This country needs more of grassroots stabilization. You go to the Scandinavian countries, every school kid, they can't pass their school without going through a CPR certification. We need to reach that level of competence and empowerment. Please do join hands. Dharanindra has been doing a good job. Shabbir is doing a good job. As of now, we started this campaign on the 11th of July, and I'm happy to say 3 cities in Andhra, Rajamandri, Rajamahendravaram, Kakinada, have been in the Nellore, started first in Nellore and then went to Rajamandri and Kakinada. As of yesterday, we completed 7,000 students whom we have trained in CPR. And before my tenure ends on the 1st of March 2026, my task or my aim is to cover at least 50,000 children who are empowered to save lives in the community, so that patients come to you for initiating veno-venous or veno-arterial. Thank you very much. Have a good day. Any comments or queries? I'm happy to answer.
This is an excellent lecture, and you made it so simple. Everybody could understand it easily. And to the audience, any questions to be asked, please.
Thank you, sir. Thank you for enlightening about the initiation. Sir, what about the paraket poisoning? Do you think ECMO after pulmonary fibrosis?
What is your exact protocol? Is ECMO for after developing pulmonary fibrosis or
no, before?
Before.
So there is no structured position statement or guideline, but all our patients who come with a positive dithionite test are getting a CT scan. If the CT scan shows less than 10% of ground glassing, right? We consider no ground glassing. We don't do ECMO at all. We just put them on a HA230 cartridge, and we put them on routine therapy, NS-style cysteine, and a kind of supportive therapy. But if the ground glassing appears, but it's not more than 10%, that is when we float the concept of ECMO to the family, even before they get intubated. So, but once it is crossed 20%, we don't encourage ECMO for the patient.
But of late we are doing hemoperfusion actually.
That is HA230.
Okay. So after the hemoperfusion, you go for.
No, it's not after.
Okay.
We take a decision based on the CT picture. If the CT is showing 10 to 15% of ground glassing, it is the filter. That filter runs with the ECMO.
Okay.
It runs with the ECMO.
But what about cardiac involvement? They develop cardiac arrhythmias, and sometimes they have.
Arrhythmias are okay, but if the LVOT velocities are good, we don't transition them to. So far, we have not had anybody transition to veno-arterial, but maybe it is a possibility. As we see more, maybe it will. We will see more.
Sir, you have covered the type 1 respiratory failure. What about type 2 respiratory failure with high PCO2, despite all the measures? Do you have any such cases with your experience in type 2 respiratory failure?
So that is where mechanical power comes into picture. Power of mechanical ventilation comes into picture. So when you have somebody with hypoxemic respiratory failure, you are all focusing on driving pressure, plateau pressure, and transpulmonary pressure. But when you have a carbon dioxide that is high, you don't think twice in increasing the respiratory rate. Now, whenever a lung collapses and expands at a faster rate, maybe at 35 breaths a minute, which you normally set to wash out carbon dioxide, it dissipates more energy to the lung. That causes ergotrauma. And now that is easily calculatable. If you Srinivas is here, actually. Thank you, Srinivas, for being here. He is one of the pioneers who did school CPR on his own initiation in Nellore. Thank you, Srinivas. Anyway, so that is mechanical power. So if I prone a patient who is having ARDS and he is already hypercapnic when you proned him, his CO2 doesn't get down, but if you increase the rate to about 30 to 35, then is the CO2 is coming down, I am getting that washout of carbon dioxide at a higher cost. I can't take that cost because the numbers will look good, EtCO2 will look good, but at the end of the day, patient will develop lung injury. So such patients should be transitioned to extracorporeal support. Now, if the oxygenation is maintained and my driving pressures have come down and only the carbon dioxide is the issue, I can do extracorporeal carbon dioxide removal for those patients. So you don't need to put an ECMO circuit. The current Fresenius multi-filtrate Pro machine has got a cartridge. Just like you cannulate for dialysis, you can put a jugular double lumen line and run it through that filter. With a lower flow, you can wash out carbon dioxide, provided your oxygenation and prone ventilation has improved at a lower driving pressure. But if on proning the patient, the carbon dioxide remains high and my PF ratio has gone up, but my driving pressure has not changed, that patient goes on to ECMO and the carbon dioxide is taken care of by the sweep gas flow on the ECMO.
What about role of ECMO in calcium channel block? Do you think VA ECMO?
VA. Straight away VA. Straight away VA ECMO.
So even after, is it dialysable, calcium channel blocker?
It's not dialysable, sir, but if you combine glucagon infusion, continuous glucagon infusion, put a pacemaker to keep the heart rate above 70, and then initiate a veno-arterial ECMO, the number of hours of ECMO comes down.
Do you have any experience in pulmonary embolism?
Yes.
In,
2 patients only.
because
I can't say experience, but we have
we
seen
give thrombolysis.
Yes.
Still he doesn't improve.
Yes.
Can we consider?
We should consider. We should consider ECMO on these patients. We should consider.
So for putting LV dysfunction, for putting for RV dysfunction, while we put them on ECMO, is there any either flow or what, any differences?
So in patients with pulmonary embolism who end up in cardiogenic shock, right, it is a biventricular dysfunction. So you need to support the oxygenation because with the membrane, but your output is supported by the arterial.
Okay, thank you. Any questions from the audience?
So only means 2 things. I have confused you a lot, or I have been too late. So I take the credit. Thank you very much.
Dr. Samuel, sir, we wish to felicitate you. Request the chair members to present the memento. Round of applause, please. Manipal Hospitals to present mementos to the delegates who have chaired the session. Dr. N. Modi Krishna, sir, cardiologist. Dr. Kiran P. Ketwagaru. Dr. Sriman Narayana, sir. Dr. Ramakrishna, sir. Please accept the mementos on the left. Dr. Banu Praveen Naidu, sir, will be presenting the mementos to the chairpersons. Dr. Balaji, sir, Chief Anesthesiologist, Manipal Hospitals, Vijayawada, to present mementos to the doctors who have chaired the session. Dr. Dilip Kumar Garu, Chief Cardiac Surgeon, Manipal Hospitals. Dr. Kola Srinivas Rao, sir, Cardiac Surgeon. Dr. N. Sandeep Garu, Senior Cardiologist, Manipal Hospital. Dr. Balaji, sir, will be presenting the mementos.
For the next topic, I would like to welcome the chairpersons onto the stage. Dr. Sridhar sir, Chief Nephrologist, Manipal Hospitals, Vijayawada. Dr. Balaji sir, Chief Anesthesiologist, Manipal Hospital, Vijayawada. And Dr. Srinivasan sir, Head of Emergency, Manipal Hospital, Vijayawada. It gives me immense pleasure to introduce our next speaker, a dynamic and accomplished cardiac anesthesiologist whose academic brilliance and clinical expertise have made a significant impact in the field of perioperative and critical care. Dr. Karthik Hanuman Shetty, who is associated with Manipal Hospitals, Bangalore, has an impressive academic background that includes a DM in cardiothoracic and vascular anesthesia from the prestigious Sri Chitra Tirunal Institute, a DRNB in cardiac anesthesia and multiple fellowships, and was awarded with gold medals. Dr. Karthik sir brings a wealth of experience in managing high-risk cardiac surgeries, perioperative care, and of course ECMO across all age groups from neonates to adults. He's been actively involved in multiple national conferences and workshops, especially on ECMO, TEE, and cardiac critical care. He has also contributed to several publications and case reports in leading journals. With his unique blend of academic insight and real-world ICU experience, we can look forward to a session that is both practical and thought-provoking. Please join me in welcoming Dr. Karthik sir for his talk on weaning.
Your cardiologist to chair the session. Thank you.
Yeah, good afternoon to everyone. Yeah, I have been associated with Manipal Hospital even before my DM has started, and then after that also I have been associated with Manipal Hospital. I have been working under and along with Devanand sir. Like all my basics of cardiac anesthesia were from Sri Chitra, and all the basics of ECMO are from Devanand sir unit. I am very proud to say that like I have worked with Devanand sir. Yeah. And someone is asking before starting this, like, what is the best center to take or learn ECMO? Like, from my perspective, like in the last 2 years, I have been part of 84 ECMO under Devanand sir. And he's along with Sunil Karan sir. There is no doubt in that. And whenever you ask me, I directly point out to Manipal Hospital, Old Airport Road, for any point of ECMOs. It is not the number of ECMOs that are important, but it is the number of people that are discharged to home are very important. We see a lot of number game in the corporate sector, but definitely the like admission, ECMO, and discharge. Those are the things that we have to look at. Just it's very similar to the insurance claim settlement ratio. That's all. Okay, I will start my topic. Weaning. So there are no disclosures and there are no conflicts of interest. Yeah. See, don't see the person who is on the horse. Are you able to see anything behind this scenario? A person entering into some battlefield. Can anyone guess what it could be? One more clue. Now? Abhimanyu. Yeah, it's true. This is the Padma Vyuha or the Chakra Vyuha. Everyone is thinking like, sir, like we are starting an ECMO, how to come off. I think this could be that session that will help you. Once you have initiated an ECMO, that means you have entered into a Padma Vyuha. Let me try to put it in a simpler way, like how to come off ECMO. So like the topic mainly goes in these terms, mainly the weaning, the definition and its criteria and the protocols that are there, and then there's something called trial off, and then the decannulation. So weaning, a slow decrease in pump flow or gas flow or FiO2 of ECMO over hours to days in an effort to take away the mechanical heart-lung support from the patient. This looks like a statement where it includes a lot of information. Let me break this into simple terms. First thing is we are decreasing the pump flow. That means extracorporeal blood flow. I will show you with an diagram in the next slides. One important thing, there is a decrease in the pump flow. Along with it, there can be a decrease of the gas flow, that is the sweep gas flow, or there can be a FiO2. And then it may take a small to a long time in weaning of the heart-lung support. Okay. Then what is this term called trial off? In the weaning, still the circuit is functioning, but in trial off, the ECMO is completely stopped or it has been bridged. In the next few slides, we will see what each weaning and trial off means. First, we will completely see. First, we wean already the Sunil Karan sir and Devana sir has put the patient either on a VV ECMO or a VA ECMO. Now we will slowly try to wean off this patients. So, when do you say weaning is successful? The patient is not requiring any further mechanical circulatory support in the next 30 days. That is actual successful weaning. And is weaning synonymous to survival? Definitely not. The patient has to be discharged home. Then only we will call it the patient has been successfully weaned, and then patient is surviving. So when to think of weaning from ECMO? It should always start whenever we are initiating the ECMO only, the thought process of how to make an exit strategy for the patient has to be done. But most of the cases, for the first 72 hours, we will not try to wean off the patient, but we should have a strategy. It doesn't mean that like now we put on ECMO and the numericals are looking good, we straight away wean off the patient. That doesn't hold good. So at least 48 to 72 hours, especially for the cardiac cases, we have to give rest. And then the primary pathology for which the patient has been put on ECMO has to be completely settled. And if the disease is irreversible, discontinue the support without recovery. We have to do it because it's an irreversible pathology. At the time of initiation, we are not sure, but as the time progressed, we came to know that the lung or the heart, that they are not recovering. At that time, we have to do the weaning. And then complication, once the complications outweigh the benefit, that means the purpose of ECMO is not serving anymore. Then also we have to do something called rush weaning. For example, the patient suddenly, because of the anticoagulation or any hypertensive episode, suddenly has caused a brain bleed, and it's a one territory completely involving the brain bleed. Then there is no point of continuing ECMO, and this has to be discussed with the patient relatives, and then we have to do a rush weaning in these cases. So, we are always speaking about VA ECMO supporting the heart and VV ECMO supporting the lung. So it's a common term, ECMO. Does it mean that we have to do the same weaning protocols for both of them? Definitely not, because they are completely different set of ECMOs. The VV ECMO supporting the lung and VA ECMO supporting both the heart and lung. So the assessment criteria, method of weaning and duration of weaning differ. So now we'll start with weaning VV ECMO. So VV ECMO generally will be put for the ARDS cases and other indications that already Sunil sir has spoke of. Now this patient, we have to, if there is a lung recovery, okay, then the weaning process has to be started. But still the mechanical, it can be an awake, like a non-ventilated patient or a ventilated patient. I will speak about those two topics a little later. So we will consider this patient is mechanically ventilated and ECMO has to be weaned off. Other side, we are not seeing a good response from the lung and the lung is deteriorating more. Then there is no chance of weaning this patient. Either the patient has to be done a lung transplant or we have to do a rush weaning. This is the basic VV ECMO circuit, where we can see that the, from the femoral venous cannula has been inserted up to the IVC junction and it is draining, and a pump is there and it is going into the oxygenator, and it is again given back into the superior, through the IJV, giving back into the superior vena cava. So three components are very important here. One is the extracorporeal blood flow, that is the total blood flow. Here we are seeing it as in the terms of RPM, that is 5000 RPM, and the total blood flow is 3.7 liters per minute. And two other important things, where here you can see This is the air oxygen blender. Here you can see two things. One is the FDO2. It is nothing but the FiO2 on the gas blender. That's why it's called FDO2. The similar one that we call FiO2 on the ventilator. Okay, and the other one is the sweep gas flow. So three components are very important. One is the extracorporeal blood flow. The other one is on the air gas blender. One is the FDO2 and the other one is the sweep gas flow. Based upon these three components, I will let you know how to wean and what are the things that we have to touch. So the circuit is on your left hand side. You can see the membrane lung, which will be having doing the oxygenation and the carbon dioxide removal with the help of the blood flow, FDO2 and the sweep gas flow. Otherwise, other side has the natural lung, where similar things are done with the help of the lung surface. So what are the indicators of recovery? So whenever you see a patient, take that you are standing at the foot end of the patient, you are seeing the patient as a whole. First, we always have to see the patient clinically, and then if the patient is then the monitor, the numerical ones, and then the ventilator, and all the things that are around the patient. So we have to go in a systemic way to assess the patient. Clinically, we should see an improved saturation because immediately that is available, and then we have to see auscultate the patient, and we have to see whether any added sounds are there, because ARDS patients spasms are very common, but these things are generally neglected because of the whole ICU burden and all other things. But still, small things, these will help in getting a good outcome of the patient. And then secretions, we can be very aggressive, and then we can do continuous inline suction will be anyways there for all these kind of cases. And then whenever you do, if you are in a doubt, bronchoscopy can also be done based upon the other parameters. And ventilation, we always on the ventilator look for the basic settings of tidal volume, peak inspiratory pressure, or the PEEP, and respiratory rate will be managed. But still we have to go a step forward, and we have to keep counting the compliance of the patient also. And then chest x-ray, like whenever there is a serial chest x-rays has to be followed. And then here the bronchoscopy, whenever we are in doubt of any collapse, or whether it is a consolidation, or whether there is an effusion, always we can use POCUS, that is the ultrasound lung. If still in doubt, we can do a bronchoscopy. And then biochemical, always we have to keep following the lab reports, especially ABGs and VBGs for a clinical ECMO weaning. In ABGs, the important things are the pH, PCO2, PO2s. The values I will be telling a little later. And then in the VBGs, always we have to keep following the mixed venous saturation. So now we'll start how to wean this patient. As the components has already been discussed, that is the extracorporeal blood flow, and then the sweep gas flow, and the FDO2. There is a editorial in 2019 where they have described a protocol, which is one of the easiest protocols to follow. See, pre-test criteria, they were telling that the primary pathology, the disease resolution has to happen. And then if the patient is on spontaneous breathing, we can give a spontaneous breathing trial. Otherwise, if the patient is mechanically ventilated, we have to sedate and paralyze the patient, so that we will not have lot of trouble while weaning, or else we will not have any false parameters while weaning. There should not be struggling. And always VV ECMO for lung pathology, so all the cardiac parameters have to be stable. And then at least an oxygen challenge test, at least with this PO2, with 100% oxygen, at least the PO2 should rise to over 200 mm of mercury. So now we'll start weaning this patient. Now we have given FiO2. We saw that nicely the PO2s have gone up in the ABG. Now we'll start reducing the FDO2. Nothing but the that is on the gas blender, we will be coming down on the FiO2 from 100% to 60%. And then if tolerating well, we can follow the numerics on the monitor using a probe plethysmograph, and also you can do a serial ABG monitoring also from 100 to 60, 60 to 30, and then 30 to 21. Our target numerical is PO2 in the ABG should be greater than or equal to 70 mm of mercury with a FDO2 of 21%. That should be our target. Once it is done and once we find that oxygenation is good, then we will go to next thing called first one is called the ECMO deoxy challenge test, EDCT. Next one is the ECMO carbon dioxide challenge test. Oxygenation is good. Now we have to see whether the carbon dioxide removal is proper or not. For that, sweep gas flow. Whenever we are speaking of oxygenation, it is FDO2. Whenever we are speaking of carbon dioxide, it is the sweep gas flow. Now, generally, the flows is to sweep gas flow will be 1:1 or maximum of 1:0.8. So, if the patient, previously the patient is having 3.7 liter flow. So, generally the sweep gas will be 3.7 liter per minute, which will be helpful in removing the oxygen. So, in this test, slowly we keep every 5 to 10 minutes, we will come to 66%. That means from 3.7 to around 2.5, from 2.5 to around 1 liter we will come down, and we will wait for at least half an hour in between. And then we will keep seeing whether the PCO2 is properly being eliminated by the native lung or not. So, once we see that the carbon dioxide is remaining at around a level of 45 to 50, we will easily accept it, and then we will say we can keep this patient for, even though the ECMO circuit is running on, the sweep gas flow, there is no oxygenation or the carbon dioxide removal from the machine. So, the next 24 hours will be called as trial off for the veno-venous ECMO. That's how we will proceed step by step with a serial ABG monitoring, hemodynamic stability, and then following a serial PO2s, PCO2s and lactates. So this is the improved protocol. Lot of importance has been given along with the ECMO flow, ECMO parameters, along with the native ventilatory settings also are very important. In the way, excuse me. All this has to be done not with the maximum ventilatory settings. So, whenever we have initiated an ECMO, the ventilatory parameters which were at maximum level just before the initiation of the ECMO, we can come down. In such a low, in this protocol, improved protocol, which is called ECMO for protective ventilation, we can see they were accepting a tidal volume of less than 4 ml per kg to accept peak inspiratory pressures of less than 30. In this trial, if we go through, even they are accepting 1 ml per kg also. That means 70 kg patient. If we are taking only the tidal volume, they are keeping it around 70 ml. Just to say that they are so much in favor of the baby lung concept. That means to save those baby lungs that are there in the ARDS patients. So even 1 ml per kg also they are tolerating well. And just to prevent the atelectasis of the native lung. See, and respiratory rate is only 5 to 7. And then they are keeping a positive end expiratory PEEP of around 10 to 15. FiO2 is less than 50%. That means mainly ECMO is taking care of whole of the oxygenation and decarboxylation, and then body is looking like completely giving rest to the lungs. So once they are initiating VV ECMOs along with the improved protocol, once the clinical recovery and assessment is done, and once it is improving, that means the lung is improving, then they are stopping the improved protocol, and then they are doing the target ventilatory settings with tidal volume of 6 to 8 ml per kg. That's the main difference between the other protocols and this study. So, when we say the meaning that what we have done to this patient, it's failed. Whenever the PO2s in the ABG are decreasing and they're becoming less than 50 to 55 mm of mercury, and the saturations are falling less than 85% SaO2, that is in the ABGs. PO2s and SaO2s are the main target levels, and then clinically the patient is developing any tachypnea or there is increased work of breathing, and along with this even the hemodynamics are worsening. So in these weaning failure, what has to be looked for? primary pathology, whether the primary pathology is completely treated or not. Along with that, whether the patient has developed any sepsis, any volume overload, or electrolyte imbalance, and muscle weakness. And then muscle weakness, because the respiratory muscles, if we keep on, they can develop myopathy, and then we have to slowly wean off these patients. Nutritional deficiency. These are all the things that we have to take care when the patient is on ECMO, and we have to make sure that all these things are achieved along with the improvement of the lungs. And then the cardiac function also has to be serially followed. Transthoracic echo would be sufficient for this. And then if the patient is developing RV dysfunction, we have to support the RV either by inhalational route like nitric oxide, or an IV like sildenafil, like infusion can be started. And other cardiac functions, whether the patient has developed any new regional wall motion abnormal, valvular dysfunction during this time, and then that is causing the weaning failure. This is how we'll wean the VV ECMO patients. So one thing I was previously telling, these are the ELSO guidelines which were given in 2021, and you can see two columns on your left hand side: intubated patients and non-intubated patients. So many times we'll keep, when the patient is tolerating well, and because like interstitial lung diseases, their PO2s may be low and so they may be slowly deteriorating, but we don't want these patients to be on ventilator. For these kind of patients, we'll put on awake ECMO, okay, and we'll be waiting for the transplant. This is like a bridge for transplant. In these cases, if the patient is neurologically okay, that means the patient is cooperative, because it's difficult even to maintain a central venous catheter when the patients are not neurologically okay and there are a lot of irritability is there. So these are long cannulas. If they are just pulled out, it becomes a lot of trouble and bleeding can happen. So first important, they should be neurologically okay, cooperative, and then they should be mainly able to clear of their secretions. That is one major important thing that is very important in these cases. If these two things are there, then we can go for an awake ECMO. In those patients, the target oxygenation is PaO2 greater than or equal to 70, or no more than a moderate amount of supplemental oxygen. What are the moderate levels of supplemental oxygen? Either 6 liters of nasal mask or face mask, or like up to 40 liters of FiO2 in high flows. And then ABG ventilation. ABG demonstrates acceptable pH based on the patient's clinical condition without excessive work of breathing. There should not be any distress for the patient. Other things are mostly they are similar for the non-intubated and the intubated patients. So mainly they were also telling regarding the reduction of the FDO2, reduced sweep gas, and the off sweep gas challenge. And I will tell the decannulation at the end. Now we will move to the VA ECMO, weaning of the VA ECMO. Mainly VA ECMO, we mainly do it for the cardiac condition. So most of the cardiac numericals will be over here. Like now, mainly whenever you put on full flows, if the patient in VA ECMO are on full flows, that means completely the work of the heart has been taken up by the ECMO, where it is indicating that the pulsatility, which is the systolic and the diastolic difference, will not be seen. We will be seeing most of the very small changes in the arterial tracer. So here we see there is an increased pulsatility. Once the heart starts beating, I mean in the sense like it's improving, the pulse pressure keeps increasing. Now we will see a pulsatility in the system. If it goes greater than 20 and the mean arterial pressure is greater than 70 with minimal inotropic support. Similarly with moderate ventilatory settings, here with minimal inotropic support, we should not be on high inotropic support. Maximum the vaso-inotropic score accepted is less than 10. So along with that, there is an echo evidence. Mainly 3 things are very important. One is there is improved ejection fraction. So LV systolic function, mainly we will deal with ejection fraction. Normal is around 55 to 60 for all the patients. But in these cases, our target is never like even 35. Mainly our target is improvement up to 20 to 25%. Even if with 20 to 25%, we will be very happy and we will be able to come off the bypass, come off ECMO most of the times. So for that, ejection fraction of 20 to 25% and aortic wall VTI greater than 10 centimeters and there is a tissue Doppler. Aortic valve will give you the blood velocity through the LVOT, whereas the tissue Doppler greater than 6 centimeters. This will give you the myocardial velocity. Both blood velocity are good, that means cardiac output is better, and then even the myocardial contractility has improved. That is greater than 6 centimeters numerically. And along with that, improved tissue perfusion, always VBGs, the SVO2 is greater than 70. That's our target. So these are the things. Generally, I being a cardiac anesthesiologist, most of the times I will be doing a transesophageal echo. In always our VA ECMO weanings are inside the OT, and we will put a TE probe and we will be measuring all these: aortic valve VTI, and then the lateral mitral annulus peak systolic velocity, and the left ventricle ejection fraction, and the RV ejection fraction. Even when weaning, even right ventricle is also very important along with the left ventricle. We should never see right ventricle as a standby ventricle here, because LV might have improved, but RV may be still struggling to improve or maybe deteriorating. That's why CVP, monitoring of the and the PA pressures, and then TE are very important in these cases. So this is how there is a 4-step process of weaning a VA ECMO patient. First thing, as similar to VV ECMO, that is the etiology of cardiac failure has to be recovered. And then hemodynamic stability. Already we spoke of that, things that should be there in echo wise, or like pulsatility, or whether it is a mean arterial pressure with minimal inotropic support. Along with this, pulmonary functions is also very important. The lung also has to cooperate the heart. So PaO2 by FiO2 less than 100, and the FiO2 should be set to 21%, and there is a bridge, consider bridging the patient from, if the lung is not tolerating and we feel that lung still has, because of some other issue, because of the associated pneumonia or any other issues, still the PaO2 by FiO2 ratio is bad, but the patient has nicely, cardiac function has improved, we can convert this VA ECMO patients to VV ECMO patients. Then the patient must tolerate a full weaning trial. Already we have seen how to wean off these patients, and all the weaning has to be tolerated by the patient. Then only we have to consider trailing off these patients. So different studies have taken like different parameters. One important thing, mainly they have done transthoracic echo parameters that we have discussed, transesophageal parameters, and then clinically the pulse pressure, and biologically the lactates, and transthoracic both the LV and the RV functions. The Toronto weaning algorithm for liberation of VA ECMO. Almost everything is similar even in this, except they will reduce the flows from to 50%, then to 70, then to 75%, they will come to 25%, and then they will stay at the 25%, then they will go for the trial off. As we have discussed the role of echo in identifying the cause of the weaning failure, when weaning we can have the RV or the LV systolic dysfunctions can happen again. Especially once we are coming down, 25% also the heart may tolerate. But when we are cut off the flows completely, even the 25% flow also can cause trouble. That's why we keep a TE probe and to see how the functions are, continuous monitoring will be there. Other things, especially pericardial tamponade, because in any other cases where central ECMO has been done, we open the chest and the tamponade is not expected. But when we are doing a peripheral VA ECMO, definitely cardiac tamponade there can be a chances, and this will be a very troublesome when weaning. So trial off. As I told, till now weaning means we have come down on the flows, especially in the VA, but the flows are not touched in the VV ECMO. In the trial of coming of VA ECMO, in the second image, we can see between the arterial and the venous cannula. That means from the venous, and there are 2 clamps applied across the arterial and the venous cannula. So, and we will attach a bridge between in the proximal cannula, that is towards the machine. We can clearly see this is towards the venous and this is towards the arterial. Now, whenever we clamp these things, the arterial and the venous cannulas, flow will be going across the bridge. That means ECMO is still running, because we don't want it to clot. So we'll keep running the ECMO, and then we will see how the patient is tolerating this trial off. I will show an example. This is a simulator where we can see the bridging cannula between the bridging tubing between the arterial and the venous cannulas. And every 10 minutes we have to keep releasing the actual flow so that the clot formation will not happen in the arterial and the venous cannulas. So what we have to monitor when trial off is happening, that means completely the patient is off ECMO, but the ECMO circuit is running apart from the patient. So we have to keep monitoring the ABGs and VBGs. ABGs, similarly the PaO2 and PCO2, whether the oxygenation is good or not. And in the VBGs, we have to keep looking at the lactates and also any deficit is developing at a regular intervals of time. We can take it as 30, 90 and 180. Otherwise, institutional protocol, every half an hour we can follow. We keep doing this in the OT. Almost we'll wait, even with the bridging, we'll wait for, in our institute what we have been doing is, every 10-15 minutes we'll be taking an ABG at least for 1 hour. Once it is tolerated only, then only we'll do the removal of the decannulation will be done. And ACT also has to be kept because we are on low flows even on the ECMO circuit. And we have to keep monitoring numerically the mean arterial pressures, pulse pressures and saturations. And because of inserted TE, we will be continuously monitoring the cardiac parameters. It consists of a capping of gas flow to the membrane line. What is the trial off in VV ECMO? That's what we have been discussing. That means only the sweep gas flow is made 0 and the FiO2 is made 21. And we can wait like this for up to 24 hours. That means the circuit is running, but it is not causing any oxygenation or removal of the carbon dioxide from the circuit. Everything is native lung is only functioning. That is called a trial off in VV ECMO that we have already discussed. So what are the main differences between the VV and the VA ECMO trial offs? VV, the sweep gas flow is off. There is no reduction in the flow, no risk of circuit clotting. Directly we can do decannulation and pressure dressing. Whereas in VA, we have to hypernize the patient in the circuit, clamp off and clamp on for every 10 minutes. We have to flush cannulas also. And then it's a surgical decannulation. So coming to the last part, once we have weaned from the VV or the VA ECMO, decannulations. Mainly everything has to be, all these have to be done very sterilely. And then VV ECMO, aseptic removal of the cannulas and pressure dressing. And if we just remove the cannulas and we have to apply pressure for almost like 20 to 30 minutes at the site. And a simple suture of the skin can be taken. Whereas in VA ECMOs, most of them groin will be opened and the cannulas will be there. So though repair of the artery and vein if required has to be done. And that's why cardiac surgeon requirement is also high, is required for the decannulation purpose. Along with that, antibiotic coverage and all other regular parameters have to be done. And important thing is, after decannulation, always we have to look for bleeding or hematoma, and we have to keep monitoring pulse at least for 24 to 48 hours. So coming to the last slide, the take-home message. So weaning is a gradual withdrawal of the ECLS. A trial off should be attempted after successful weaning. Always we have to see that ventilatory parameters must be readjusted prior to the trialing off. And surgical closure of the VA ECMOs and a good communication between the teams. That is the intensivist, cardiac surgeon, cardiac anesthetist, perfusion and nursing team should be there. It's completely a teamwork. Thank you.
Thank you, Dr. Karthik. That was fantastic session. Weaning, I think, like he made it like an art.
Thank you, sir, for the enlightening and informative talk. I now request the chairpersons to felicitate and present the memento to Dr. Karthik.
As there is a small couple of questions.
Yeah, any questions? We'll take up the questions after.
Sridhar sir.
Yes.
Excellent topic. Of course, very difficult, but you made it very simple.
Thanks.
From my perspective, so what is your experience, CRRT plus ECMO?
Yes. uh, it can be integrated in the circuit, sir. And always whenever we are in doubt, that means if the blood urea nitrogen and the creatinine are increasing and we are expecting an end organ damage with a decreased urine output, early CRT is always much better, sir. Already Sunil sir has nicely written the topic where we have to include the CRRT things inside the ECMO. Always an integrated ECMO with a CRRT is useful in these kind of patients.
So what connections you commonly use? That means the arterial and venous of that CRRT circuit.
Yes, sir, only those connections will be used, but always it should not be across the oxygenator, sir. Either it has to be pre or post. Post is much better, but it should not bypass the oxygenator, sir. That is the only concept that we have to follow. That's all.
Do you prefer any separate lines for CRRT?
No, sir. Whenever the ECMO lines are there, and if the patient is expected to be doing good, like we can integrate within the CRRT. CRRT can be included in the ECMO, sir. Extra line and maintenance, and they will all become infection prone, sir. And also further also we may require lines even for other infusion of the inotropes, though it's always better to integrate in the ECMO.
Do you have any experience with the SLED-F rather than the CRRT?
I'm not sure, sir.
That means sustained low efficiency hemodiafiltration, where we
generally our
dialyze
SLED
for 10 to 12 hours.
SLED mostly will be doing it on the dialysis lines only, so not specifically not integrated in the.
Why I am asking this question is some of the hospitals may be not having CRRT machine available. Say suppose CRRT machine is engaged somewhere, then you may have to do suddenly do extracorporeal renal therapy for this patient who is on ECMO. So in those scenarios, you can definitely use 5008 for seniors, where you can use hemodiafiltration for a brief period of 8 to 10 hours. Till that time CRRT is available.
Generally what I have seen is
it may not be possible within the circuit. There is, because the flows are much higher. So not that it is not doable, but you will have to keep very low blood flows. Many patients, when they are weaning off or when they are much stable state, yes, we have done, but our preference has been to do with a separate HD catheter. More so because, as he said, the lines are anyway free. Now, if you are doing a CRRT, the problem is there is one line which gets blocked all the time. So it's preferable to do it in the ECMO circuit so that you have other access available for other lines. But if it is SLED, we do have window of time and there's a relative free time for where other things can be done. Just coming to the question, in the circuit we have not had much experience because of the fact that the flows are a little higher in SLED. And the SLED machines are more resistant for alarm modification as compared to the CRRT where you can actually mute the machine. Yes, yeah. But so also when you compromise on the flow, you would expect the efficiency of clearance also comes down. So in that scenario, it's probably better to do a separate line if you have. But so there's no hard and fast rule, but there is data that SLED-F can be done on CRRT as well. On ECMO.
Thank you.
I now request the chairpersons to felicitate and present the memento to Dr. Karthik. I request Dr. Lokesh sir, pulmonologist, Manipal Hospital, and Dr. Anil sir, cardiac anesthesiologist, to present mementos to the chairpersons.
Thank you, sir. And to chair the next session, I request Dr. Navya, cardiologist, Manipal Hospitals, Dr. Sagar, senior anesthesiologist, Manipal Hospitals, Vijayawada, and Dr. Basha, sir, chief intensivist, Pinamneni Siddhartha, Gannavaram. Moving on, it gives me a great pleasure to introduce our next speaker, Dr. Vinay K., a dynamic and a committed intensivist from the Department of Critical Care Medicine at Manipal Hospitals, Bangalore. Dr. Vinay holds multiple qualifications including MD, DNB, DRNB in Critical Care Medicine and the prestigious EDIC. He is currently pursuing his European Diploma in Advanced Echocardiography, reflecting his ongoing commitment to excellence. A national level academic achiever, Dr. Vinay has received the ISCCM Kavita Kamineni Oration Award for his best paper and a best thesis commendation from National Board of Examinations. His clinical strengths lie in multi-organ support, transplant ICU care, including advanced extracorporeal therapies like VA ECMO, which he will be elaborating on today. Please join me in welcoming Dr. Vinay for his expert session on VA ECMO as a bridge to cardiac transplant. Thank you. This session will be moderated by Dr. Sunil Karan sir and Dr. Devananda sir. We will move on to this.
Good afternoon. So the topic is termed as crisis to cure. So both Sunil sir and Devanand sir will be moderating. In case any queries, he will be supporting us. So the topic is termed as crisis to cure. So these two were the gentlemen who sort of played a major role in getting the machines out of the cardiac OTs into the ICUs. He's Theodore Kolobov and Warren Zappol. So this is an interesting case of bridge of VA ECMO to a destination of transplant. So a brief introduction to that to set the agenda. We all know it gives us the circulatory and the respiratory support. The normal DO2, VO2, Sunil sir has already mentioned. The VA ECMO specifically provides both circulatory and respiratory support. The indications have evolved, which started off as just the post-cardiotomy shock, and ECPR has added, and the new upcoming reason why VA ECMO is more relevant. Coming to the numbers, as we can see, right from 1990 to up till 2024, this is the latest data. So the centers have increased from 83 back then to now around 600 centers, and the number of ECMO runs have also significantly increased. We can see this late peaking which has been off late. Coming to the outcomes of VA ECMO for the adult program, it is somewhere around 47%. We at our center have fared much better than the global registry, which the point which Devanand sir stressed upon. So this particular case was patient was initiated on VA ECMO due to cardiogenic shock. A brief definition: SVP less than 90. Evidence of end organ damage either in the form of oliguria or lactatemia, and hemodynamic criteria, that is low cardiac output, the cardiac index, unsupported cardiac index, and the supported cardiac index less than 1.8 and 2.1 respectively, with elevated filling pressure. This is the definition of cardiogenic shock. So we all know the goal is to provide coronary, cerebral and systemic perfusion with effective ventricular rest for recovery or the destination therapy of choice. So etiology has already been discussed, from left ventricular to right ventricular to refractory arrhythmias, pericardial diseases, the toxins, and also the mechanical valvular or mechanical issues. In all these indications, the VA ECMO can be used. This is from the ELSO document. The right half of the screen is where the indications of ECMO have been evolving, and the left half of the screen is where it is already evolved and well proven. So what are the supports or what are the circulatory devices available for our armamentarium? So left-sided, it's IABP, Impella, Tandem Heart. Right-sided, Impella RP, Tandem Heart and Protocdio. And biventricular is what we are speaking today. That is, the speciality of VA ECMO is it can provide both right and the left ventricular supports. So this is the algorithm which we follow. I mean, just from a plain cardiogenic shock to what's called as a refractory cardiogenic shock, where there are two other variables, that is the cardiac power output and the PAPI, based on which we decide the which circulatory support or which to offer to the patient. So this is two hemodynamic variables. So this is what the VA ECMO serves as. Of all the indications of VA ECMO, it acts as a bridge to one of the destination therapy. Destination can either be a transplant, recovery, or a durable or a long-term LVAD support, or even it can help us to buy some time to decide on which destination to offer to the patient. So quickly jumping into the case, which we encountered near probably 18-20 months back. So she was 28-year-old, trimmy, 5.5 months postpartum, presented with a history of chest pain and breathlessness to an outside hospital, where she had recurrent episodes of VT, and the patient was in shock and breathlessness and was referred to our hospital. Outside hospital, already the LV was down. Patient also had a refractory VT storm-like clinical condition, and which was pharmacologically and electrically addressed. She had worsening shock and hypotension, and patient was intubated and was referred to our center for further management. On arrival to Manipal Hospital, Bangalore, patient was intubated, was on controlled ventilation, requiring high FiO2. The vasopressor requirements were quite stiff. The ABG showed acidosis, high lactates. The GCS was full, and she had all sorts of lines. Capillary refill time was high, raised JVP, speedle edema, all signs of classical cardiogenic shock and heart failure. So this is how she came in with. The LV was very poor, and that's the opening X-ray. We can see the pads which are already, when she came from the emergency, she had ongoing VT episodes. The ECG was nothing majorly suggestive of any significant vascular insult. Drops were elevated, NT-proBNPs on the same lines. The POCUS which was done showed B profile, and IVC was marginally dilated, non-collapsible. She was breathing very heavily. And echo showed global hypokinesia, EF of 18%. The VTI was low. There was also evidence of RV failure, which had already set in. And she had a tricuspid regurgitant jet of 3.3 meters per second. So the labs have been mentioned here. Hemoglobin of 9.5, platelets 95,000, OTPTs were very high, INR was deranged, and tropical fever, autoimmune, sarcoid, endocrine workup were sent because of the timeline that patient presented 5.5 months after the delivery, which were all negative. So with this history, the issues were shock, low cardiac output, cardiogenic nature, acidosis, lactatemia. There was biventricular dysfunction with electrical instability. There was oliguria and AKI. There was ischemic hepatitis and coagulopathy. So with this brief history, the differential diagnosis which we considered was first being peripartum cardiomyopathy, because patient per se didn't have any history of fever, any such history to implicate that it was an infective origin. So even though the timeline of 5 months was crossed, but still we consider it as a primary diagnosis, a primary differential. The other things which were thought were viral myocarditis. Even now we have a debate regarding which of the two was the patient suffering from. Other things like Takotsubo, ischemic cardiomyopathies or pregnancy-associated issues are all very unlikely because the timeline of presentation was not matching. So what are the diagnostic modalities? ECG, as we all know, it didn't show anything abnormal, majorly abnormal. Biomarkers were very much elevated. For PPCM to prove, there have been some, some tests which have been recommended. Just did a normal prolactin, which was
high as expected. Cardiac imaging could not be done because patient is already on stiff vasopressors to sort of pinpoint on the diagnosis. And endomyocardial biopsy, at this point, it was not contemplated, but it was running in our background, running in our minds. So how did we manage? Inotropes, vasopressors, goal-directed medical management strategies, organ supports, including RRT, the other routine bundled care in the ICU. So bromocriptine and anticoagulations was also started despite her being thrombocytopenic because of the high likelihood of peripartum cardiomyopathy, and other things like mechanical circulatory support were kept in the background because as of now we were able to still achieve some amount of systemic perfusion for her with inotropes. So coming to bromocriptine, why did we use bromocriptine? There is a good evidence to suggest that in peripartum cardiomyopathy, bromocriptine can improve the outcomes. There is something called as a board regimen: bromocriptine, oral heart failure drugs, anticoagulation, relaxants, and diuretics. All these all the 5 things were employed. Patients fitted into a severe PPCM category, where bromocriptine is uptitrated up to a maximum dose of 20 mg per day. So these are the evidences which support in favor of bromocriptine, where early usage of bromocriptine had an impact on the outcomes. This is again the BRO-HF study. This is again another study from Germany which showed better evidence and better long-term outcomes. They compared even a short duration of 1 week versus an 8-week duration of bromocriptine. And also bromocriptine, interestingly, has an impact on RV function, not just the LV function, it also improves the RV function. So there are certain heart failure medications which are contraindicated in pregnancy and lactation. So the left half of the screen is where the pregnancy it is, the green ones being things which can be employed. We need to remember that warfarin needs to be avoided in pregnancy, whereas in lactation, warfarin can be administered, and specific things being the AC inhibitors and the aldactone, which is avoided in case of active pregnancy, but whereas in lactation it can be used. So coming to the continuation of the case, there was worsening AKI over a period of next 24 hours, worsening shock, acidosis which was not settling down despite continuous RRT, and lactatemia continued to worsen. So there was a worsening SCAI stage. So we classify any patient coming in with cardiogenic shock as SCAI stages. There was worsening cardiogenic shock despite optimum medical therapy and organ supportive measures. So serial focus monitoring done, which showed further worsening of LV and the RV function. So this is what the SCAI stages means. So probably the patient had come in with a classical C stage and had dropped down to D stage at the end of 24 hours of ICU stay. So that was an indication to contemplate and initiate mechanical circulatory support. So when do we initiate ECMO? What does the ELSO guidelines say? VA ECMO should be considered for cardiogenic shock within 6 hours of its occurrence, which is refractory to conventional pharmacological and fluid therapy, and in patients with a reversible cardiocirculatory collapse and those eligible for a cardiocirculatory assistance, for example, they quote as VAD or a destination of transplant. So it has to be contemplated within 6 hours of onset of refractory shock. What is refractory shock? We have already discussed. And what are the contraindications? There is no, except for certain irreversible damages, more contraindications are largely relative. And there are other classifications by which we take a decision on the VA ECMO. There's something called as an INTERMAX, Interagency Registry for Mechanical Circulatory Assist Devices. So INTERMAX 1, this patient was fitting in INTERMAX 1, which was a crash and burn. So that's a critical cardiogenic shock, which is a life-threatening hypotension despite inotropic supports, and she is a right candidate to initiate VA ECMO. So patient was initiated on peripheral VA ECMO on day 3 of admission. Bifemoral configuration was performed. Hemodynamics and organ functions improved post VA ECMO. A distal perfusion cannula was inserted. A routine ICU care and other organ supports. Patient continued to have AKI, Whereas, so choosing the right strategy, which we need to sort of decide before we go in with the VA ECMO. So the peripheral VA ECMO, always the drainage is from the femoral, the most preferred side at least, and the return is from the opposite limb femoral artery. Whereas this is a bit different in case of ECPR, where the drainage and the return is in the same limb because of the time constraint or the time-bound decisions which we need to cannulate on. And this has been one more beautiful algorithm which they have made things very simple rather than following a complex criteria to identify refractory cardiogenic shock. This is a retrospective analysis from the ECMO CS trial. So how do we decide on any patient requires a VA ECMO? So the last part of the slide, the cardiac index less than 2.2, SVO2 less than 60, or the PCO2 gap more than 6 is when we need to contemplate and we need to administer extracorporeal supports. There have been various predictive scores like SAVE score, Encourage, Remember, which have been mentioned. So how do we monitor patients? We have initiated her on VA ECMO. How do we monitor them? So there are continuous monitoring, there is intermittent monitoring. Continuous monitoring comprising of ABGs, blood gases, target SVO2 of more than 66 is very important. 66 of more than 66 of SVO2 has translated into DO2 VO2 ratios of more than 3, and the distal limb perfusions, pulse pressure, pulsatility, and lung protective ventilation needs to be continued. Intermittent monitoring, like how our let's say given patient lactates, hemoglobin, markers of hemolysis, and neurological examination, and use of Swan GANs, especially to decide on venting when to do, or when there is elevated filling pressures or the increased afterload. Consideration of awakening and extubation is recommended more so in VA ECMO when compared to VV ECMO as soon as the hemodynamic stability is attained. And echocardiography, we all do focus routinely daily on multiple. So this has been a beautiful checklist for performing what are the things which we need to look in a patient with our bedside monitoring, right from cannulation, monitoring to weaning. Echo plays, or let's say focus plays a very important role. So continuing with our case, peripheral VA ECMO, bromocriptine therapy, anticoagulation, and other heart failure medications were continued. LV remained poor till day 8 and continued to remain on vasopressors and anodropes. Multidisciplinary care was continued. An MDT meet was done with the family despite being on optimal medical therapy along with extracorporeal support. The LV was not recovering because of the timeline of recovery was already 7-8 days old. So hence it was decided to proceed with the coronary angiogram and to perform an endocardial biopsy, because at this moment still the diagnosis was I think it needs to be zoomed out. Yeah, thank you. So a decision to perform a coronary angiogram with endocardial biopsy concurrently was taken. CAG was done and endocardial biopsy was also obtained and sent. In the meantime, because of the likelihood of high non-PPCM etiology, at the end of 7-8 days, a patient was also immunomodulated with steroids also. So this is the image at the end of 9 days post CAG, where we can see the LV is quite dilated. There was an appearance of spontaneous echo contrast also, and also the X-ray looks quite bad with congested lungs. So post CAG, the patient had deteriorating LV function, probably as a part of natural disease worsening itself. There was LV ballooning, there was smoky appearance and spontaneous echo contrast in the LV. The decision for LV venting plus or minus central conversion was made, and patient was referred to the operating theatre. So Devanand sir converted it into central VA ECMO because the patient had a quite rapid deterioration and the flows were not met with just peripheral VA ECMO. With LV venting was also done because, as we saw in the previous image, there was quite a significant LV dilation. Patient was transferred back to the medical ICU, So why do we need to perform, or why do we need to perform venting? So this is the pressure volume loop. As we start off at the baseline cardiac output, it is represented in the light blue. Our end diastolic volumes are quite less, and also the EA is the elastance, which is the slope is quite normal. As you increase the flows on ECMOs from 1.5 to 3 liters to 4.5 liters, the slope of the afterload, or let's say what is the effective arterial elastance, increases, and also the EDV increases. So when there is increased afterload with increased end diastolic volume, our purpose of heart protection or giving rest to the heart is not served. Hence the venting was performed. This is how it looks on an image. This is a transesophageal echo at 135 degrees on the left hand side, where we can see the ascending aorta, which is fully having what is spontaneous contrast, or let's say it's a smoky appearance of the ascending aorta. The aortic valve is functioning well, hence it has sort of held on, or else we could have seen that regurgitating. This is on a VA ECMO patient with a peripheral VA ECMO and a lot of afterload increase, and we can see here the aortic valve is hardly opening. These are all the indications where we should go ahead and perform a venting. Venting also needs to be done preemptively, like how Devanand sir was telling. ECMO needs to be initiated, VA ECMO needs to be initiated early. Venting also should be contemplated at the time of initiation, if not later. So how do you decide regarding the LV unloading? There are various factors: the arterial pulsatility, SpO2, CVP, the aortic valve opening, the ultrasonographic markers. If we have a Swan-Ganz elevated PCPW, there are various ways in which we address this increased afterload, like just reduction of the ECMO flows, to use of afterload reducing agents, to active venting strategies like sending the patient to the theater and performing an active venting. So these are less invasive maneuvers, being the reducing the flows, using of inotropes, use of vasodilators, increasing the PEEP, using diuretics, and the other ones being the more aggressive or the invasive ones, which is performed in the theater. So patients also, this patient came back with a venting with conversion to a central VA ECMO. Patient also had secondary sepsis with most commonly like in any other ICUs, which was Klebsiella pneumonia, which was addressed. We do encounter a lot of interactions. It is with the dialysis circuit, with the ECMO circuit, and the native body. So there are various challenges and antibiotics and the drug dosing consideration which have to be made. And blood products like routine bundled ICU care with hemoglobin targets of 9 were achieved. So that's what Sunil sir was telling. Anticoagulation. What is the best anticoagulation? This is the hot off the press. This is a 2025 ELSO release where they have compared direct thrombin inhibitors, that is bivaleuridine versus heparin. So most of the studies and the meta-analysis shows that it is clearly in favor of use of direct thrombin inhibitors. Bivaleuridine to argatroban head-to-head comparison is there. Surprisingly, bivaleuridine has a superiority over argatroban also. So the relevance to this topic is our patient also had persistent thrombocytopenia, and on workup she also turned out to be having heat positive antibodies. So we eventually had to switch over to bivaleuridine for further anticoagulation. So subsequently the biopsy results came, which was done a few days back, so which showed neutrophilic infiltration with some amount of activity still ongoing because of ongoing infection which is already there, and persistent inflammations. Rather than steroids, IVIG was administered with the hope that we can arrest the inflammation, or let's say assist the cardiac recovery. So which didn't have much of a help eventually. Patient continued to remain oliguric and AKI, and patient underwent regular RRT sessions. So configurations on RRT and ECMO, there are 3 types: inline, parallel, and integrated approach. Evidence favors integrated approach, but parallel is also equally efficacious. How do we convert an integrated, how do we take access from an integrated approaches? So the access can be pre-pump or post-pump. So one thing need to remember, as Sunil sir was telling, the return should always be pre-membrane. Even you can have an access post-membrane, but the return should always be a pre-membrane, because like how a normal HD dialysis catheter has a lung for a protection. For this circuit, if there is a air suck down, we have an oxygenator to prevent the air embolism. So these are various combinations, and this is what in one of our patients back at MHB, where you've been using with an integrated circuit, we can see the access and return are marked in the red arrow. So the access and return are both in post pump and pre-membrane. So this is again a zoomed out image of the same. So there are various challenges because there is a two-organ interaction. It's not just a single artificial organ. There are two artificial organs, either ECMO and RRT. So like recirculation, higher pressures, no use of citrate on ECMO, clotting issues, drug dosing consideration, hemolysis, and manpower and expertise plays a very important role in integration of RRT into the ECMO circuits. So coming to the continuation of the case, that patient underwent regular RRT, persistent AKI, poor LV function despite completion of second line of immunomodulation. So at this point, after almost, I'd say 20 days of ICU stay on extracorporeal support, a team decision was taken to offer destination of either a transplant or a VAD. So the durable VAD versus transplant was kept in mind. So workup for the transplant and VAD was started. CT abdomen was showed because the patient also had concurrent acute kidney injury almost 3 weeks into the illness. So the renal CT angio was done, which showed good renal architecture, meaning it gave us an hope that the renals could still recover. So the panel reactive antibody testing showed favorable profile, and super urgent listing was done because the family mainly didn't wish for a VAD considering the cost associated and other things. So we have some evidence to back up why the transplant is superior to VAD, and ECMO and organ supports was continued, awaiting the LVAD decision by the family or either a transplant or VAD. So these are some articles after post 2021 which has changed our thinking whether should we go for a durable LVAD versus a heart transplant upfront. So there has been some evidence supporting use of orthotopic heart transplant upfront rather than putting durable LVAD. So this is again we can see in the Kaplan-Meier curves. Heart transplant, the primary heart transplant might still do better. So this is again a retrospective analysis of patients who underwent a primary heart transplant versus prior cardiac surgery. So a patient with an open chest prior also influences the outcome, or a prior LVAD also influences the outcome. If you see this Kaplan-Meier curve, so the primary heart transplants fared better in the 10 years survival. So, and this is again one more meta-analysis where they looked into primary heart transplant versus a LVAD or a destination therapy as LVAD. Most of the evidence has maintained the equipoise. This ABCD is 1 year, 2 year, 5 year and 10 year survival. There is an equipoise. It depends on the center, either you and what the patient's affordability is like. Like durable LVADs cost somewhere in the range of 50 to 75 lakhs. So that also plays a major role. So the data is in the equipoise currently. So coming to the complication from the same meta-analysis, complication in terms of stroke, bleeding and infection are all much higher in LVAD. So this is one thing which we need to keep in mind. LVADs come with its own risk when compared to heart transplant. So there might be a tilt of evidence towards the heart transplant as the destination at this point. So to solve this puzzle, what does the ELSO say? ELSO clearly mentioned patients with a known severely reduced LV systolic function before VA ECMO placement could be considered for earlier LVAD implantation or heart transplant. So they also maintain it depends on the institution. Both have a equal weightage in terms of evidence. So patient underwent a cardiac transplant 45 days after the initiation of ECMO by the CTVS team. Procedure, even though there were some post-operative bleeding and such events, largely it was uneventful. Post-op care, immunosuppression was titrated. Patient was off ECMO. Renal recovery ensured after stabilization of the hemodynamics. So she was gradually weaned off lines, tubes, and off the ventilator too. Simultaneous rehabilitation, physiotherapy. Patient was discharged post-operative day 24. So this is on the left half of the slide. This is how she came in with. She was on a lot of supports, priority. This is one of the image of her undergoing physiotherapy at our center. And this was the explanted heart, the deceased heart. And this is an algorithm which was more or less exactly followed. A patient coming in with VA ECMO, when to perform, what are the decisions which we need to take in terms of decompression and choice of destination, whether it's VAD or transplant or it's palliation. So these are our teams which were involved. This is always a team game, as I was telling. And this is her photo 1 year post-transplantation with her kid's birthday. So the nearer any disease approaches to a crisis, the nearer it is to go cure. Danger and deliverance make their advances together, and it is only in the last push that one or the other takes the lead. So let's take the lead in bridging a lot of patients to get the decision of either a transplant or a VAD. Thank you. Anything Sunil sir and Devanand sir wishes to add?
There was certainly divine intervention at the right time, I'm sure sir will agree, because we listed her for a transplant and within a week or less than that we got a donor in one of the city hospitals, a 19-year-old heart. So at every step, I think the other worry we were also having was what about immunosuppression, because AKI was ongoing, so there was also a thought at one stage that she may have to go for a dual transplant, like dual organ, heart and kidney. But again, fortuitously, a week, 10 days prior to the decision for transplant, she started opening up her kidney. So I think, of course, team and divine intervention and being at the right time at the right place, I think that's what that is. Sir, anything to add?
Nothing much. I think rehab was one of the things which made the difference. She barely could walk, and from there to here it took nearly 2 months after the discharge for her to come back on her feet. That's point one. Point two is, sometimes it's very difficult when they come very sick. You do not know what kind of myocarditis we are all dealing with. So yes, ideally the question can be asked, why didn't you try, say, IVIG in the beginning itself? And these are the questions. In fact, most probably one of the small corrections we would have done is we landed in trouble, I think, isn't it? Trying to get the biopsy. We got the biopsy, but I think we created tamponade, so things went from bad to worse, conversion and other things. But all in all, went well for her. I think many people, including, I think, nephrologists, I think underscores definitely the importance of a good team and doing things at times. Sometimes, like AKI, for example, when she is not recovered, the decision still remains, should you do only the heart, even if they agree, or should you do kidney along with that. I think one of the patients we did, correct? DMSA or something like that, show the nephrogram, and we went ahead without doing kidneys, eventually recovered. I think combined expertise, is what can give the outcome.
She's right now with follow-up with one of our cardiologists in Kolar, in the neighboring district as well. So I think they also took the decision to move. In fact, the referral came as need for ECMO. So though she was at that point just on vasopressor. So I think CME is like this, of the right awareness of that a facility like that exists also does make a difference. Yeah, but I think overall it was sort of a team game, including the referral physician also, I think. So everybody had this thing, and of course God's grace.
Yes, sir. I do have a couple of questions just for discussion's sake. So in the starting, sir, you have mentioned that the patient was having refractory VT. So what was done for that, sir?
Patient which he came in, they had cardio. It was electrically addressed, and patient they had put her on midron infusions and such things. So both measures were ongoing. Yeah.
Because she's a grey area of 5.5 months postpartum, cannot really label her as peripartum cardiomyopathy. Could it have been a tachycardia-induced cardiomyopathy? Because she was having refractory VT, she might be having it for quite some time.
We did in fact work up for sarcoid for the same reason, because young females presenting with refractory VT, sarcoidosis was in fact it looked very unlikely. We did give her steroids upfront for the same reason, either be it any of the autoimmune diseases or sarcoid or any of the viral issues. So to give that, the first line of immunomodulation in terms of steroids were already administered.
And second one is the ECG showed LVB. You have mentioned the ECG. How much was the QRS duration, sir? Just for discussion's sake, I just mentioned. Because if it is still tachycardia-induced cardiomyopathy or a pre-existing cardiomyopathy which has worsened due to viral myocarditis which has come.
So just to answer that question, she was actually a sports person. So she was a district badminton player also. So unlike national level, unlike she had something major, is what we think, because she went through the whole pregnancy without a problem. Just on the timeline we thought could be peripartum, we are not sure, obviously there was nothing before that, and of course could be just a myocarditis tipping the balance.
If in case the patient was improving on ECMO, would a CRT-D would have been helpful at that time if the LBBB duration is more, apart from the endomyocardial biopsy?
Definitely.
Patient never, she continued to remain on requiring high flows. We couldn't sort of get down on the ECMO flows itself. The moment we came down,
VTA never came even to 10 at any point of time.
One more doubt, sir. LV venting was done. Was that? Because there was a lot of sec in the was the anticoagulation high?
Coagulation almost. In fact, at one point we were struggling with the balance of thrombocytopenia, giving up platelets versus this, and that's when the HIT antibodies came positive and we moved to bivalirudin.
Should it be hiked up, sir, in case before venting or during the time of venting? Because there was a lot of sec and it looked like rather than sec it was a grade 3 sec.
Yeah, I don't know whether there's any data to say hike up. I think we would look at twice the APTT value, and with bivalirudin, of course, there's no other way we would want, or of course with heparin also with an ACT tag. So largely the ACT targets were maintained, and also the APTT was between 40, 60, 80 in that range, and again AKI was there, so there were a lot of confounding things. So it was a bit of a struggle balancing everything. I think we've had platelets down to 30 at one point, 30,000 as well.
So also suggests that titration on extracorporeal supports is based on the blood flow. So they gave a range for each value of a blood flow from 1.5 to 2 liters. It's not based on either a sec or definitely she was at a higher rate. We are in the
criteria on weaning is no smoke or sec in the heart is one of the criteria.
True. Yeah. I think she had more than second. I think there's enough objectivity to say that she never got through it. In fact, there was no way we were even able to reduce the flows. So we had actually extubated her in the middle, and I think she got just before the LV venting. Actually, she was extubated, and because of the back pressure, some degree of pulmonary edema, she got re-intubated. So there was never a time when it looked like her heart was really good. We never could even get down on the floors. Yeah.
Thank you, sir. Thank you.
I'd like to felicitate you. I request the chair to present a memento and bouquet. I request Dr. Pallim Padeshwaram sir, Senior Cardiologist, Heart Care Center, to present mementos for the chair members. Thank you, sir. I would like to introduce our next speaker, Dr. V. Dinesh Kumar, Consultant Intensivist and Critical Care Medicine, Manipal Hospitals, Vijayawada. He holds an MD in Anesthesiology along with IDCCM and DRNB in Critical Care Medicine. His areas of interest include neurocritical care, nephrocritical care, transplant critical care, and extracorporeal therapies. And Dr. Srinivas Samavedam sir will be moderating this session. And the chairpersons, I would like to invite Dr. Lokesh, Chief Pulmonologist, Dr. Uday, Consultant Pulmonologist, Dr. Lakshmi Prasunna, Consultant Obstetric Gynecology, Manipal Hospitals, Dr. Ravi Kumar sir, Pediatrics, Manipal Hospitals, Vijayawada, and Dr. Sirisha, Microbiologist, Manipal Hospitals, Vijayawada. Thank you.
Good afternoon, one and all. So I'll be quick with my case discussion on VV ECMO of an elderly primee. So for the next 15 minutes, I'll be briefly describing this case. So for a better understanding, I would like to divide the set of events which were happened prior to the initiation of ECMO, after ECMO, and after decannulation of ECMO. So basically, she was an elderly female, known bronchial asthmatic, referred from elsewhere with a working diagnosis of severe CAP. And she had all this history for about a week. She presented with fever, cough with expectation, was diagnosed to have viral pneumonia, and in view of increasing respiratory distress and oxygen requirement, she was intubated and was referred to our center. So total duration of course was 7 days prior at the outside hospital, and prior to that she even had 3 days of total history. So it was already a 10-day history prior to us that she has presented. On presenting to us, we have involved the pulmonologist, so it was admitted under Dr. Lokesh, the pulmonology team. So for the working diagnosis, they have done quick BAL. The BAL analysis revealed a patient as having influenza B pneumonia. So it was a severe CAP with influenza B. So she was already started on oseltamivir at an outside hospital with a piperacillin tazobactam, and was continued. During the further analysis, what we have got from the micro department is, along with the BAL influenza B, the cultures grew zygomatous species. So initially we thought probably this could be secondary bacterial infection was affecting her. So with the discussion of the multidisciplinary team, so the decision to initiate the fungal treatment for the zygomacety species, the amphotericin B, was initiated. So prior to this, the total duration for the ventilation prior to the ECMO was 13 days. So during this course, during the second week of illness, she had decreasing in her PF ratios, her lung compliance was getting bad. So prior to the admission itself, the decision to plan of ECMO was there. So I would like to tell what exactly happened, why we were late in initiating this. So you could see the this X-ray. This was on day 1 of presentation. Classical picture of ARDS, bilateral diffuse heterogeneous opacities was there. And this was the BAL report that was influenza B, and the cultures that were grown were, zygomatous species with pauciseptate. So there was a discussion whether it is aspergillus or mucor. So during the second week, we had issues with the compliance of the lung with increasing P-flat and driving pressures. So these were the set of events. So day 1 to 5 said viral pneumonia with the fungal pneumonia was as a co-infection was started on amphotericin B and was continued. During the second week of admission, she had worsening lung compliance with PF ratios were falling down, and she has become refractory to this refractory hypoxemics. And the decision to initiate was there prior. We would like to tell why we were pretty late in initiating this. So the working diagnosis on the day of admission, on the day of initiation was severe CAP with ARDS with viral and fungal as a co-infection. And the Murray score was 3, her RESP was a score of 1, so which you usually tell for prognostication purpose. Total ventilated days prior to the initiation was 13 days, and this was the PF ratios prior to the initiation. So the PF ratios were 40. So for the discussion purpose, I would like to ask Dr. Lokesh, so how frequently you see influenza B patient having fungal infections as, as co-infections like?
So very interesting, basically this lady, like he mentioned, she came to us in the 29th week of pregnancy. I got a call from another center from Vijayawada saying that this is a situation. So first to take up this case is a little challenging, and then once we did bronchoscopy on admission day, we got influenza B, and our microbiologist told me that, Lokesh, see, this looks like either mucor or aspergillus. It can be one of them. Then I was a little surprised, but definitely the literature it is there. Post-influenza, the patient is requiring severe pneumonia, causing severe pneumonia, requiring hospital admission. That means that their immunity is, they're immunocompromised state, and also there is neutrophil dysfunction when they get influenza infection. And also in literature they said so there is endothelial damage and also alveolar epithelial damage, which prones them to get the secondary fungal infections. Secondary bacterial infection is well documented. At the same time, secondary fungal infection like aspergillus is more actually there in the literature, but zygomatis is also there. So that's when we thought that we don't know whether it is pre-infection or colonizer, but we didn't want to ignore that. So we started this patient on liposomal amphotericin B on the day 2. So, and also other risk factors for my patient is, she is an asthmatic, chronic asthmatic. She was on inhaled corticosteroids. Those who are chronic asthmatics, they tend to have aspergillus fumigatus colonization. We call it APPA. Those patients come with APPA. So that could be one reason. We thought second reason is, and also she's pregnancy state itself, they have a little bit of immunocompromised state. So these three factors, we thought yes, she might be having true infection, secondary fungal infection. So that's the reason we started with antifungal.
So, sir, anything else you want to add? So yeah, basically we had, this patient had a fungal pneumonia as a co-infection, was started on amphotericin B. As sir said, there were definitely particular risk factors to this patient to have fungus as co-infection. One is a long-standing asthma history for which she was on, long-term steroid inhalers. Second thing is influenza B pneumonia for which she has been having. And most common fungal infections per se, as I said, aspergillus will be the first, and second most was mucor. But anyways, amphotericin would be a broad coverage for both aspergillus and mucor, and the decision to go on with amphotericin B was taken. So sir, I would like to ask you, like, I do know we did have a lot of difficulty in counseling the attenders right from the beginning for, going early ECMO, because she was at 26 weeks, refractory hypoxemia. One of the best outcome would have been with the prone ventilation, but that was not an option over here. So sir, I just want to know, at 26 weeks, we do know, like, it's actually a relative contraindication. Do you think it would have been ideal for proning an patient at third trimester into 26 weeks? And because we didn't know exit strategy for this patient. Are we putting the ECMO for, for the healing purpose, or for the transplant, or somewhere between the decision? We were like pretty much not clear.
Patients have survived. It's not that everybody who came pregnant with 26 weeks with a viral pneumonia died. But with the availability of ECMO, we have a better option of minimizing the lung injury. But what you need to remember here is that you are also dealing with the fetal oxygenation.
Exactly.
So a PaO2 of 40, that is what your PaO2
yes, sir.
is simply unacceptable for a pregnant state PaO2. This is one of the situations where conservative oxygen strategies have to be given up. One of pregnancy, traumatic brain injury and AMI cardiac shock. You don't go with the philosophy of conservative oxygen strategy. You need to be more aggressive. The PaO2 has to be above 80 and the SATs have to be above 95, 92. So there I feel that, and having said that, prone ventilation is, pregnancy at 26 weeks is not an absolute contraindication for prone ventilation. In a resource limited setting, or if ECMO is not an option, it is done, it has been done and done successfully. So
indication, I think as rightly as he said, we used to do it before ECMO period. Even during ECMO, COVID and all, we have done a lot of proning where we get so many circuits, you know. So we have done at least 5 in our unit. We have done 5 during COVID itself.
Okay.
I mean, the only other call would be, do we try to terminate the pregnancy? Maybe a couple of weeks more, you would have looked towards termination and then going ahead with proning, because then there's some degree of fetal maturation. But I think in today's world, if you have a good NICU, 27-weeker is not a very difficult one to this thing. But,
anything else you would like to add?
So like we were actually, he was asking about ECMO, why initiation was late. So the thing is that once we got the ball culture showing Zygomatus fungi, I was not really sure whether she will come off a ventilator after 1 week. We were not expecting. So that's when, still then we advise them, maybe if at all we have to start 2 options are there. One is that ECMO, then if required lung transplant. So there is one personal story for the patient husband. Basically, he just lost his father undergoing liver transplant in day 13. He just told me that, sir, I didn't recover from my financial losses and also from my emotional thing. So again, for my wife to put her onto ECMO and lung transplant, I am not even ready to think about it. So that was a thought process going on in their mindset. And meanwhile, as a clinician, I was really unsure whether she will make it to day 7 or not, because we know how many cases of Zygomatus fungi we have seen in Mycora rhizopus. If you have that much of severe blown out ARDS with secondary fungal infection, usually they die on day 3 or day 4 itself. So most of the times, even though you put them on liposomal amphotericin B. But luckily, she never behaved like classical secondary fungal pneumonia. Throughout the 14 days, her she didn't require vasopressors and her would not produce good. There is no fever at all. She was the only one.
She was single organ involvement.
Single organ involvement. She was. We never changed the antibiotic itself. She was on. She was on meropenem for almost 14 days. So that's when we believed that yes, she will. She might require ECMO and she will require ECMO and she might get through it. Then we did a second round of counseling, saying that they didn't want to go anywhere. We told them honestly, there are 2 lives are there. So if you want to go to a better center where you can go to Hyderabad and also Bangalore, we can facilitate that. So because we are a center which we are initiating in ECMO in last 1 year, so we are not that much experienced as well handling 2 things. We are honest with them. They said, we'll think about it and you'll come back to us. Then they said, you can do it, but we don't want to go anywhere. You do it here only. So that was a thing. Then it was challenging for us also as clinicians. That's when we took support from our Manipal Hospital Bangalore team. Then they agreed finally. So we initiated an ECMO, but we know that it is very late, pretty late, almost day 21 of her ARDS. So you can see that how much her plateau and driving pressure. When we are doing ECMO, we were doing veins. You can imagine how much volume we are putting in to do an ECMO for this patient. Probably we are giving more than 1000 ml. That much while we are doing ECMO. That was the scenario. So not an ideal thing, but that was a practical thing.
So moving on to the case, so the initiation was done. So it was almost on 14th day, 13th day of our presentation to the hospital. The cannulation was done percutaneously with the critical care team and the anesthesia team. So those were the drainage and the written cannulas, and those were the initiating flows, and this has been the pre and post membrane oxygenator ABGs that was done, and that was the X-ray which was done for the confirmation for the cannula distance position, and the change of the color of the drainage and written cannula has been noted. So I would like to say the main significant events that has happened during the maintenance phase on ECMO, where on the day of initiation of ECMO, there was a spontaneous expulsion of fetus. And she did have a lot of hemodynamic instability with reduced urine output, was requiring blood requirement. So all this lasted for transiently. Luckily, with the help of our obstetric team and the neonatal team, the resuscitation has continued. And on day 6 of initiation of ECMO, we had the secretions was becoming very thick, purulent. Had to take the pulmonology's help. They have done repeated BAL. The bronchial toileting was done, and those were sent for analysis. And this time, apart from the influenza B and apart from this fungal co-infection, we did have an isolate of multi-drug resistant polymicrobial infections, which I'll be telling the coming slides. And on day 9, she developed right side pneumothorax with a possible alveolar pleural fistula. So this was our BAL analysis. The organisms that were isolated were Acinetobacter, Klebsiella, Pseudomonas, apart from influenza B, and the resistant genes have been mentioned. The conventional cultures of these same has been isolated, where the organisms were the Klebsiella and the Pseudomonas. Klebsiella, if you see, the main mode of resistance were mainly this metallo-beta-lactamases, and Pseudomonas was almost sensitive to the BL-BLIs and even to the carbapenems. So, and the synergy testing was done, and it was showed Cassavia estronium resistant. So prior to this, the patient was started on polymyxin with sulbactam combination with TG, and this was the right-sided pneumothorax that was developed on day 8 of initiation of ECMO. So initially we placed one ICD, but the leak was pretty high. Had to be placed another second ICD to compensate for the leak. There was a lot of bubbling happening. We continued with ultra-low protective ventilation with the PEEP titration. With a minimal PEEP, and the bronchoscopy was done for localizing, for the leak, but it couldn't help us much. But over the time, you can see it took nearly about 9 days for the complete lung expansion to happen. The strategies were all 2 ICDs were placed, and then the ultra-low protective ventilation, and once the respiratory mechanics have got better, we left the patient on spontaneously, minimized the sedations and all, and we left the patient on spontaneous breathing. So here I would like to ask our microbiologist Sirisha ma'am, how do we actually approach these patients with polymicrobial cultures, and how do we prioritize and rationalize antimicrobial selection? So she was on meropenem prior to this event. After that, we had started on polymyxin B with sulbactam and TG-cycline, and we continued amphotericin B. So yeah.
This is actually, Dinesh, very tough question to answer, because critically ill patients who are already hospitalized, they are invariably get colonized with multi-drug resistant organisms. The problem in this case was she was having so many organisms and so many genes. We were really not sure whether they are really colonizers or we should go ahead and treat them. But seeing the whole scenario, we don't want to put her in a septic thing, bacterial septicemia or something, because lung was really bad. So there was no other option rather than choosing a colistin. That was the only option, because even with azithromycin combination, synergy was also not showing, and we were not sure which gene was positive in which organism, because that is very, very important. If this is OXA48 with aceneto, then you're not supposed to give that one. If it is Pseudomonas, then there's no point in giving these two. So it is a very a crucial point. So we thought, okay, we'll go ahead with something which will cover everything. It may be a colonizer or a pathogen, but being in that particular critical condition of seeing the patient there, we didn't have any other option rather than going. And even covering with amphotericin B was because we were not sure whether it is going to grow or not. And I think, as I discussed with Dr. Lokesh, the septae were not really very clear, whether they were aseptate or septate. And some points we had even doubt, is there any mixed infection with aspergillus? So it is a better option to go and cover with amphotericin B. So that was a discussion, and we went. And one more important thing is, like, sometimes doing these kind of biofire tests and all will give you a clue whether to choose a proper antibiotic or not. If there were no carbapenem resistant genes there existing, then you are having a good choice of meropenem, imipenem and all left. If you find those genes, then I think the last option would be your cholesterol.
We have in-house Dr. Niren, ID physician, sir. I just want to know, we have continued, amphotericin B for about 2 weeks, and then later we have decided, to substitute amphotericin B with posaconazole. So we did change over to posaconazole after 14 days of amphotericin B treatment. So how do you think we should do the stewardship of antifungal management when we're coming down from a broad spectrum coverage of fungus to going more with one single antifungal? And you're correct. Sir, I have a doubt. How about using fungal biomarkers over here? So like how we use CRP Procal to know, apart from clinical response, to see even how is the trend of a Procal and CRP for de-escalation. Could it have been used fungal biomarkers like galactoman in this patient? Definitely, she was on piperacillin tazobactam prior, so it was very difficult, call to change over from amphotericin B to posaconazole. But during this transition period, she was looking fine. She didn't have any temperature spikes in mounting, counts were fine, hemodynamically stable, no extra organ involvement, only the lung was the sole organ that was there. So how do you think the fungal biomarkers will help us in stewardship?
Stewardship-wise, we are yet to reach a position where fungal biomarkers will guide you in de-escalation of your antifungals. This particular patient, even if you had done a biomarker, if it was positive, I would not take it as my index or my guide for therapy because of the false positivity. If clinically you are thinking that there is no other infection and one of your markers or your BAL is positive, you should treat it. Okay. But it may help you in situations where you do not know whether you are dealing with a bacterial or a fungal infection. If a biomarker, especially in the bronchoalveolar lavage fluid, is positive, you may be confident of starting the patient on an antifungal drug. But like procalcitonin, you cannot use the optical density of a biomarker to de-escalate the antifungals as of now.
Fine. Thank you. So moving on to the case. So this was on day 17 where we have decannulated the patient and the ABG was in the acceptable range that we have seen in the morning sessions regarding the weaning from VV ECMO. The pH, PCO2 and the PaO2 are in the acceptable range, and the decision to decannulation was taken. And this was exactly 3 days after decannulation. You could see the patient was holding her child. We thought everything was fine, and everything was going in our favor. And On the fourth day of decannulation, we could see purulent discharge being drained from the ICDs, and she landed into septic shock with increasing counts. This increasing counts trend we have observed post decannulation. What we thought, okay, post decannulation, this fungal, the biofilms being getting released, all this kind of endotoxemia can be seen. So we had discussion with Dr. Lokesh and the primary team and the critical care team, Srinivas sir and all were there. So we decided, okay, what could be, what else can be done. So we thought, okay, why can't we add caspofungin? So along with the posaconazole, the patient was started on caspofungin as per the literature and did. How often do we see, like, sir, this kind of deteriorations, sepsis, patient going into this kind of combination where we we continued with the posaconazole and added caspofungin to our regimen, and when this happened, had to think what else can be done at this scenario.
It's an individual decision, but I think this is a true reflection of the learning curve of taking care of ECMO subjects and taking care of ECMO patients. They need special attention, right? Because too many people walking around, too many people handling the circuits, this will happen. But again, we didn't find the Pseudomonas in the earlier molecular diagnostics, so this is obviously a hospital-acquired infection. So, as you get more experience, you will notice that these infections will come.
Would you like to add anything?
Actually, like Dinesh mentioned, so despite having so many challenges, that we started late, day 21 of ARDS, and like we expected, her lungs were stiff and she developed pneumothorax. We placed one ICD, lung didn't expand, two ICD, lung didn't expand. Then negative section for 4 days, lung did not expand. Then we wanted to do something heroic, maybe blocking with some spigots and all, looking at the bubbling and all. So I did bronchoscopy, we checked all the segments in the right side, but we could not localize even with methylene blue. So that means that probably this is not BPF, this is only APF, because the stiff lungs, what she had, so it is causing so much of trouble. So we just have to, we thought we'll just wait. Like you said that, like, time heals. So surprisingly, day 7 of ECMO, she developed this persistent pneumothorax. Then maybe around day 14 of ECMO, the lung started to expand just with conventional therapy. So like we said, the time heals. So she started to improve. That's when we thought that day 17 we weaned off. But after challenges started off weaning off is day 3, day 4, we developed again this septic shock. Reason what I thought, you can see that X-ray, the right mid-zone, you can see that necrotizing infection, and you can see in the ICD, you can see purulent secretions. So despite suspecting this, and also we just weaned off cannulas after 17 days, so we just wanted to add candidemia is also we see in our hospital ICU, so we just added capsofungin for that. But in blood culture, we didn't have candida, only the secondary bacterial infection was the main thing for her deterioration. So that is the thing, so that's when she is already on polymyxin P and tigecycline for 21 days, she improved. So what to start again? So we didn't have cultures in first 3 days. So we reintroduced meropenem 2 gram TAD, sulbactam 3 grams, minocycline to cover Acinetobacter and whatnot. We know that she is deteriorating rapidly, stakes are very high. So we tried everything. So you can show that, I think next slide is what all we tried. But ultimately, so we lost her. So, but it was very painful for all the team who are involved. But this is the ground reality of ECMO patient. The reason for showing this case is that we know that in successful best centers we have only 50% success rate, 40 to 50%. So you'll always have this 50% failures despite whatever you do. So, and also learning for us to maybe what else we can do better. Maybe we can convince them earlier to go on to ECMO so that we'll not have this kind of BPFs and also secondary infections to handle better.
So this was our antimicrobial utilization timeline strategy over the time. And towards the end, yes, we did have a lot of difficulty in strategizing what exactly is affecting her. Thought probably the decompensation could be secondary to fungal sepsis, and we went ahead with starting on caspofungin. But it didn't help us, and finally the patient succumbed to sepsis with septic shock on day 7 post decannulation. And as we have already seen this, one of the most common causes for deterioration after weaning and decannulation of ECMO, the sepsis was the most common. And is there anything else that could be done, would have been better, or what are the takeaway points from this case, sir? Sir, yes, sir.
Amphotericin on ECMO, the recommendation is to actually give higher doses. So
is it, that's what, sir, is it 10 mg?
I'm not saying patient died because of that, but 5 to 8 mg per kg is what is recommended. Number one. Number two, also it is likely to shorten the membrane's life, because the lipid component. So generally we try not to use propofol, liposomal,
exactly.
Because that's the only problem it sort of. And when you change the circuit, it's very important that you redo a loading dose, because what happens is first 48 hours it coats the adsorbs on the surface, then it probably behaves like any other patient. But when you change, there's a fresh site for it to reload on the, so the recommendation generally is to use TDMs for it, but TDM of course not available in our country, so we would generally go with the empirical sort of, guesswork kind of serum levels. But you do higher doses for amphotericin when you have this thing.
So yeah, I think we are very thankful to our NICU team. So can you just play that video of the... So this was happened on day 1 of ECMO cannulation. There was a spontaneous expulsion of fetus, and here you could see there was a lot of blood loss that has happened, and there was a lot of hemodynamic instability. It was definitely affected her perfusion. There was decreased urine output, had required a lot of blood transfusions, and we had our pediatrician over here, Dr. Ravi Kumar sir. Here you could see hardly the child was breathing. Maybe what I thought was there were 2 ECMOs happening at a time in her. One was what we have initiated, and one was the God-gifted, that is the placenta. I think that helped her, the child, till the last moment is what we were thinking. And definitely, yeah, the resuscitation of the child did help with the help of our NICU team. And this was the grandparents of a patient, and the time she got delivered, the child's weight was somewhere around 960 grams, and she was with us for about 40 days, sir? 40? Yeah. 59 days. At the time of discharge, I think the child's weight was somewhere around 1.7?
1.3. Now she is 2.3 kgs.
Yeah.
So 2.5 months old.
Maybe here, definitely, yeah, we couldn't give back the parents and the child, her mother. Don't know why. See, always we know the priority should be the mother. In this situation, it has been the other way around. The child did survive, and yeah, the mother was not there. But yeah, all our efforts we kept. But it was pretty unfortunate that we lost the patient.
So only happy thing is that her grandmother said after losing her daughter, I can see my daughter in my granddaughter's face. That was the only happy moment we actually felt, because see them, they are almost 60 as grandparents, right? Because they were in also apprehension that if you lose the mother, what can you do with a baby? That was a thought process before actually starting ECMO. But after all this happened, they could say that I can see my daughter in my granddaughter's face. So that was the only thing, happy moment for us after battling a lot of emotions for about, I think, 4 to 5 weeks. And I thank all the team members, whoever is involved in this. So thank you all.
So thank you all. I would like to end my presentation with this Japanese term Shoshin, a concept in Zen Buddhism that means always have a beginner's mind. It refers to having an attitude of openness, eagerness, and lack of preconceptions when studying a subject, even when studying at an advanced level, just as a beginner would. Thank you. Thank you one and all for coming to this semi. I would like to thank the Manipal Hospital management. Now, I'm pretty happy to see my teacher, my current ECMO teachers over here, my friend, my senior, all over here in this hall, and I could see a very good numbers coming to this CME. I'm pretty happy, very happy. And following this, we have a very good workshop sessions followed. Please do follow for the workshop sessions. Thank you one and all.
The chair will present a memento for Dr. Dinesh. And I request Dr. Dilip Kumar sir, Consultant Cardiac Surgeon, Manipal Hospitals, to present mementos for the chairpersons. We'll be starting the workshop in a while. I request all the delegates to participate in the sessions. Thank you.
సినిమా కెమెరా కదా, దీనికి రెడ్ ఇస్తాడు పెద్దగా, ఈ స్క్రీన్లో చూడక్కర్లేదు.